again.
I don't miss you every day. Don't need you anyway. You can take your love away. But it's easier said than done. Can shout out when you won. Can have my love run. Say I don't miss you every day. Don't need you anyway. You can take your love away.
Dear colleagues, друзья, коллеги, присаживаемся. Мы очень сжаты во времени, съели 30 минут в секциях хирургии и нейрохирургии. Но мы хотели собрать всех в большом зале для официального открытия. Пленарное заседание было вчера, но сегодня отдельно по хирургии. Take a seat, colleagues. Thank you.
Пациент қауіпсіздігі ымырасыз таңдау. Уақыт диірмені тоқтаусыз, өмір сәт сайын өзгеруде. Заманмен қатар дәрілік, сәулелік терапияның нәтижесі, алдын алу іс-шаралары мен озық технологияларды қолдану арқылы ота жасау зор жетістіктерге жетуде. Медициналық қызмет көрсету ұйымдардың көптеп ашылуы көрсетілетін қызметтер сапасын жақсартуда өз әсерін тигізуде. Адамдар арасында салауатты өмір салтын ұстанып, денсаулығына мән беретін жандар көбеюде. Осы құбылыстар негізінде пациент қауіпсіздігі күн сайын тәртібіндегі маңызды мәселеге айналды. Сондықтан 2019 жылы Дүниежүзілік денсаулық сақтау ассамблеясының 72-ші сессиясында халықаралық медициналық қауымдастық бір ауыздан бүкіл әлемдік пациент қауіпсіздігі күнін белгілеуді маңызды деп тауып, арнайы шешім қабылданды. Оның басты мұраты ең маңыздысы зияныңды тигізбеу деп аталады. Кеше мүмкін еместеу көрінген істер бүгін қалыпты жағдайға айналды. Бұл заманауи медицина жетістіктері. Жоғары технологиялар дәрігерлерге нәтижелі әрі сапалы қызмет көрсетуге көмектесуде. Дегенмен жетістіктермен қатар пациенттер арасында түрлі асқынулар, соның ішінде инфекциялық асқынулар қаупі де арта түсуде. ТДО-ның мәліметі бойынша әрбір 100-ші ем алушы медициналық көмек алу барысында кемі бір инфекция жұқтырады екен. Орта есеппен әр 10-шы пациент ауруханада жұққан дерт салдарынан дүние салады. 19 ғасырдың соңы медицинада иондық сәулелендіруді ашылумен есте қалды. Бұл диагностика саласының жаңа деңгейге көтерілуіне себеп болды. Сәулелік диагностикадағы жаңалық, сондай-ақ радиация әсерінен қорғанудың жаңа тәсілдерін қарастыруды қатар талап етті. Радиациялық қауіпсіздіктің басты мақсаты апаттық жағдайлар мен қалыпты қолдану кезіндегі адам үшін сәулелену мөлшерін бақылау және азайту болып табылады. Хирургиялық қауіпсіздік заманауи медицинаның іргетасы болып саналады. Барлық хирургиялық шаралар жоғарғы нәтижемен қатар әрқашан адам өмірі мен денсаулығына тигізуі мүмкін қосымша кері әсерлермен қауіпті. Хирургиялық қауіпсіздік көптеген маңызды іс-шараларды қамтыған кешенді көзқарасты білдіреді. Бұл әр емделушіге сай емдеу тәсілдері, анестезиялық дұрыс таңдау, ота жасаудың қажеттілігі мен одан кейінгі арнайы күтімді қамтиды. Тиімді ем ретінде дәрі-дәрмектерді қолдана отырып, біз олардың кері әсері болмайтынына кепілдік бере аламыз ба? Олардың қауіпсіз екені қаншалықты шындыққа жанасады? Міне осыдан келіп дәрі-дәрмекті қолдану және оның кері әсері туралы терең зерттеулер қажеттілігі туындайды. Бұл фармабақылау мен дәрігерлердің жеке тәжірибесі арқылы жүзеге асырылатын жауапты қадам. ТДО-ның мәліметіне сай, әлемде ем алушыға дұрыс тағайындалмаған немесе қолданылмаған дәрі-дәрмектің зардабын растайтын 42 миллион қателік тіркелген. Денсаулық сақтау саласын дамыту мемлекеттік саясатта басымдыққа ие. Өйткені медициналық қызмет көрсетуді дамыту елдің әлеуметтік экономикалық әл-ауқатын көтерудің негізгі алғышарты болып табылады. Пациент қауіпсіздігі бұл медициналық қызмет көрсетудің өзегі. Ол пациентке зиян тигізбей, сапалы көмек көрсетуді білдіреді. Қазақстан Республикасының президенті істерін басқару орталығының ауруханасы алға қойған міндеттерді атқаруда еліміздің медицина орталығы болып табылады. Мұнда еліміз бойынша кәсіби шеберліктерін үнемі шыңдап отыратын ең мықты мамандар қызмет етеді. Аурухана заманауи диагностика және әлемдік брендтердің емдік құрал жабдықтарымен қамтамасыз етілген. Хирургия саласында роботтандырылған жоғарғы технологиялық оталар жүзеге асырылады. Ем алушы өзіне қажетті барлық медициналық қызмет түрлерін бір жерден ала алады. Дәрігерлер мен медициналық персоналдық жоғары кәсіби деңгейі. Медициналық техниканың ең соңғы үлгілерімен жабдықталған. Инновациялық медициналық технологияларды ұтымды пайдалану, емдеудің жан-жақты әдіс тәсілдерін қолдану, халықаралық стандарттарға сай қызмет көрсету және пациент қауіпсіздігін қамтамасыз ету. Барлық қызмет түрлерін жеке тұлғалық бейімдеу. Пациент қауіпсіздігі бұл біздің бүгініміз бен болашағымыз және әлемдік денсаулық сақтау саласын дамытудың маңызды саласы. Ендеше оны айнымас қағидаға айналдыру жолдарын бірге талқылайық. Конгресске қош келдіңіздер.
Для приветственной речи приглашаем директора нашей больницы Албаева Рустам Қожбековича. With the welcome speech, we invite our chief of the hospital, Albayev Rustam.
Саламатсыздар ма, құрметті әріптестер. Бүгінгі конференцияның қатысушылар, сіздерді бүгінгі шарада көргеніме өте қуаныштымын. Очень рад, уважаемые коллеги, всех приветствовать на сегодняшнем конгрессе. Вчера мы проводили официальную часть и открывали терапевтический блок. Сегодня у нас уже третий день конгресса. Мы открываем официально хирургический блок. Скажу честно говоря, для нас это такой опыт, первый в плане хирургии. В прошлом году мы проводили аналогичный конгресс по терапии. Я думаю, был очень интересный, очень актуальный. Хочу сказать, что те вопросы, которые сегодня будут обсуждаться, это все профиля хирургического блока, и общая хирургия, онкология, кардио, нейро, эндоскопия, может, там, гинекология, может, кого-то я забыл. Очень интересные и очень актуальные. Будут очень хорошие доклады, очень хорошие дискуссии будут, плодотворные. Поэтому, уважаемые коллеги, всем хочу пожелать плодотворной работы. Думаю, что все пройдет в очень интересном ключе. Коротко, раз уже я добрался сюда, Мажил Касалович, хочу рассказать о нашей больнице, потому что многие, наверное, не знают. У нас 400-коечный стационар, 200 коек – это хирургический блок, 200 коек – это терапия, 12 операционных у нас, из них 2 гибридные операционные, поликлиника на 750 посещений в смену, 2 смены мы работаем, это 1500 посещений, по факту гораздо больше, до 3000 посещений происходит в день. В 2022 году мы запустили 2 новых корпуса, это 200-коечный терапевтический стационар, мы запустили циклотронный производственный комплекс, на сегодняшний день мы производим 9 радиофармпрепаратов. Больше нас в республике радиофармпрепараты не производит никто. Основное направление, которое мы проводим, наша больница, это разработка новых технологий, новых инноваций, которые в дальнейшем мы проводим трансфер в практическое здравоохранение, в регионы. И зачастую, Равшан Жумарт нас здесь, не даст мне соврать, она лечпроф наш, регионы направляют к нам пациентов, самых сложных пациентов, самых непонятных пациентов, которым нужно верифицировать, правильно поставить диагноз. И успешно эти диагнозы ставятся в нашей клинике. Мы расписываем базисную терапию, особенно это такой профиль, как аутоиммунные заболевания, ревматология, нефрология. В общем, все сложные пациенты из регионов, они приходят в нашу клинику. Туризм медицинский мы активно развиваем. Айрат Туриханович один из тех руководителей, которые занимаются этим направлением. Просто для сравнения хочу сказать, это для нас сравнительно новое направление, но за последний год мы сделали огромный скачок в том плане, что в этом году мы планируем принять порядка 850 международных иностранных туристов. Просто для сравнения хочу сказать, по данным регистра, в республику вообще за год приезжает не более 2000 официальных иностранных медтуристов. Вот считайте, практически 1/3 часть проходит через нашу клинику. Внутренние медтуристы, то есть те наши граждане, которые уезжают за рубеж, получать лечение в таких странах, как Южная Корея, Турция и так далее, мы сейчас переключаем их на себя. И эти показатели не в 2 раза выросли. По платным услугам хочу сказать, что в этом году мы планируем заработать порядка 10 миллиардов тенге. Я думаю, что учитывая, что бюджет одной клиники в области занимает не 7-8 миллиардов, я думаю, это показатель, мы, грубо говоря, можем содержать одну региональную клинику. Рассказывать можно очень много, сколько угодно. Я очень рад видеть всех, родные лица. Со многими из вас я стоял в операционной бок о бок долгое время, поэтому сейчас будут секционные занятия. Я сейчас, Мажил Касалович, вас приглашу, вы, наверное, скажете, где какие секции будут. Сам я, наверное, буду с кардиохирургами обязательно присутствовать. Баршаңызға тек қана сәттілік тілеймін, тек қана жақсылық, бізге тек қана жақсы жаңалықтар келсін. Спасибо. Удачной работы всем.
Hello, dear colleagues. We have earphones and direct translation from English to Russian and Russian to English. The earphones at the corner on the left side. Now we have all participants from 6 sessions. They will go in parallel. This section will be for NeuroAddicts, the name of the section. And the room on the right side, it's this room for neurosurgery. It will be full day from the morning till the evening. And the next room on the left side, it will be section for, just a second, endoscopy. After endoscopy, at that room will be traumatology and orthopedy. And then it will be ophthalmology and otorhinolaryngology, ENT. The room for 70 participants near the elevators will be for arithmology. Ayan Süleymanç, leader of the room, and after the lunchtime will be the section for the young scientists at that room. And general surgery and oncology will be on the level 3. Nasrullah Abdullayev Shanazarov will start this section. And last section, cardiac surgery, will be in the room near the elevator for the 50 participants. Қош келдіңіздер. Астанада көруге қуаныштымыз. Бүгін 6 бөлмеде бізде секциялар жүреді. NeuroAddicts осы бөлмеде, нейрохирургия көрші бөлмеде, эндоскопия, травматология, лор, офтальмология келесі бөлмеде болады. Кардиохирургия мен аритмология екінші қабатта лифттің жанында болады бөлмелер. Хирургия, онкология үшінші қабатта болады. Қазір барлықтарыңызды секцияларға өтулеріңізді өтінеміз. Просим всех пройти по секционным залам. All sections are going in parallel online, and yesterday it was more than 3,000 participants online, and I hope today will be more. Good luck, have a good day, and successful operations and presentations. And I hope we can start NeuroAddicts. Orlando, Ahmed, and Senta moderating the session.
Наверное,
Dear colleagues, we have a problem with the cable, and for the presentations, we need to give presentation on USB to the technical team on the right side of the room. Thank you. Now I'm leaving you. We need to start first case, and in 30 minutes we will be ready. And I'm asking, Vlad is on the way maybe, Orlando and Senta. Jens will help, I hope, to start the session. We have colleagues from Uzbekistan and speakers all around the world, and from Kazakhstan, and should be colleagues from Russia also. Okay, and Kyrgyzstan. Yes, let's start. Now I'm leaving. Okay.
not working. So we're gonna start with the session. Professor Jens Fiehler will start with his talk. I'll just briefly introduce him. So he's the director at the University Medical Center Hamburg, Eppendorf, and please Jens, start with the lecture.
Thank you. It's, I try something. Доброе утро, уважаемые коллеги, дорогие друзья. That's all. So my subject, I had the free choice of subject, is thrombectomy in large core stroke. So this was a big subject for the stroke world because we had quite a few randomized controlled trials that more or less surprisingly showed that thrombectomy works even in large core stroke. So all this meticulous, what's the core, what's the penumbra thinking is more or less thrown out of the window. And I think not only me, but also many of you will wonder why. And I would like to discuss with you some of the data and maybe bring a little bit of light into this mystery. So from a disclosure perspective, I'm the core lab PI of the tension study. It's one of the randomized controlled trials that I'm talking about. So this is how it used to be. So we have, in an acute situation, we have an infarct core, then we have a penumbra, and if we reperfuse, the infarct is only the core in the follow-up imaging. And if we don't reperfuse, all of the penumbra region is going to be necrotic, is an infarct, and it's gone. And yeah, so essentially what we are salvaging is the penumbra. But the problem is, where is the size limit? So if we have a very large infarct core to begin with, and then if we reperfuse or not, doesn't matter, we always have a big infarct. So what's the point? And the reason for all those studies was to establish, is there an upper threshold for the infarct size? And we have all those studies, 6 studies in general. So LAST is also published in the meantime. So 5 out of the 6 studies are published and 5 out of the 6 studies are positive. They are different in some respects with the patient selection. And if we look at the tension study, the randomized controlled trial, what we see is the rate of good outcome with treatment is 31% and without treatment is 13%. So the therapy effect size is 18%, more patients with MRS 0 to 3. And the very recent publication of essentially of September, so 2 weeks ago, also showed that this effect size is the same even after 12 months. So 38%, 17%. So it shows that the number or the percentage of patients with good outcome even increases with time in both therapy arms, but the effect size is stable. So there's no closing of the gap between treatment and no treatment. But there is one thing that I would like to focus on, and this is we have the highly significant difference in the rate of good outcome. So 39 versus 16%, what I just told you. But if you look at the infarct size at follow-up, there is no significant difference. So why are the patients better after treatment if the infarct size is essentially the same? So what's the point? What are we doing? So MRS 0 to 3, 18%, infarct size is 10% smaller, yes, but it's not significant. It's not that much. So we have 205 milliliter versus 227. Does it explain such a huge therapy effect? Hard to say. So if we look at what's happening to the individual patients, what you see here in this diagram, you see how many patients from 90 days to 12 months on the left side with thrombectomy, on the right side with medical treatment. And you see how many patients improved and how many had a deterioration between 3 and 12 months. And I think the short summary is that a lot of good things are still going on in the endovascular thrombectomy cohort. There's much more traffic. And with medical management, that's essentially, it stays the same. It's a bit confusing, this graph, and we don't have the time to go into it, but essentially, what I think we are doing is we are having a much more prolonged effect of thrombectomy with cortical reorganization and rehabilitation and whatever is going on, but with medical treatment, essentially nothing happens anymore. And if we look at these are all the different studies that I mentioned, all the 6 trials, and the green bars are endovascular therapy, and the gray ones are best medical treatment. And you see that in each individual study, the endovascular therapy has a much higher rate of MRS 0 to 3 and 0 to 2. But they are different. If you look at the rate of good outcome in the Chinese study, Angio aspects is the best. And in Tesla is the worst. And this can be best explained by different patient selection. So if you select with CT perfusion, you have a better outcome than if you compare with non-enhanced CT, for instance. But if we compare, let's say, SELECT-2, one of the studies with CT perfusion and tension, what you see here is that the effect size, so the difference between treatment and no treatment, is almost exactly the same. So what we are doing with CT perfusion, we are not selecting the patients with the higher therapy effect, but we are selecting essentially the better patients in general. So it's a question what you want to achieve with your patient selection. So going back to this, is there a threshold for an infarct size? And this is what we recently analyzed, is we had a look at all those studies who published on MRS 0 to 2, so the almost complete infarcts, and there is still a therapy effect in those patients. And this is now almost classical paper from the Hermes group, and they published that the infarct volume reduction explains only 12 to 14% of the thrombectomy effect. So, but where is all the rest coming from? So essentially what we are thinking all the time is we reduce infarct size by early intervention, but that's not what's happening here. If we look at the follow-up volume in the endovascular group versus control group, in the small infarcts, there is a difference actually in the rate of good outcome, but in larger infarct there's no difference anymore. Okay, I keep it like that, and we did another analysis because we didn't believe it, and we got to a different result. So if you just focus on the patient with successful reperfusion, not all the patients, what they did in Hermes, but only patients with successful reperfusion, we found that more than 50% of the therapy effect is explained by the infarct reduction. This is a recent analysis from the Angio aspects group, and here you see a kind of ambiguous finding. And so if you take into consideration also the mismatch between the clinical patient selection and the infarct cause selection, then if you have a lower NIHSS, smaller infarct core, so exactly what you would expect, and higher NIHSS and larger infarct core, also what you expect, so the regular relation between core size and symptoms, then you have a significant difference between treatment and non-treatment. But if you have a bit of a chaos with, for instance, high NIHSS, so lots of symptoms and small core, or the other way around, then you don't have a therapy effect anymore. So there's something beyond the sheer volume measurement that we don't understand at the moment. And it might have something to do with not only volume, but also the degree of ischemia. And you can measure this, or the ischemic edema can be measured by a so-called net water uptake, which is essentially just how gray is the CT. So it's very simple. Because we just had a look in the previous slides only on the volume of the infarct core, but we didn't consider what's going on inside of the ischemic core. So we can just very easily measure the density. This is a formula that is the easiest formula you can imagine. So left versus right, essentially. So the relation between left and right. And this is the percentage of net water uptake. So very easy. And if we look at so I think we skipped this part. So if we look at this graph, you have in the patients with persistent vessel occlusion and vessel recanalization, obviously in the acute situation, you have the same edema, but with persistent vessel occlusion, you have higher net water uptake than with recanalization. So what does it mean in practice? We reduce edema by reperfusion. And I think this is not very intuitive, because what I was thinking is that if we reperfuse an artery, then we would rather increase the edema, because a lot of things are going on with the blood-brain barrier, and you have all the blood pressure, and it's all pushed into the brain tissue, and that's not what's happening. So what we do, I think the first hint for the subject of the talk is we reduce also the edema. So not only infarct size, but what's going on in the ischemic core. So we reduce edema by reperfusion. And then we had a more closer look on this phenomenon with 422 patients with successful reperfusion. And what you see here is the rate of good outcome versus the preserved penumbra volume. So if we say we have a big mismatch between core and ischemia, and then we can rescue some of it. So essentially the regular theory of why thrombectomy works, we rescue penumbra. And so what you see here, if we rescue 100 milliliter penumbra, the rate of good outcome is 40-something%. And if you rescue none at all, you have a poorer outcome, go like there. And if you rescue more, you have better outcomes. So you can essentially do a thing that is called mediation analysis. You can analyze, if in case of reperfusion, how much does penumbra salvage contribute to the rate of good outcome? And essentially, this is the other important message for today. The reduction of penumbra, or the rescue of penumbra, contributes 28% to the effect size, but the edema reduction, 66%. So what we are actually doing with thrombectomy seems to be we reduce edema, but we don't necessarily rescue penumbra. Of course, we rescue penumbra, but this is not the major factor for explaining the therapy effect. And this is, if you look at it as a sequence of events in time with stroke, you have, in patients with a lot of edema in the beginning, you have a higher chance of infarct growth. So if you look at a small net water, so light gray, you have less infarct growth with the same size of infarct. And if you have a dark gray infarct, you have more infarct growth. Independent from the penumbra, it's just what's going on in the infarct core. It's published a few months ago in JCPFM. Yeah, this is, I think, a fancy graph showing the same thing. I don't want to go into detail. So why does thrombectomy work? So addressing the original question that I posed here was, so where's the threshold? So essentially, I think what we are seeing in reality in this core, it's not a homogeneous core that is dead. There's something going on in the core. And it has a variable prognosis depending on the edema. And most likely, you can't, maybe you see it here. With successful recanalization, you still have a large region with some brain damage. But the difference between treatment or reperfusion and no reperfusion is that it's entirely dead on the right side here. But here there is a partial necrosis only. And I think that's the most likely explanation for those thrombectomy studies. So partial core rescue, I don't know if this is a good term. If I may summarize, the penumbra salvage in general, and in particular with large core infarcts, is less important than expected. The reduction of infarct infarct volume, that's what we originally intend, explains maximum 50% of the therapy effect. Most likely, the edema reduction in the infarct core is much more important than expected. And shades of gray is a hot topic. So we should really have a look at the CT scan, or not only look at how extensive is the aspects distributed, but also how dark is the brain if the region is affected. And this concept of partial core rescue is something that we need to understand better, to also to help develop further therapies for neuroprotection and other approaches to improve the outcome of large core patients. Thank you.
So thank you, Jens. Any questions from the audience? Okay, we'll proceed to the next speaker. Professor Orlando Diaz. He's gonna talk regarding the power of the needle and percutaneous approach for difficult neuro-endovascular lesions. So please.
Good morning. Thank you for the invitation, Manjil. I'm so happy to be here in Kazakhstan. I'm very impressed with the people, with the country. I'm so happy that I came to see friends like Alberto, Rene, and the rest of the team. I'm going to be presenting. So I spoke to Lvis. The disease is there. Every time we understand the disease better and better. And the way that we treat, we need to have a plan. If the plan is bad, the result is bad. So, and at the end, what tools we use, what technique we use, the arterial approach, the venous approach, it doesn't matter. At the end is, what is the purpose? What we want to close, the shunt. We want to reduce the venous hypertension. We want to take care of the intranidal aneurysm, etc. So we need to have a plan before. And I want to, thanks again for the invitation. I'm from Colombia, South America, and work in Houston. And this was a long trip, South America. This is Colombia here, working in Houston, and from Houston to Kazakhstan. And I'm so happy to be here. It was a long trip, but I think that has been worth it. This is my conflict of interest. And this is that I'm going to tell you the technique. As I said, this is another tool. This is not going to replace any technique, but why to ignore this technique? The needle, there is a small device, and it's a cheap device, have a big power, specifically with difficult cases. that we are going to be seeing. So this is going to be the outline. So understanding the pathology, planning. If the planning is not good, the result is not going to be good. Sometimes we have a plan, we do the case, and at the end, we don't have the result we want, and we need to change. That is very common in our field. So what technique to perform? Use the technique that you feel comfortable with. You know, I know that Rene is an expert to do a venous approach. Maybe I'm not as good as he is doing the venous approach, but I'm better doing arterial approach. So we need to do what we have in our institution, what we have in our hand, in our mind, and go from there. Be effective, be safe for the patient. So, and if we have a needle, we can use direct skin, that is the easy, but we can use multiple options. One of them is the surgical exposure. And I want to show you with the Acom Siemens machine, the iGuide that I have been using for a long time is very effective. What is the embolization material? We can use Onyx, MBCA, maybe in the future we can use Subtura that we're learning from Alberto now. But this is a simple case. It's like a 50-year-old case. It's a metastasis of renal cell carcinoma. When we're doing this is the 3D, we see the destruction of the bone. And the angiogram showed that basically the superficial temporal artery. We have been having a long time a lot of lawsuits in the US for skin necrosis after superficial temporal. So when we see superficial temporal, occipital, or posterior auricular that is supplying the scalp, maybe the embolization, presurgical embolization is excellent, and the resection of the tumor is excellent, but then it's going to be necrosis. So when we have that and look at the tortuosity of the superficial temporal, we prefer to go directly, do direct puncture. It's very simple, and then we can do a direct injection of the embolization material, and we can have an intratumoral injection of the embolization material, like you can see here, pre on the left and post on the right. So this is very simple. This is an old case, but we can have also complex cases like this. This is a patient, this is a doctor with this type of lesion. It's huge. This is what it used to be called cirrhoid aneurysm. We know that this is a fistula of the scalp, and because this is chronic, has been there for a long time, so you can see all this venous dilatation, all these venous aneurysms, and it's like a caput of Medusa appearance. And we can be impressed with the clinical presentation, impressed with the angiogram, but we analyze the angiogram doing the Dyna-CT, 3D, and then we can see exactly this is where the shunt is. So in reality, it's a very simple disease. It's a very simple plan. We need to disconnect the shunt and do whatever you want to do. You know, go there with a microcatheter, superficial temporal, as I said, very tortuous. So we can go simple with a needle and inject Onyx. This is a relatively old case. Decrease the shunt. Of course, this is a multidisciplinary approach with plastic surgery, etc. And we can have the Dyna-CT with all the Onyx that we can get, and this is after extra skin resection. So it's a huge, supposedly it's a difficult case, but it's very simple if we treat this patient with a needle and then. Here's another one. I had the opportunity to see also Rene the last day, Alice, doing this similar case. This is a patient with a hypervascular lesion of the neck. You can see here the three-dimensional and dual volume reconstruction. This is the injection, and it's interesting. It's not a carotid body tumor because there is no spleen of the carotid. It's not a vagal paraganglioma. It's not a jugular, but I'm going to tell you what it is at the end. So it's a hypervascular lesion. So it's very simple. We stop doing intraarterial embolization. We can use ultrasound or even very simple doing a fluoroscopy injection. We use, and then we think that we put this is most of the tubing, we know what a DMSO tubing, DMSO compatible tubing, because we inject DMSO and we test it for in the lab. So most of the tubings are DMSO compatible. And when we think that we puncture this type of tumor, it's going to be a jet of blood coming out, but it's not, it's dripping, look at that one. So we treat this exactly, do an intra-injection. We used to put a balloon in the internal carotid. We don't do that anymore. We are more concerned about the vertebral because sometimes the vertebral artery, the musculospinal branch of the vertebral, C3 anastomotic branch, neuromeningeal trunk of the ascending pharyngeal have anastomosis with the vertebral. So we have almost a complication injecting intratumoral, refluxing into the anastomosis to the vertebra. So to me, if we need to put a balloon, it's in the vertebral, not in the carotid. But after we understand, this is the injection of onyx. I don't remember if it was 34 or not, but sometimes they are multi-compartmental. So doing is a simple procedure, very safe. It's a quick procedure. We can be far away, protected with a shield to prevent radiation. This is the type of penetration. We're not injecting. Sometimes we're getting reflux into the branches of the external, but I never have a complication to the internal. And this is the injection. After that, we can have a very good pre-surgical embolization. This is the surgery. Is basically a bloodless surgery, and this was an ansa cervicalis paraganglioma. It's not a vagal. It's not a carotid body tumor. It's an ansa cervicalis that has been reported before. This is a similar case. It's a hypervascular tumor of the neck. Not all the hypervascular tumors are paraganglioma. This is metastasis of renal cell carcinoma, and the clue is the ascending pharyngeal supply. So again, we can do this one. Most of the time, they are multi-compartmental, put multiple needles there. It's not acupuncture, it's embolization here, 4 or 5 needles, injecting, controlling, and this is before, and this is basically after. So doing that with a needle, not spending catheter, is very safe, and I think it's the best for the case. This is a very interesting case. This is a patient with, as you say, upper extremity weakness, abnormal blood vessels in the cerebellum, and hyperintensity of the spinal cord. Excuse me? Okay, perfect. So when we do the angiogram here, we can see that is an isolated transverse sigmoid sinus. So there is no connection, and there is reflux into the cortical venous system, and a lot of blood vessels. I tried to use onyx. The onyx was flying into the venous system, and so we can try to recanalize the connection between the turcula and the isolated sinus. So we go from the left side. This is what we need to. At the end, we can do 2 treatments here to recanalize the whole sinus and put a stent and connecting to the venous system and embolize the fistula, or being practical and go there is a basically type 5 cognitive classification and close that segment. And there are multiple ways to go there. One is going through the thrombose jugular into the sinus that I have done before, or going from the turcula to the sinus, or from the jugular to the sinus. But it was impossible after using all type of material. The other option is to do a small bore hole and then go there and put coils and onyx and close that one. So, but if you analyze the 3D, look at, I don't know if there is a pointer here, on this side, on the right, the transmastoid branch, the transmastoid foramen is huge. So there is a natural borehole here. Is that one? I don't see, there is, I think there is a pointer here. Here. This is small, this is huge. So even though borehole was an option, as I said, we can recanalize. This is huge. So look at here. So doing the reconstruction with the Diagnostic, we can see that it's a natural borehole. So we can use that as an advantage. So patient in prone, this is the microcatheter through that transmastoid foramen, getting into the segment of the sigmoid sinus, and put a small 4 French, that the dilator that we use for the femoral or radial goit. The patient, as I said, is in prone. This is the microcatheter, the sheath. Injection directly from there. We can see the connection to the perimedullary venous system. This is the onyx that was doing nothing via an arterial approach. So the rest is easy. So it's just to put coils and then fill with onyx and fix the problem. So this is another patient with multiple abnormal blood vessels. So what is that? But we can see here there is a mass. And it's not unusual, has been demonstrated that this is a paraganglioma of the, of the canal. Look at this is injection, the CT angio. Look at the CT angio, and it looks like an aneurysm. Look at the hypervascular, similar to the, I'm sorry, this is a hemangioblastoma. So here is the injection into the internal iliac, supplying the tumor, and the 3D, seeing all the high flow situation on the anatomy, and there was a small aneurysm related to the flow. And look at how the venous outflow is a venous conjection. So this patient was taken to the surgery, and then patient started bleeding, so they need to close. Even though I have a pre-surgical embolization, was not enough using the arterial approach. So put in a needle. It's the same, so we can have control of the injection. So it's like doing the paraganglioma injection. We do a injection of contrast first, see how the flow is, and this is exactly intratumoral onyx cast. So what about when we don't have it's a deep lesion, but we need to be very precise? The eye guide is a good option. This is a patient with a juvenile angiofibroma that was embolized in a different institution, was resected. When we do the angiogram to do another lesion, we can see that there is small multiple branches going there. Remember the connection to the inferolateral trunk here, meningohypophyseal supplying this one. And even though we can do a lot of strategies to do the intraarterial approach, doing this at the Dyna CT, that we can see exactly the lesion extending into the sphenoid sinus. And I think it's safer and was very easy doing the eye guide. So we say what is the target, and this is the target here, and we start looking what is the best direct approach to get that there is no bone in the middle. And it's very simple. The machine is telling you it's 4.51. It's telling you the angulation, and you have this one. When you fluoro, it's going to have a target here, and we put the needle in the middle, and we know that it's 4.5 millimeter. We mark that, and we push, and it's very precise. Very precise. We are doing an intratumoral embolization. This is the needle here. And also because the inferolateral trunk and meningohypophyseal, I protect those internal carotid with a balloon, because eventually we can have intratumoral anastomosis, as has been very common. So we can do a direct injection. Weight is the same technique, and the balloon is inflated here. And we can see how the onyx is distributing inside of the tumor, sometimes getting the venous outflow, and the balloon is there to prevent embolization to the distal MCA. So this is how it's getting reflux into the feeder in general. It's similar to any type. Look at how this is going into close to the cavernous ICA branches. And we stop, it's the same technique. We wait, we can do an injection, continue injecting, and until another compartmental is filling here. Look at this one, this is getting close to the inferolateral trunk. And this is post-embolization. We think that we can do that. We also can do another eye guide approach and go from there. So this is the onyx cast and Dyna CT after the embolization that is basically very similar the initial treatment. This is what it has been reported with the onyx, and like a 4th of July with the electrocauterio in surgery. So this is during surgery for this case. This is a recent case. This is a 42-year-old patient with proptosis. There is a CT scan that was negative a few years ago, and this is the new, look at this lesion that is causing proptosis. It's intraorbital, intraconal. This is the MRI and enhancing, look at the blood vessels. And they try to resect this tumor, and when patient start bleeding, this is the clinical presentation here. The vision was preserved, which makes the case more difficult for us. So the orbitotomy was performed, and it was a lot of blood going there. So we did the angiogram, look at the hypervascularity of this lesion. Definitely is difficult to do a presurgical embolization. The choroidal blush was preserved here, so making the case even worse. And this is the supraselective injection with a microcatheter and using a balloon here just to redirect the. And after doing embolization with NBCA, the most important part of the tumor was not taken care of, and so I use a eye guide and do direct puncture. This is direct puncture with a needle. This is injecting onyx. We had the balloon here inflated in the ophthalmic. The patient was consented for possible blindness, of course. They knew the risk, but I try to preserve the choroidal blush. So this is the injection of the onyx. It's well controlled, very simple. It's difficult to obtain sometimes this injection intraarterial. This is the Dyna CT during the eye guide where we can localize exactly where the needle is. And this is the post-surgical embolization. The choroidal blush is preserved, the ophthalmic artery is preserved, and the patient, when I talked to the ophthalmologist, said, "Did you close the ophthalmic?" I said, "No." He said, "How come?" He was suspecting, and the patient was suspecting, to be blind after the embolization, making the surgery easier, but I was not. This is the tumor, was a solitary fibrous tumor that used to be called hemangiopericytoma, and after surgery, the vision was also preserved. So eye guide. For these cases, normally for dural fistulas of the cavernous, we have multiple approaches, easier to treat. But there are cases of cases. There are difficult cases. It's impossible to go through the arterial approach or to the venous, even though the inferior petrosal sinus is not there. 90% of the cases, we recanalize the inferior petrosal sinus. We can use the facial vein. We can puncture the superior ophthalmic vein using ultrasound, eye guide. We can expose surgically the superior ophthalmic. There are multiple ways that I'm sure UI has done all of them. But there are difficult cases like this one. This case was treated in a different institution in US and was trying to do embolization, was very difficult to get all the ways. So they showed the case to me. There was no connection to the superior ophthalmic vein, to the facial vein, so surgical exposure was not an option. Sorry, this is turned around, this one. And this is the injection. So injection into the contralateral side, we can see the shunt into the intercavernous sinus going into the left cavernous sinus, but there is thrombosia. So it's very difficult we cannot go to the facial, we cannot do an exposure, surgical exposure of the superior ophthalmic vein. So there is the best way to do that, and the easy way to do that is using eye guide and get into the cavernous sinus. We don't do that routinely. This is a case that definitely are unique cases, impossible cases to treat. And this is where the needle is, and we can do the Dyna, make sure where the inferior cavernous sinus is, follow the needle, get into the cavernous sinus. Very simple, believe me. This is a very simple procedure because the machine is telling you everything, the angulation and so this is direct. This is the puncture, pre-embo here and post-embo where this is the post-embo where we inject onyx. Surgical assisted approach. So in this case, for some reason, there is a focal venous hypertension, abnormal venous drainage. But for some reason, this patient was taken to the OR. They did in the OR, but it was a difficult case. Difficult to understand. Dural fistula sometimes are difficult to understand. Sometimes we understand the fistula when we fix it. And this case, so after I analyzed exactly what happened, the shunting was here, is in this transverse sinus, was draining in one of the tentorial meningeal vein into the vein of Lvis. This has been described that the vein of Lvis is not draining exactly into the transverse sigmoid sinus junction. Sometimes it's draining in one of the tentorial meningeal vein, that is this one. So the shunt was over here, and they called me for the surgery because the patient, they opened, they do a craniotomy, they didn't know where the shunt was. So this was transferred to me. So this is the residual after surgery. This is a long way to go. The patient was intubated. So I know that this is very simple to puncture this, taking advantage of the craniotomy. So we did this one, it's using eye guides. This is the sinus using this craniotomy. The has been placed, it has been performed. This is already, look at the target here. As I said, we put the needle in the middle, and we is very precise. Here is the target, you can see here. Has to be exactly at the same, and the machine is telling you how many. And this is coming back, arterial bleeding from because it's an arterialized transverse sinus. Advance, change for this just to use a microcatheter. So this is the microcatheter here, the sheath, the 4 French sheath. And advancing the microcatheter into the area of the fistula, the wire. Do a supraselective injection. This was exactly what we want to disconnect the vein of Lvis from the arterialized sinus. Put some coils there, the routine, and then at the end inject glue, MBCA, inject the Onyx 34. That's what most of the time I use in this type of lesion. And this is the final result. So this is another tool. This is, the disease is there, the physiopathology is there. We need to have an approach. What is the plan? What we want to do? Do whatever is easier for you, faster for you. I remember that there is a power of the needle. The needle sometimes made the case easier than we think. Thank you very much.
So thank you very much. I think that now we have this live case. I'm not sure how to manage with this part, but hopefully they will somehow connect.
Proceed with the next lecture.
Okay. Otherwise, we will proceed with Ahmed. I think so. And then Rene, you have the... Okay. Okay. They cannot. So we'll proceed with the next speaker regarding the status of mechanical thrombectomy in the Middle East. Please, Ahmed.
So, good morning, everyone. My name is Ahmed Elserwi. I'm from Cairo, Egypt. And today I will be presenting to you the status of stroke in the Middle East and especially in Egypt. I was discussing with Minjil that practicing neuro-endovascular therapy is very different from country to country and from region to region. So I will give you a quick overview about what's happening in my region. There are 18 countries in the Middle East. 9 of those are regularly practicing and offering mechanical thrombectomy for LVOs, for large vessel occlusions. If we have a quick look at the numbers in 2023, Egypt, which has a population of 114 million, performed 465 procedures. Saudi Arabia, which has a population of 37 million, performed 1,000 procedures. The Emirates, which has a population of 10 million, performed 120 procedures. And all the rest of the other countries performed less than 100 procedures in 2023. The number of hospitals providing the service are highest in Egypt and Saudi Arabia, and it decreases in other countries. If we look at countries like Oman and Qatar, there is only one hospital in the country that offers mechanical thrombectomy for LVOs. We will go in more depth, talk about what's happening in Egypt, because this is where I have a lot of data and this is where I practice. So Egypt is almost 400,000 square miles and it has a population of 114 million people. Cairo, the size of Cairo is less than 1% the size of Egypt, and it is very densely populated with a population of 22 million people. In 2023, 465 thrombectomies were performed in Egypt, and 90% of those were done in Cairo. So most of the work is done in less than 1% of the area. An overview of the health structure in Egypt: there are 3 main hospital systems. First, there are university hospitals, and they operate under the Ministry of Education. They're mostly government-owned, few private hospitals, and they're usually tertiary centers, and the treatment is offered free for all citizens. And then comes the government hospitals that operate under the Ministry of Health, and they include educational hospitals, public insurance hospitals, and general hospitals. And then comes the private sector, which in Cairo especially makes most of the work, and it operates under the Ministry of Health. And these hospitals are either primary, secondary, or tertiary. And in these hospitals, it's completely different, because when you treat patients, these patients usually pay out of pocket. They have to pay for the treatments. And more recently, there are private insurances that are paying for them, but not the public insurance. So in 2023, Egypt, with a population of 114 million, there were 24 hospitals offering the service. If we compare this to a large state like Texas, for example, which has a population of 30 million, which is quarter the population of Egypt, there were 45 comprehensive stroke centers, 6 thrombectomy-capable centers, and 93 primary stroke centers, which means that there is still a lot to do in the region.
Ahmed, sorry. I just got the information that they are like live with the case. If we can just proceed.
Yeah, sure.
Hello? So, do you have any images of the case that you guys are doing and what is going to be the plan? Nobody has presented the case. Are you listening over there?
Mitchell, can you hear us? We cannot hear you.
Hello, there is a problem here with the sound. I think the sound is coming from the different room here. Monjil, do you have a, could you talk to us? Are you listening to us?
Yes. Jens is going to try to call him. Let's see if his phone is still right. Yes, he's speaking.
Yes, I think that we need also to get the monitor closer.
Is there someone from the technique that can help?
No. Monjil is doing the case now?
No, probably not.
No. Do
Because-
you know what is the case about?
No, no.
No, nothing.
No. We can try to guess, but so did we see a pathology here on the pictures? Up to now? Not really.
So we can just turn around.
So the vertebral. So
PCA?
on this side, on the right side, and then look at the stenosis of the left vertebral to the vascular here on, on this. Yeah.
Okay.
That's the only thing.
The PCA, let us tell you, look, the PCA is.
Yeah, that's PCA.
So those are left PCA. Look. So we see two stenoses at left distal V4 and left PCA also. Not the proximal, but a bit later on.
I'm gonna talk to them.
Раз, два, три. Раз, два, три.
Yes, definitely tight stenosis, 3 to 4 centimeters after the origin of the left PCA.
Пожалуйста. Можно будет звук подключить? Так, план қандай? Ар жағында жоқ. Хорошо. Баллон бір жарым ашып едіңіздер? Hello, hello. I hope you can hear me. Rene, Jens? Hello? Can you hear me?
Orlando, how would you treat this? The tight stenosis of the PCA, which is an artery which is less than 2 millimeters.
It's a very interesting. Hello, it's a very interesting question. After the samples in US that we consider underdeveloped country, we are very limited for intracanal stenting. So the patient has to be seen by a vascular neurologist, make sure that the patient has been receiving the optimized medical treatment, control of the blood pressure, control of everything. If the patient, I'm sorry, Monjil, are you, hello?
Hello, hello, I can hear you. Yes, Orlando, please continue about samples. It's a very good trial. It's stop development of the intracranial stenting, yeah?
It's a very tight stenosis indeed. So self-expandable stent or balloon expandable stent?
Rene, I hope you can hear me.
Yeah, I can, yes. Very good.
Yes, we have some experience with just self-expandable stent placement. Maybe in this case, I will do the same. In next 5 minutes, we can show you.
Which is what I would do also. That's why
Yes.
I asked Orlando what he would use, because I think in the US is rather balloon expandable.
Yes, but I would do in US an angioplasty and atlas stent. We don't have, we are not using wingspan lately, but it's an option, but the system is too big. I wouldn't use a balloon expandable. This is curved, it's small, we have the risk of rupture, it's less flexible. So I would use an angioplasty and most likely an atlas stent after that.
So no Onyx Resolute here.
Not Onyx. You do the same?
I don't use balloon expandable stents intracranially for different reasons. First, the vessels are not straight. Second, I think it's safer to under-dilate. If you go up to nominal diameter, the risk of rupture is higher. And if you under-dilate, then the stent will be floating in the artery proximally. So if you need to go through, you may crush the stent.
Okay, the case is under local anesthesia.
I would use general in US because I don't want any movement and have the risk of rupturing. What would you use over there? You push them.
Okay. I will switch for the left side.
So, yeah, general anesthesia. I think it's very brave to do it under local anesthesia, or maybe the Kazakh patients are tougher than ours.
Monjil, what is the advantage in this case to do under conscious sedation? You don't have anesthesiologists. What is the limitation? Why not to do under general anesthesia?
I think we can ask our anesthesiology team to give a slight sedation. But when you start to do a little bit deeper sedation and then patient is starting snoring, yes, it's another problem, huh? And patient is
But there was a little bit of a stenosis on the left vert. Why not going through the right?
yes, it looks like stenosis on the left. Just a second. Yes, unfortunately, I left my keys at home and I waited for the keys, and that's why we were late. Yes, it's life. It's force majeure Yes.
Could you tell us a little bit of the clinical presentation, patient age, the patient presented with a PCA, infarct? What is the story? What is the history on this patient? And the
Patient
medical
is
treatment?
67 years old and it was not stroke, it's incidental finding, yes. But Islambeck is prepared the case. I think there is a small ischemic changes should be in this territory, usually.
Embolic.
Yes, should be embolic.
source. And is it distal enough for avoiding branches to the mesencephalon?
Yes, it looks like P2, P3 segment. And as you noticed, I don't see the screen in the operating room, but we are operating on the Toshiba. It's a good machine, but in my opinion, this machine is not for neuro. And I hope Adnan will agree with me. Yes.
I'm not Adnan, but Adnan changed just recently to Siemens.
Yes, there's Siemens and Philips is for neuro. Yeah.
What is the dual antiplatelet regimen, Manjul, that normally you do for this type of patient? What do you use? Brilinta, Prasugrel, Plavix? How many days before?
Patient premedicated with Brilinta, kaçan verdin? Yes, in the evening, patient received 280 milligram in the evening, and in the morning it was another 90 milligram aspirin. Yes, and the patient on aspirin already for the cardiac reason. Yes, now we can see it from the CT and patient is moving.
In US, the only way to do intracameral stenting is if the patient is not responding to the medical treatment. Otherwise, we can have legal problems or ethical problems with the hospital administration. So it has to be on Plavix or aspirin or Brilinta. We check the P2Y12 to make sure that it's responding. And if the patient still is having symptoms, we proceed.
Yes, in our country, it could be the same, but most of the patients are not so disciplined, and I think this is not the branch. Just a second, roadmap is moved. Қозғалмай жатыңыз аға, қозғалмаңыз. Қозғалмай жатыңыз. And I noticed the other point, if you treat the patient, and after the treatment, you say to the patient, you need to take medication, and then the patient is more controllable. Huh? Yes, it's quite distal from the medullary point. Okay, this is a point where we're already doing occlusion. Yeah? Let's check. Okay, let's see the angiograms before. This is left side, and let's check the PCA territory. and there is no PCA. If there is a PCA collaterals from the MCA, usually this kind of stenosis will be occluded in a very short time. That's why it's a patent. There is no collaterals. Credo. Credo, verso. Yes. This was. We will take Credo 530, and we will try to place just the Credo. And usually the radial force of the Credo is enough, and it's possible to do it without angioplasty. Let's see. Yes, from the CT angiography, it was just a V4 segment, and we planned easy case, just straightforward with the.
So there are
Straightforward.
here two ways to proceed. Either first make the PTA and then place a stent, or place a stent and potentially add a PTA after it.
And option 3, just place the stent without PTA.
Yes.
Let's see, Rene. And also there is a stenosis in P1 segment, P1, P2. Yes, the Credo is arriving. We are working with the Neuron Max as a guiding, and the Headway Duo is an access catheter. GK Black was used for the navigation, and now Credo 530. We can start
530,
here.
so obviously oversized Credo.
Yes, it's oversized. It's all the time oversized, and I noticed 5 is working better than 3 and 4. Okay, let's do angiography. And it's safe. 5 is not expanding till 5.
The advantage also of this kind of stent is that you can unsheet or resheet and change if you want to.
Yes. And now stent is in place. Let's check just a second. And one before. Yes, nothing changed, huh?
Not much, indeed.
Much. Let's wait, and now I will ask for 3,000 units of heparin. No, no, sir. No, sir. Please, Anish. Shall till the neurospit will come, the Credo will be in place, and we will do second angiography, and we'll see.
Rene, would you do the angioplasty first if you would have been doing this case?
Usually we have quite short stents, so maybe it changes, but we had a couple of situations where trying to cross with the balloons through the delivered stent displaced the stent. Which is the reason why we tend to first PTA and then stent. But it's interesting to see that Minchil has a good experience with this, and if it works quite often, it's good. Here, I think that at some point, some PTA may be required, but let's see how it continues.
I think they improved also the design of the PTA balloon. So this folds that might have caused it should be reduced.
There is some problem with resheathing the stent. Okay. Okay, let's see. Let's see what happened. Just a second. The stent is not resheathing. Stent doesn't want to go inside the microcatheter. No. Okay.
So we don't have Credo in US, so it's a completely resheathable stent, or is part?
Usually, yes.
I see.
Yes, usually yes, but not in this situation. Okay. Now we have some technical issue. I have two options. Option one, I can resheath the stent and then I can place the stent and then try to go through, but usually it's a problem. And option two, I will take out the stent and then we'll do angioplasty. I think the second option is better.
Which microcatheter were you using, Minjal?
The first was a headway duo, and now I'm coming with the NeuroSpeed 1.5 by 8. There are collaterals. Okay. Okay, let's try to go in parallel with stent, and sometimes it works. Side of lesions. Alt atmosphere. In the flap.
So the NeuroSpeed, for those who don't use it, is a dual lumen balloon, but it's a dual lumen PTA balloon and not a dual lumen remodeling balloon. And with the advantage that the stent can be delivered through it, with the drawback that it's more expensive than a core balloon, but it's quite handsome to first do the PTA and then once PTA done to deliver the stent through it.
Makes more sense.
Rene. Caribou. Rene.
So the balloon is quite
Rene.
short.
Rene. Rene.
Nader is here, huh?
I have a question.
Hello, Nader.
So Nader and Udai just joined.
Okay.
Hello.
Good morning, Mindil.
Hello, hello. Alt atmosphere. So stop.
Don't you use NeuroSpeed sometimes, balloon with for delivery of the stent? So if in case you want to post-dilate, it will be much easier?
Also. Alt. Okay. Okay, we did a PTA with the NeuroSpeed. We went parallel, maybe parallel to stent, maybe inside the stent. No problem. Now it looks better, huh? Okay, I need to pull a little bit my balloon, and we will repeat the angioplasty. Okay, just a second.
What do you mean
Sure.
parallel to the stent, Minjil?
We go through the struts of the stent, but stent is opened like a solitaire. It's not deployed fully. We deploy the stent partially.
Oh, okay.
I couldn't resheath the stent inside the microcatheter. That's why I need to go like this.
But once now the balloon is in place, the neurospeed, potentially you could retrieve the stent and resheath it on the table in order to deliver it through the balloon.
Stent is already in place, and
It's also a good option.
yes, we just can detach the stent nozzle. And there is a small stenosis at this point. Okay. And we are giving a nominal pressure, it's 6 atmosphere. And at 6 atmosphere, balloon is 1.5 millimeter. I think we don't need more pressure. With the pressure, the diameter of the balloon is changing. Yes, now it's, I think it's enough angioplasty.
Yes,
And
much
maybe in P2 segment, I will give a little bit more pressure, a little bit more diameter in this segment. Okay. If I will give 9, it will be 176. Yes, now it's a 9 atmosphere. If I will give 1.5 balloon, 14 atmosphere, it will be 2.2 millimeters. I know, Rene, you are using the syringe, but with this chart and with this difference of pressure, we can play with the diameter of the balloon.
So definitely not with this balloon. The balloon has a different, so the neurospeed balloon has a change in diameter according to the pressure. So Coro balloons almost don't vary. And that's why with a Coro balloon, the level of the pressure is less important. That's a nice result.
As I think we don't need more angioplasties, and now we can detach the stent. One more angioplasty in this segment, 9 atmosphere. And we need to keep it. Yes.
I have a question. How do you know that the balloon was inside of the stent? Huh?
It's parallel.
It's outside.
It's very theoretically. Orlando, it's very theoretically.
I see. Okay.
Okay, I will leave my wire in place, and now we can detach the credo. It's good, huh?
Very
I
good.
I hope. Yes.
Good result.
I hope so. And patient under local, and we can communicate with him, and it's also nice. Okay. Nearest headway duo is distal.
How is delivered the stent? Yes, unsheathing. How to deliver the stent?
Just push it through the microcatheter.
I see.
Yes, the easy way is to take a neurospeed and just go PTA and then place the credo, but I want to show you this technique. It's also possible to use credo stent without the neurospeed. You may take any other balloon and go parallel with the headway duo, inflate, and after that you can place the stent. It's also possible, and it's easy.
Yes.
It's cheaper. Yes.
Very interesting.
Yes, and this result is acceptable, and if you agree with me, we will finish with this case. I will just take out my neurospeed and headway. Now we will do control angio. And the next case, we will be ready in 1 hour. I think there could be small changes in the program. We have 4 live cases for today. The second will be web case. I know Rene is hating the web, but we can try to do our best. And the case number 3 will be stenosis with aneurysm intracranial. And the case number 4, hemangioblastoma of the cerebellum, the second stage of the embolization. Let's do control, and then we can continue with the presentations. It's a time for coffee break in 5 minutes. Okay, as I learned from Alberto said no soft shields, it's increasing the radiation. Huh? Yes, it's good. I hope it's good. Yeah. Okay.
Very good, very nice.
Yep.
Very good. Awesome.
Okay. Thank you. See you in 1 hour. And you can go to the coffee break or continue with presentations. Thank you.
We finish the lecture that Ahmed started, and then coffee break.
Coffee break. Enjoy coffee break. Так, с этой операцией все. Следующих пациентов срочно привозите. Следующий под общей анестезией.
Thank you, Minjil. So we go back discussing what's happening in Egypt with mechanical thrombectomy. So if we look about the factors influencing the infrastructure of mechanical thrombectomy in Egypt, we have to discuss emergency medical services and emergency departments. The cost and availability of equipment is an issue. Neurointerventional training is another issue, and the post-thrombectomy care. So if we have a look at the emergency medical service, it's a completely different culture from one region to one region and from a country to another. The culture of calling an ambulance to take a patient with a stroke to the ER is probably non-existent in Egypt. Usually the patient arrives to the ER with his family or friends or neighbors, not through an ambulance. Even if patients call the ambulance, the paramedics are not trained to use LVO scores to detect large ischemic strokes. So the probability of the patient going to a tertiary stroke center is very low, so the ambulance usually takes the patient to the nearest hospital. If the patient has evidently a high NIH score, the ambulance usually drives the patients to the hospital with the free ICU bed, not to the hospital that can take care of the patient. In the ER in Egypt, the departments are most commonly run by medical and surgical teams, not by emergency medicine physicians, and they're not trained to different types of strokes and the management. Not all hospitals have on-call neurologists, which is also a difference between Egypt and Europe and other regions. And even less hospitals have vascular neurologists. CTA and CTP are not readily available in emergency departments to help triage those patients. And even patients who arrive in a tertiary hospital with the capability of detecting a large vessel occlusion, there are no hospital agreements to transfer patients in a drip-on-chip fashion for the LVO patients. The cost of the procedures also is an issue. Most government hospitals have a limited annual supply of materials. So even if a hospital can do a thrombectomy, it does not mean it will, because it just ran out of supply. Most private hospitals provide a pay out-of-pocket system with only few accepting private insurance. So you're talking about patients who might go to a public or government-owned hospital that can provide the service but is not providing it because they have lack of material. And the material is present in the private hospitals, but if the patient arrives there and cannot afford to pay out-of-pocket, he will not get the treatment. If we say that the average household in Egypt income is about 25K in Egyptian pounds, a thrombectomy costs 200,000K. So it's extremely difficult to pay out of pocket for most of the population. And if the patient is going to stay for a long time in the hospital and go to a neuro ICU and do some rehabilitation, it's going to cost him around 400K Egyptian pounds, which is extremely expensive for the average Egyptian. As I said, the government, usually hospitals run out of the equipment. Most hospitals don't have biplanes, so most of the neuro procedures in Egypt are done on monoplane suites, angio suites. Stent retriever thrombectomy is much more common than aspiration. Egypt is primarily solitaire land. Most of the material is the solitaire. Some trivos, but mostly it's solitaire. We don't have balloon guiding catheters. We only use 8 French guiding catheters. And if we get balloon guiding, if we get aspiration catheters, the only one that sometimes are present are the Sophia. The other thing is the neurointerventional training. I'll come back to it, but I just want to say that in neurointerventional training, a lot of young physicians want to go into the stroke business with so little training and just imagining that treating a stroke is treating an M1 occlusion in a patient with good vessels, that it's a procedure you can do in 10 minutes. But in real life, it's not like this. So I see it in a way that if you're going to go into the stroke business, you have to be trained in all INR, all neuro-endovascular procedures, and you should have a good training for it. For example, you often encounter tandem lesions, and in tandem lesions, usually we just dilate the ICA origin to go inside, do the thrombectomy, and we stent on our way out. Another situation that we can face is resistant tough clots. Here there was a carotid termination occlusion, and then we used 1 solitaire, ICA, MCA didn't work, 2 solitaires, MCA, ICA didn't work, and then double solitaire, ACA and ACA, and we could get the clot out and have a complete recanalization for this patient. Another situation that you could face is occlusive dissections. Here we can see that the petrous segment is completely dissected and there's complete carotid occlusion. And our ability to pass through this dissection with an 8 French guiding catheter, we can see that there is also an occlusion of the middle cerebral artery where we did a thrombectomy, and on our way out, we placed a stent all the way in the petrous segment, a carotid wall stent from the petrous segment downwards, and we can get a good result for this patient. Another situation that we can face are distal thrombectomies. Here we were trying to do a balloon angioplasty and stenting for a carotid termination severe stenosis. You can see the image on the left side. As soon as we inflated the neurospeed balloon, we had an occlusion of the anterior cerebral artery. And then here we can see that we have an occlusion at the A2, A3. And we don't have distal thrombectomy devices. We only use solitaires. And in this patient, we passed with a rebar in the A1, in A2, A3, and then half open the solitaire, and then we can get a good result of complete recanalization. And there are other situations that you cannot name. There are uncommon situations where you have to think out of the box. Here there is a complete basilar occlusion, and whatever I could do, I could not pass through the occluded segment with the wire. It was not possible. So we took access from the anterior circulation going through the PCOM down to the basilar artery where the wire passed very easily. We did a small dilatation with a 1.5 millimeter balloon, and this allowed antegrade passage of the solitaire and the rebar and the solitaire, and we can get a good recanalization. So there is no one hospital that has a large enough volume to train neurointerventional fellows. The training in Cairo and most of the Middle East is in the form of volunteer shadowing, what we call shadowing, where the trainees will shadow 1 or 2 mentors in their academic and private institutes. And due to the lack of high volume of cases, a lot of cases being performed in private hospitals, not in educational hospitals, where patients require the attending consultant only to do the treatment. So the trainees usually develop their first skills in body interventional techniques before going into neurointervention techniques. Finally, also we have a lack in the ICU and rehab centers. Thrombectomy capable centers are usually busy, and it is not infrequent that they might not have ICU available beds, hindering the performance of thrombectomy. So the tertiary centers are the most busy centers, of course, and then you get a patient with an LVO and there's no available ICU bed. And as I said, there are no agreements between hospitals to treat patient and then send him to another hospital. Physical and occupational therapy, as well as speech and language therapy, are not readily available in Egypt. And a lot of the stroke patients, after doing the thrombectomy, usually are sent back home to be cared for at their home with a special nurse or with the family members to decrease the cost of the nursing care. But the good news is we've been doing thrombectomies since 2014. In 2014, I did 3 cases, and then after the guidelines in 2015, we started doing more. Each year it has been almost doubling, except for the COVID period where it decreased a bit. In 2024, until June, 344 cases were treated in Egypt so far, and expected to reach about 700 cases by the end of 2024, which is again almost double of 2023. There's a lot more to do. There's a lot more to organize. There's a lot more to try to organize in different parts of the country to try and save more patients. But so far, I believe under the certain circumstances, we're doing the best we can. Thank you very much.
Where do we have the mic? Okay. Shall we have the coffee break or the presentation from Rene? Coffee break? Okay.
Okay. Ah oui. Bien. Okay. Bad news. No. Okay. Bad news. I don't know more. I'm waiting. I was just in Frankfurt and I'm going to city. Since then,
I made it.
it is what it is. We know this game. It is what it is.
Do I need this code?
What did I think?
You want to plug your presentation?
Yes, I think it will be better if we just take this.
Out of the book. Or just leave it.
Yeah.
But then you have nothing to do. Continue. Start.
Yeah, he'll die in the building.
I suppose it works. Okay.
5, 6, 1, 2. Пять, 6, 7, 8. Что там, закрыто уже? Что? А? Чего? А?
Nader and Rene, they will be online now. Yeah. So we are moving forward to the second case online. And Nader and Rene, could you please be so kind and maybe be the moderators?
Me?
Yeah.
I
Колонки.
moderate.
Ну, чтобы мы тоже слышали.
Yes. Come. So
Какие-то системы говорит.
where are we?
I don't
So
know,
it's
Orlando
Rene.
should be an Ahmed, but I don't know where they
Elvis Evo, c'est...
Она якой экономической сферы. Ага. Все хорошо, умники.
Yes, it's acute transmission now.
Yeah.
So we will start with Rene.
Yeah, with this one live case too, because they are like online, they said to me.
Okay. But nobody's here.
I don't know.
Так,
Should we ask for people to stop the coffee break and come? No? No bell like Luc Picard used to do?
But they are already online.
Yeah. So, Minzil, what is this case you're starting?
Ром, подключи, пожалуйста. Nader.
Yes.
Hello.
Hi.
I already wrote to the NeuroAddicts. We needed 20-25 minutes, maybe 20 minutes, and now we start the angiography, and there is a next presentation from Rene about Lvis, and then we will.
Okay, we will
connect.
start with Rene with his presentation. Lvis Evo, Rene?
Rene is there?
Yeah.
Okay, yes.
Yes, okay.
So,
Можно звук выключить.
okay. We need for this afternoon a bell, Minchil, to tell everybody when the pause is finished.
Okay.
So Nader is asking everybody to join. Sorry? Okay, I will start. This will make, and people will come progressively. So, some thoughts on the use of coils. Which type of coils to use when aneurysms are being treated? And is there a difference when using regular coils that are made just of platinum or coils made of platinum and hydrocoil? And so platinum and hydrogel, which are called hydrocoil. Obviously, the goal of treatment of an aneurysm is to occlude the neck. And the best way to occlude the neck is to put a clip, because the clip is just on the neck. Even if I'm not referring patients for clipping, I think that it's the most logical treatment. So the goals of all coils are to allow placement of the coils at the neck, and to get only an endovascular occlusion of the neck only is difficult. We don't have endovascular clips. I had only this patient, it's the only one that I could treat, where you see the bilobulated aneurysm, where there is a little one here and a large one behind. And this patient, I intentionally placed only a very small coil at the neck, which indeed allow to cure this aneurysm. The problem is it's the only patient that I've been treating for aneurysms where something like this works. But the fact that this coil occluded the neck, the single coil, and this has worked, is probably related to the fact that this coil was a hydro coil with some gel that does more than platinum. So here is the aspect when hydrogels are being used with some neo-endothelialization, which is what we're looking for. So there are some studies in the literature. This is not a topic which is so new, comparing platinum coil and hydrocoil. Those studies have been made, I would say, in the last 10 years. And all the different studies show that there was an advantage in using rather hydrogel-coated coils. The first one was a HELPS trial, which was randomized, but the difference is never a huge difference. There is an advantage, 7% reduction in adverse outcome. Everybody would like to hear there is no recanalization anymore. Of course, it does not work. But I think to obtain a stable occlusion is a multifactorial point and not a single one. So you see that with hydrogel, there was less recanalization or major recurrence. Another study done in the US was gel the neck with the attempt to place a lot of hydrogel at the neck. The previous study, the amount of hydrocoils that can be used was highly variable. So some physicians use 20 regular coils and 1 hydrocoil, which is of course meaningless. Here in that study, most of the coils to be used had to be hydrocoils, specifically at the level of the neck. So 600 patients were treated and with different adjunctive devices with a rather high amount of hydrocoils. Even this could be 90% or not 50%. And the rate of occlusion was rather high in compared to what is obtained usually with regular coils. Here are some pictures, I would say for me, of the past, where aneurysms are treated only with hydrocoils and not with hydrocoils in combination to stents. And I was amazed to see that whenever there was some filling, this was completely gone. Here are a couple of similar pictures. You see immediate results. There's always some filling, but on the follow-up, you don't see at all where the aneurysm was. Here some larger aneurysms where the likelihood for recurrence is higher, and obviously there is something. Maybe this is interesting too. You see this MC aneurysm, where here is something which is still to be seen, but look at the follow-up. It's amazing to see that nothing left. This aneurysm today would of course be treated with a flow diverter. At that time, it's I guess 20 years old. At that time, it was balloon-assisted hydrocoil. This is the immediate result. The follow-up is still not what you see usually with regular coils. The last study I will cite is a great study where the criteria were adapted in order to show as much as possible differences, and finally, in compared to platinum coil, there is a reduction in, let's say, recanalization being major recurrence or retreatment for major recurrence of 8%. 8% is not perfect, but in the end, when you use coils, why not to use the one that work somehow better? And as there are no drawbacks in using it, that's why in our practice we use exclusively for aneurysms and only hydrocoils. Of course, it's multifactorial, and today the way to handle is to combine it with first assistance of a balloon to coil the aneurysm, and then through the balloon, since the stents that can be placed through the balloons are available since 2012, it's possible to close the door with a stent, And the combination of those techniques with the hydrocoils and with the stent is the one that allows the highest level of stability in our experience. So here's an old evaluation. You see 2 years control just after we started to do this. But we found out that the level of complete occlusion of at 1 year is much higher than anything which is published in the literature, 90%. And now we have some later follow-ups. The problem is the amount of data has become very important. So I will show you just study on the patients with superior cerebellar aneurysms, where we checked, and I'll show it to you. Before I want to share this patient here, because, oh, you're not supposed to see the name. This patient, I treated her the first time in 2002 for this superior cerebellar aneurysm that I coiled, where it looked rather well occluded, even if it's not perfect. But in fact, what you don't see on this picture, that this aneurysm has 2 compartments. The first compartment, which is here, and the second compartment, which is thrombose, which is pushing on the chiasma. And after this first treatment, of course, partially thrombosed aneurysms always recur. And this aneurysm recurred. And the patient being not that young, she was recused for further treatments. And in the meantime, I changed hospital. And I saw her 3 years later when she was almost blind. And it's the only patient that told me, it's the only one that told me, whatever you do, if you can do something, do it. If I die, I don't care, but I don't want to live like this. And it's probably 20 years ago also, but I still remember it because usually patients don't say, if I die, I don't care, I don't want to live like this. And the reason was I cannot watch TV, but worse, I cannot see my grandkids. So she was 72 or between 72 and 75 at that point. And the treatment that was done was here, further treatment with hydrocoils in combination to a braided stent. And this is a treatment with 1 month follow-up and 5 months follow-up, showing a minor recolonization at 1 year also that was also treated. But the amazing thing is that she recovered vision. So the ophthalmologist wrote to me and told me it's the only patient that I know that was blind and who is able to see again. And then she's from France, she came to Germany a couple of times with her husband, getting older, and then when she was 80 plus, the trip was too far away. Her husband passed over, and I had the surprise to see her last year. And I saw her at a sad event, because it was for the funerals of my mentor, Professor Merlan. And at that point, this is the patient here. So here, she's 95 years old. She sees very well. And she told me in the meantime that she connected to Professor Merlan, him, and that in his last years and months when he was deteriorating a lot, she gave him a phone call every day to say, hello, how are you doing, to support him morally while he was getting older and disabled. And she said, yes, I'll do it because one of the persons that trained from you helped me, so I'm helping you. Isn't it amazing? And the most amazing that she recovered vision. She could see very well. And I don't know why she did see well. I mean, she did not receive a flow diverter, but she had a combination between a braided stent and hydrocoils. And the aneurysm obviously did not continue to grow, but must have shrunk. So maybe I'm biased by this story, but I don't think so. I'm going to share with you the result also of the SCA aneurysms, where probably there's a difference if you consider the smaller and the larger ones. The smaller ones are not a problem. Here is typical SCA aneurysm, where The problem here in the treatment of those aneurysms is how to make sure that you want to occlude the SCA. I mean, the artery at risk is the SCA, not the basilar. And the usual treatment for those patients is to place today a flow diverter, because anything else is complicated. The problem is that the flow diverter is reducing the flow in all arteries that are bridged. So both SCAs and the contralateral PCA are being reduced, and is the reduction of flow sufficient to allow cure of the aneurysm? I'm not sure. I even think that there are some situations where we saw that it's not, and this technique here works. So it's efforts. You must find a way to get a balloon inside. Then the aneurysm is hydrocoiled. And in the end, we place a stent in a fashion that we call half-T stenting. I don't see it here, so I will show you other examples later on. And here you see the follow-ups are amazingly stable. Yes, the stent is being placed from here, just ending at the origin, at the junction with the basilar. And same thing here, they all are really the same with this difficult angulation. So how to get inside here? Microcatheter must be over curved in order to be able to go there. Once access is being achieved, which is a challenging step, a wire is being placed in the SCA, an exchange maneuver being done, a balloon is being navigated. So here, oh, we have the procedure, so good. Here is the microcatheter, which is being overshaped. You see, otherwise the microcatheter is never doing this, it's always going up. But when it's already overshaped like this, it makes it much more easier. And here we've got an access to the SCA. Then a balloon is being placed there. Whether a second balloon is needed, usually not. The only thing is inflation of this balloon here has tendency to push the microcatheter from the aneurysm to the other side. So that for stability purposes, it makes it very comfortable to have a second balloon so that the microcatheter is being held by both balloons pointing to the aneurysm, like this. And then once the aneurysm is occluded, a stent is being placed. Why not to place a stent before? Because the stent would extend inside the aneurysm, preventing the coiling ability of the aneurysm. So that's the result. And here are the follow-up. So half-T stenting of the SCA we've been doing now in a bit over 50 patients. Oh yes, the second balloon is more often than I thought. It's 80% and not 50%. Using a braided stent, because the braided stent must be visible, point 1, and point 2, it must be possible to resheath, unsheath, and to change the position of the stent. So an atlas is here more difficult. We don't have the same level of precision. And you see that the follow-up after 1 year is 94%. It's almost none of those aneurysms that reopened. We had one ischemia, one silent occlusion. I mean, the results are really good. Here, double lobulated aneurysm. Again, access, microcatheter is in place, balloon is there. Here is the coil, and look at this other picture. It's amazing. You see that this aneurysm has no neck, but that the coil is wrapped around the stent, which is here. For the aneurysms that are more than 10 millimeters, like this, the problem is not only the stability, but the compression of the brainstem. And what you don't want is that aneurysm continues to grow, because it becomes very rapidly highly symptomatic. So here is a 4 days follow-up, 12 months. And in situation where there is some recurrence, then a flow diverter is being added, with the drawback that the flow diverter can create ischemia. Here's the two, oh sorry, this is, in this patient here, a treatment, I start here. We did not treat as I just showed. We just placed flow diverters, saying the flow diverter is there, it's great. is going to solve the problem. So we just put a flow diverter in the basilar. This is the initial aneurysm. The result after 4 days is much better. So yes, we are on the way to cure the aneurysm. Great. But you see that 12 months later, it's reopening. So another flow diverter is added in the second one. Because of the addition of flow diverters, here we had some thrombotic issue, where then you see that both SCA are missing. So of course, all medications to reopen the stent and the arteries were given, but because of this retreatment, some ischemic issues occurred. And after 2 years, where the patient has been seriously disabled, you see that there's still some flow inside the aneurysm. And this is here another patient which we treated at this stage together with Ahmed, where he received 10 years before a first flow diverter from the PCA to the basilar. 4 years later, a second flow diverter. And despite this, the aneurysm was growing with a huge aneurysm compressing the brainstem at this stage. So the ability for a simple flow diverter to do the job is not good. Don't rely on this. So to avoid this, there are some large and giant aneurysms of the SCA where I think that we must modify the technique. Here is this patient who is a conductor with a progressive hemiparesis, and we can understand why he has this hemiparesis, where the aneurysm looks mostly thrombosed. Here is the SCA. So we first coiled and stented the SCA. I'm absolutely convinced that those type of aneurysms, before a flow diverter is being placed, because this will be done at some point, must be hydrocoiled and the SCA must be stented in order to control the SCA. And some weeks later, not in the same phase. I'm not sure whether we can do it in the same step. I fear that if we do it in the same step, the chance for the stent that has been placed here to thrombose is quite high. That's why we wait a few weeks. If it's done in a second stage, we never had a thrombosis. When we do T-stenting, that one braided stent covers the other one, we had a 10% rate of thromboembolic issues. So this is a very important difference. After 6 weeks, he got a flow diverter, and this is a follow-up after 6 months. The aneurysm shrunk a lot. And a couple of other situations here where here's the issue, how to get access to the SCA. We had to go through the aneurysm with then coiling and stenting inside, with the T-stenting here that was achieved. So I will go to the conclusion if I find it. No, I did not prepare a conclusion. So the conclusion, yes, is that there is obviously, there are many reasons for aneurysm to recanalize. One of this is the type of coils to be used. Platinum coils are biologically inert, which means that if a coiled aneurysm is retreated, if you take the microcatheter, you can enter the cast of coils. This is quite amazing. If it's hydrocoil coated coils, hydrogel coated coils, you cannot enter the cast after. Something else happens, and the chance of stability is higher with those coils in combination to other factors. Thank you.
Thank you, Rene. I have a couple of questions. First one, when we started to use the hydrocoils years ago, we had some issues about hydrocephalus. Remember that? It
Yes.
was a few years ago. So this is my first question. What is your experience actually with this complication? Second question, they had tendency more to have thromboembolic manifestations coming from the coiling. I don't know why. We used to have some maybe detachment of the hydrogel that goes in the circulation. So doing MRI after, sometimes it was symptomatic, not, but you always see some hyper signal on diffusion in the white matter. So what's your experiences with this?
So two very good points. First point, the issues with hydrocephalus have been reported the first year. There were 3 cases that were reported by the Rothschild team, and since then there have been no others.
We had also.
So I think, okay, so maybe others, but very few, and since that time it's completely gone. So it was at the beginning of microvention, almost crushed that startup down. It did not, obviously, because now not microvention, but neuro is doing well. But obviously it did not happen. Maybe it's related to the change in how the coils are made. And now I go to the second point. Initially, the coils were achieved in a very complicated way. There was a primary coil, then there was a tube of hydrogel placed on it, and then there was another coil around it. So there were 3 layers. And those coils were called HES, and the amount of hydrogel was much higher. Today, it's the wires that prevents the coil to elongate, which is inside the coil, which is a wire made of something with hydrogel. So that at some point the hydrogel goes through the coil itself, but much less than was initially. And I think that this solves most of these problems. I mean, either a more thromboembolic issue, the studies that have been done show that randomized prospective studies, there was no difference in the ischemic issue.
Thank you. Any questions from the audience?
Hello, hello. Can you hear me, Nader?
Yes, yes, yes. We with you.
Yes. If any questions, yes, it's a nice talk on hydrocoils, and there is another technology from microvention, yes, and we're trying to show you now. Can we continue, Nader? Any questions from the auditorium?
Not really. No questions.
Okay.
We were following you. Where are you? Can you explain to us what you're doing now?
Okay. If there is no questions, HydroGel it's a very nice technology. Rene, I agree. And in Kazakhstan, the additional price for the coil is nearly from $100 to $200 for each coil. That's why we're using regular platinum coils. But yes, it was time when the microvention distributor, Midcore company, brought the HydroGel coils, and I really liked the idea. We can place the regular coil, then in the middle we can place the HydroGel coil, and it was feeling that the long-term follow-up and recanalization rate is really low in those patients. In this case, patient has several aneurysms. Patient has a microaneurysm on right MCA territory. It's an unruptured case. You can see the small aneurysm on right MCA bifurcation. This is for the second treatment, not for today. And there is a small ACA, hypoplastic on the right side, which is good, And if there is any problem, then we can rely on this hypoplastic ACA if there is problem on the Acom territory. Vertebral basilar system is okay. And on the left side, так нам положил, что вот, или уменьшить надо? Yes, on the left side, we can see the Acom aneurysm. It's nearly 5.5 millimeter, and it's a round shape. It's okay. We especially found this aneurysm for our web. It's only one size 7x3. Yes, comparing with the European countries, we need to find the patient for the device, not device for the patient. But it's okay. And there is it looks like small aneurysm on left MCA bifurcation, maybe lower branch. You can see on the lateral screen. And we tried to do several projections, and the neck of the aneurysm is really invisible. And then we decided to do 3D angiography. Yes, in most of the centers, this is the start of the treatment. In our situation, sometimes we do not do, we did not do so much 3D. If 2D is accurate and on Philips, we finish with the 2D. But in this case, yes, it's a web first, and it's a Toshiba. You couldn't see the lateral screen. Then another angiography, nothing visible. And then I decrease the magnification. And this is the working projection. Yes, this aneurysm could be coiled. Option 2, balloon assist coiling. And I think in essence, it would be double balloon assist, kissing balloon assist coiling, and then stenting. Or it could be stent and balloon assist coiling and placing the stent at the end, detaching the stent at the end. And it's also possible to place a flow diverter stent on the left side, and the right hypoplastic Acom will grow and aneurysm will shrink. But also there is option to place intrasaccular device, which could be contour, web, or there is one more new intrasaccular coming from Israel. It's a Lucid device. But now we have VIA 17 inside the aneurysm. You already saw the navigation of Scepter 4x15 in left ACA territory with Traxes. 14, the guiding is launcher. It's a coronary guiding aid French, Judkins right. And yesterday I showed to Alberto and Orlando how we are modifying in Kazakh manner. And via 17 inside the aneurysm, now I will ask for web 7.3. Web Tashkent, Zamir. And this is a position of the microcatheter inside the aneurysm. Nader, I know you have experience with the Luna, with the Artis.
Minjil, you say you placed the Scepter balloon. I'm not experienced with intrasaccular devices, but I guess you placed it to try to redirect your microcatheter while placing the web, or what's the reason for the balloon?
Rene is in the room, and I was visited Essen in 2012, and I prefer to have a balloon in place for any unexpected occasions. It's like a second parachute, but it's also like condoms. It's a very safe sex endovascular.
So it's for safety, not for redirecting or trying to direct the microcatheter while placing the web? Huh?
It's only for safety, yes.
Okay.
Safety first.
Do you do antiplatelets if you are planning to do a web, or routinely in case that you need a stent after or change your strategy? What's the plan? Normally, what do you do?
Yes, Orlando. It's an elective aneurysm, but also if we see wide neck aneurysm in emergency, we are giving antiplatelets. Usually it's a ticagrelor or 180 milligram, and the same in this case. we gave ticagrelor 180 milligram loading dose, and then we continue with 90 milligram. And if no stent needed, then we can take out the anticoagulation and we can leave the patient without antiplatelets.
Yeah,
Okay, now web is inside the aneurysm and starting to touch the dome of the aneurysm. And it's opened. When it's opened, it's became soft. And my microcatheter is staying at the neck of the, at the neck level. Okay. Now web, Jojo, let's go. Now web already in place. Maybe we will do 3D rotational to see the.
So Minjil, as I told you, I don't have any experience with intrasaccular devices. Can you give us an idea about how do you size the web you're using?
The web in this case oversized and it's 7/3 and the aneurysm is 5.5. I think Islambeck is already measured the aneurysm.
So you usually oversize to do intrasaccular?
Usually oversized, and it's preventing, it's a recommendation from the company.
Okay.
When you oversize, then the canalization rate is less.
Yeah, definitely oversizing. One of the problems with the web is recanalization, and then oversizing is glue. And at the beginning, they recommend 1 millimeter. We need to, because it has to be well opposed to the artery, and now it's 1.5 or even 2 millimeters. And then we decrease the height. So that's glue.
So
the other thing with
oversize the width, but you decrease the height.
Yes.
Okay.
And then at the beginning, we oversize 1 millimeter. We try to oversize 1.5 or even 2 and decrease the height. And the question for the balloons, the balloon also, if we inflate the balloon, we can position the web better, because doing the balloon after the web to reaccommodate is not possible. So when the web is deployed,
Ahmed,
yes.
Orlando, Ahmed, now I'm inflating the balloon, and we will see how is the balloon is inflating, and we may check the artery patency, and the artery is patent, balloon is inflated, and web is not moved. It means the web already inside the aneurysm, and everything is okay. When you're using balloon for the navigation of the device, then you need to inflate before the placement.
Yes.
And after placement, the balloon will never change the, I hope it will never change the position of the device inside the aneurysm.
I think, Minchil, it's a very good idea to use the balloon here to control the position of the web, because from what I see here in the room, you must have a better image quality, but I find it's not easy to determine exactly where the device is. And there are machines of different quality. You mentioned just before that this is rather for body interventions. I think that if you're not having a high-end neuro-angio, it may be not easy to see the web, so that you compensate this lack of visibility, of vision, by inflating the balloon and seeing if something is being displaced.
As now on AP, you can see the balloon and separated web, and the image quality the same as you see in the conference room. The AP tube from the installed period, it's 5 years old tube, and the visibility is not so good, but it's okay. We can control on lateral the reference screen. I hope you see the same.
Yes, we see the same. I would like to add another advantage of the balloon is when you release the web, if you inflate the balloon, that you are sure that the web, sometimes it can protrude from the aneurysm. This is one point. And the second, with the double lumen, you can always use right away a bailout stent if ever the web is protruding inside the parent artery.
Yes, it was the idea, Nader. Yes. If there is
Alberto.
any problem, we can place the stents through the septum.
Sure. Alberto
Yes.
has a question or comment.
Mingil, Alberto.
Yes, Alberto.
That was my question regarding if stent or not afterwards. At the beginning, the company said that the main advantage of web was that you don't have to put the patient under antiplatelet, which of course we all agree that is a main advantage. But more and more, and I think the current recommendation is to do double for at least 1 month. And for stenting, we are putting the patient under double for 3 months, which is not much more, only 2 months more difference. And that was my point. If the problem, as Orlando said, is recurrence, recanalization, why not to put the stent after deploying the web? Apart from the price.
Yes, it's a good comment, and we will closely follow this patient, and if it's needed, we can place stent in second step. It's so-called step treatment, and the other point is dictating this kind of approach is a financial support from the healthcare system. They're covering, for this treatment, the healthcare system will cover only 80% of the treatment. The web is a little bit costly, but the previous patient was paid well, and in 2 cases, we covered both. It's a principle of our healthcare system. It's a socialism.
What a comment concerning Alberto. We have to make a difference between a rupture.
And now we will detach the web. Okay. I hope it was detached.
Talking about detachment, the previous generation of web, there was a lazy detachment. Sometimes we try to detach, and there is a percentage that was very difficult and was a nightmare. Now they have corrected that detachment zone microvention, and the new generation is it's unusual to have a lazy detachment. But this could be a potential problem when we are in a nice position and then we need to retrieve the web because it's not detached. Now we see that less and less.
And sometimes the proximal end of the web stays inside the microcatheter. Yes. So you have to push a little bit the wire to be sure that it's not attached.
It's okay. It looks like okay. Okay. Yes, now we will do the control CT, but I think everything is okay. And if there is no questions, or any questions, Nader, Orlando?
Yeah, I have a question, but Alberto
Well,
also.
my last question is, the balloon seems to be a good, reasonable alternative to control the branch that you don't want to get occluded. But in this case, it seems that even if right A1 could help in case of occlusion of the Acom, it seems to be very small. And I mean, when you inflate one balloon in one branch, can it be that the web protrudes into the origin of the other branch? You know my point? You understand my point?
And then, Alberto, we can navigate with VIA to the second branch and place Credo in second branch.
But do you think it could be possible if you inflate a balloon and you don't leave to open the web in this branch? And if the protrusion occurs in the neck, it can go to the other branch.
But the other option, we have hypoplastic A1, and I think it could be okay.
Our other option could be double remodeling.
Yes, double remodeling also okay. Okay,
Minzel,
the web
I have
in
a
place.
question. I have a question, Minzel.
Yes.
You said this is a ruptured aneurysm?
It's unruptured aneurysm.
Unruptured aneurysm. Okay, if
Yes,
it's
it's
a ruptured aneurysm, would you put this patient under double antiaggregants?
Yes.
Because there is still circulation inside the aneurysm. It doesn't. It's not like the coils. It doesn't occlude right away. So, would you feel comfortable with double antiaggregants in a ruptured aneurysm? And if ever you want to put an EVD, how you would do?
Another, I think there is another possible option. It's a modification of sandwich technique. It's also possible to place a microcatheter between the web and the aneurysm wall and inject a little bit liquid embolic inside the web device.
What embolic?
I think
Which
Rene
embolic?
has more experience in this.
Which embolic? Which one, Minjil?
He's talking on
Squid 18, I think, will be okay.
And you do this with balloon protection, or you do it without balloon?
I think there is no need for balloon protection because web is like a flow diverter stent at the neck, and it shouldn't be any leak from the aneurysm side. It's just theoretical. I never done it.
You didn't do it?
No.
No, okay.
For rupture cases, we don't use dual antiplatelet in Houston. It's better to have a bad embolization and bring the patient back than trying to put a stent and then limit it, the VP shunting or anything like that. So basically, if this is a rupture, we're ready in case we need to leave a stent. Because sometimes move or sometimes it's not perfect. But for rupture aneurysm, we don't do any antiplatelet. We put the web and we do a follow-up because there is a highest risk of recanalization anyway with web.
May I?
Okay, I have a friend, Siba Dalai in India, and he's placing stent in every ruptured aneurysm.
Mijil, it's Vlad. Just to say hi. And I was wondering what's happening with the contour in Kazakhstan by the size, position, and form of this aneurysm. I find it perfect for contour and no balloon need. What do you
I
think?
didn't recognize the voice, sorry.
Vlad, it's Vlad. Vlad Gavrilovich.
Ah,
I have
Vlad,
just right,
hello,
yeah.
it's Italian accent,
Yeah.
yes, right. I see. Yes, Contour is not yet available because Contour is now the product of Stryker.
Yes.
And Stryker is coming to Kazakhstan through the Russia. And the current geopolitical situation is a disaster, and I think this year, maybe next year, it's not the time for Contour.
Okay.
Yes.
I have experience with Contour, and my follow-ups are not really good. I have also inversion of the contour inside the aneurysm or migration of the contour inside. So the few cases I had to use it, now I gel a microcatheter, a headway duo, and I coil. I use it as a stent, just at the neck. So I deploy the contour, I gel, I put some coils and then detach it. But I prefer personally the web, even if they recanalize also. Huh?
Yeah. The fact is like the position of the sac, the form of the sac, and the diameter of the aneurysm. I also use those that Coco Jumbo technique, quindi mixing the coiling and the contour. But by the size and by the position of the neck, I found it very, very adequate treatment for this kind of aneurysm contour. And yeah, it has some recanalization rate, of course, but also it depends how the contour is deployed and the size of the device respect by the sac. So
you have a lot of protrusion inside the parent artery with the contour because you have to oversize it a lot, so it protrudes inside the parent artery. And I have some serious thromboembolic complication with occlusion of one of the branches, and I had to put a bailout stent. It's, for me, at least the web stays at the neck. It doesn't protrude inside.
Okay.
So
Those
this is
are,
my
different
my
experiences.
personal experience.
But I had some very nice cases, and that's the reason why I asked about this. We're still speaking about the personal experience.
Now that the company has been sold, it's interesting because all the complications come out. Before it was only good, and now we hear that the recanalization rate is important. I did not hear about ischemic issues before, but it's an interesting information.
Maybe a small comment from my side. So we review the images for the next study in the US. Obviously, I cannot talk about it. Yeah. No, nobody's listening. So I'm not concerned, let's put it this way. So I think maybe there's, like everything, you have this hype phase, and then there people are a bit more sober, and then they learn how to deal with it, and then, so I think it's not as bad as it sounds. And I can talk about the first 2 studies in Europe. They are published, and we had a very detailed look on the cases, and the results were good. Awesome. So it's not terrible, the whole thing, but I cannot say more than that.
Can I just a small comment? Because I found it very, very interesting, the way the discussion went. The idea of using an intrasaccular device to begin with is that you get inside, you have a proper sizing, you play with it, you take your time, and you detach the device. And the way that this discussion went, I mean, I didn't know what's the end. If you need the balloon, and then at the end you need the stent, and then he was talking about a liquid embolic, then why place an intrasaccular device? It beats the purpose.
I found this is a very interesting comment. We have another debate that may be open, which is that there are now different saccular devices between contour, web, and artis. And I wonder whether the newest is always the better. Because it seems that now there's a new one, and you see a shift among operators to go from the old one to the new one. So it's new, it's better, but that's not serious. Come on. We need to have some data, and I wish operators at some point to stick to a device and not to change all the time, otherwise I lose confidence in what is good. Must it be the newest which is better?
I think you're right, but some cases, but really some cases, can be beneficial of the new devices. If you can coil, you go for the simple technique, but I think I had to treat a pyramidal aneurysm of the Acom.
It's normal, you're Egyptian.
With mango. So I couldn't coil because coiling, it was a ruptured one. Coiling used to come down in the Acom. So I think in this case, for instance, a contour can be beneficial because it will make a good basket at the neck, and then you coil also. I never leave it like this. So I think for every case, you can find the special device. You must not generalize, okay, I'm use all aneurysm intrasaccular. I think this is my philosophy.
Which means that at some point, just like coils are available from different manufacturers, and except hydrocoils, all are made out of platinum. So then it's efficiency of the detachment system and the stiffness and the ease of use. But you reach a level where they are quite more or less equivalent, and probably will have something equivalent for endosaccular.
Yes, Nader, can I speak?
Yes, sure.
No.
Yes. We already finished 2 cases. Till the 30 minutes we have till the lunchtime. And it's a technologies, it's a NeuroSpeed with Credo. It's a web device, and we have time for discussion. And I think with the coiling, now we could continue the coiling process, but yes, the coiling is important, and it's very important to know how to deal with different kind of devices. And if it's available in the country, it's also good. And this was the web number 4 in Kazakhstan. Yes, and I think for the case number 4, the placement is quite easy, and thanks to the engineers, R&D, developing the devices, and with them, our life became easier. This is Islambek, and now he finished his patient for today, and will join you at the lunchtime and at the Presidential Center. And after case number 3, Islambek will bring Alberto and Rene to this Angio suite. See you. Please continue the presentations and enjoy the conference and Astana. Thank you.
Thank you, Minjil.
Thank you, Minjil.
So maybe Rene, you want to continue, or Senta? I don't know. Rene, it's your AVM.
J'ai pas encore fait Lvis et Beau.
Tu veux faire Lvis et Beau et on fait les mots après?
Comme tu... Oui, peut-être Lvis et Beau, oui. Okay, so let's continue. Here are some infos on the Lvis Evo and the studies that has just been done, which is called Sealant. So the Lvis Evo is a braided stent. There are 3 braided stents on the market: the Baby Leo, the Leo and Baby Leo, according to the size, the Atzero, and Lvis, which has been existing for 12 years and which has been changed. There was a first evolution, and now it's a second evolution, and it's probably the most important one. And I would say before the Evo, the Lvis was the stent which was okay, but that did not open always very well, and it's changed now a lot. So some general info, maybe here, for those of you who don't know it, it's made now out of DFT wires, so wires with a platinum core, so that the stent does not need specific markers, but you see the all over stent as, can I have my mouse? Yes. You may see it here quite well, and of course it's important to be able to see when it opens. The last evolution also is on the flared ends. The flared ends used to be is a laser pointer. The flared ends used to be super long,
And then when you want to go with a microcatheter here, you always get in trouble. Now it's not an issue anymore. It's definitely an important change. But the most important thing here, I placed the old Lvis and the new one. You don't see this kind of pictures anymore. Here were the old markers, and you see that obviously it did not open. If you compare this diameter and this diameter, here is of course a difficult part because it's in the curve, and here it did not open. Now it opens without all those issues. Our experience, we use it a lot. I have some precise results on the first 100 patients that we checked very precisely, and you don't need to see this. Just that most aneurysms we treat, the highest amount of aneurysms we treat are MCAs. Where's the mouse? Here's the mouse. MCA aneurysms are the most frequent we treat. Mean size 7 millimeters, so regular size, and the balloon is more or less always there. Here is the post-op result, and you see that we obtained an occlusion. The follow-up at 1 year is 90%, and this is better than any of the aneurysacula we saw. So it's probably a bit more efforts to place in. We saw how easy it was to place in the web, but the results are just stable. And now we obtain, and since we have this combination hydrocoils and braided stent, we can say that we achieve the same stability than a clip, which was not the case before. And today, one of the justifications to keep on clipping outside of the economical issues, which may be in the world an important reason, but if there are no economical issues, the main reason to say patient must receive a clip is because of the stability. And it's being said to young patients, your aneurysm is difficult, it has a large neck, you should get better, receive a clip, because it's going to recur. And here today it's not the case anymore. Should we compress the struts? We change opinion with time. When we received the stent, we were quite willing to push on the stent, which brings the struts together, hoping to have even more higher compaction and density of the coil at the neck. The problem is, then it's impossible to get back to the aneurysm. So excessive pushing is not a good idea. Sealant is a study that has been conducted last year to see the results when using this combination of hydrocoils, Lvis Evo, and all coils must be hydros. I mean, otherwise it makes no sense. And this study has been done in Europe, mainly Germany and France, looking at the occlusion rate at 1 year, and now the patient have been entered. And here are some of those patients that have been treated, where you see here the aneurysm is coiled, the stent is in front of it, delivery is made. This is another advantage of delivering the stent after coiling. You can deliver the stent only for the purpose of stability of the result, not stability of the coils. The balloons makes the job. The advantage of placing the stent in the end is to do a CT, a cone beam CT, before the placement of the stent to make sure that inadvertently a bleeding did not occur. And once this is done, the stent is being delivered. Here are some examples. Here, this Acom, where we first had the balloon inferiorly, but it was not so good, so we displaced it, or we added a second one. And once aneurysm is coiled, the stent is being delivered, and you see that the stent here opens. That's the difficult portion. Here, I'm trying to move the mouse. Okay. You see that that part here is usually the one that is more difficult to open, and here you really have a nice level of expansion. So it's visible, it opens in curve. And the proximal detachment issue, this is with one of the products from the competitors, has quite often detachment issues that you don't have with the Lvis Evo. We can place it in small arteries. Here an example of this pericallosal aneurysm, where these are not easy aneurysms to treat, because as soon as you have 1 or 2 microcatheters, when you make a control angiogram, you don't see anything. There is not enough flow arriving. So here's a balloon-assisted coiling. And at this level, you don't see any flow. So I thought, okay, it's good to place a stent. The inferior branch is without coils protruding. So I delivered the stent, even PTA'd inside the stent to be sure that it completely opened. And when I retrieved, it looks good. But when retrieving the microcatheter, it looks horrible. It's just a problem. I mean, horrible. It's not a good result. But interestingly, if you look at 1 year later, it changed a lot. So this combination made the job finally of hydros. Here is this inferior MCA with, again, balloon placed in the inferior division branch. A Comanche now placed in the superior division branch. Coiling is being achieved. And in the end, we delivered here the Evo, and you really can see that it opposes well despite the change in diameter. Here's 6 months follow-up where you see that there's an occlusion, and this occlusion is definite. It will remain like this. Here, a more difficult aneurysm, it's a trifurcation. You may see here that here is M1. Here is 1 division branch. Here is a second one. And here the third one. That's why 1 device was placed here, 1 device was placed there. Then the aneurysm was coiled. Then you see here how the stent is behaving. That's the result, where you have a complete reconstruction of the artery. Okay, some other example, some shortening of the stent after the balloon, before the balloon. Let me go back. No, here we are. Initially, the stent stopped here. And if you go through with the balloon, maybe you push on the struts, or maybe it's an overexpansion of the stent, where you see that the struts now are being pushed a bit more distal. Here's a 1 year follow-up. Those aneurysms are completely cured on a definite way. This also is interesting because how to treat this? The usual answer is to go on for surgery because MCA division branches are quite small. And you see that the aneurysm is extending. If you look on another aspect, it's the same aneurysm, but you see that it's involving the inferior division branch of the MCA. Here, this aneurysm, where a stent was first placed, but it was difficult to open it, despite the fact that he has a good ability to expand. It was not so ideal. So we had to push on the stent. You see the change here in positioning of the stent, taking me more proximal and pushing him more. And here, under assistance of a balloon in the other artery, the stent partially deployed, the aneurysm was completely treated. Finally, it was better, to take the stent off, treat with both balloons, and in the end, deliver the stent so that the stent would not protrude too much inside the aneurysm. That's the result. Another way to place the stents, which we do increasingly in this kind of anatomy, where the angulation between the temporal branch, or the superior division branch and the M1 is highly acute. How do you want to place a stent here? If you want to have a stent making those double loops, it will never do it.
So this is where we do an extended half T that we call now C stenting. So both protection devices are placed in the MCA in the division branch, the aneurysm is being coiled, and the stent is intentionally not only left in the division branch, but some proximal part is delivered here in order to be able to push the stent to the other side in order to have the stent going around, making here, I cannot use, here we see it, going around like this, making this C shape, getting from one branch to the other division branch. That's the result and the follow-up. Okay, and I'm going to make it not too long, this presentation. I'm going to switch to the, I'm trying to get things changing, but my mouse is not answering so well. Sorry, I have to disconnect. I think it's going to be better to use my mouse to change the slide. Otherwise, it's too low. The last one I want to share with you is this patient here. Okay. Do we have it? With this aneurysm. First question, so she's 50 years old, 58 years old, and can we, yes. Do you treat this aneurysm or not? You see it's a very small basilar aneurysm, so looking at the Angio, the answer should be no, too small to justify any treatment. Looking at the MR, the opinion changes. Obviously, it's a giant aneurysm, mostly thrombosed, and extending inside the mesencephalon. Hello, Guglielmo. So now we have to do something, and the question is to do what? So let's go back to that aneurysm. I go back to this picture. How to treat this giant, mostly thrombosed aneurysm? Should we do a stent and coil? Should we flow divert? Should we put two flow diverters? What is the best option here? When talking to colleagues, the first answer usually when you show an aneurysm today is to say flow diverter. The problem of this aneurysm is that it's already thrombosed. A flow diverter transforms a circulating aneurysm into a thrombosed aneurysm. There's nothing more to thrombose except a very small part, so it makes no sense. The best treatment is probably parent artery occlusion. But how to achieve a parent artery occlusion here? Is it possible? Maybe, because we have both PCAs coming from both ICAs. But how to make a parent artery occlusion here, preserving the SCAs? We want to get rid of this, occlude the basilar, and we want that the SCA come from the PCA. So the most logical way is to stent from the PCA to the SCA on each side, and then coil the basilar tip, which was quite simple on the right side. On the right side, we placed here a small EVO. On the left side, it was a bit more complicated because you see that the angle here is tough. So at some point, it was possible to do it. Here, we had to instant PTA also. And then we coiled that aneurysm. Here's some further instant PTA. Here we are. And I should be able to show you the 3 months follow-up. Already after 3 months, there's a button on the PAC system where when you change the date, you can see, you will be able to see that this aneurysm already after 3 months got significantly smaller. I must do it again. Yes, you see here it just shrinking and expanding when you change the date. So now we have a 1 year follow-up and it's almost gone.
So I think it was the only correct way to make a parent artery occlusion, but how to make a parent artery occlusion preserving the SCAs was to somehow find a way to protect the SCAs. So the EVO, in my opinion, is not only a stent. Because of the braided design, it has something like a flow diverter light. It's a braided stent, so like any braiding, it reduces the flow somehow with a high rate of occlusion and stable occlusion. Thank you.
Thank you, Rene. Any questions for Rene? I have a question. Sure. Orlando?
Rene, as usual, spectacular. I have a question. What is your personal opinion comparing in the practical world Lvis Evo versus Vista Silk Baby? So you can use the same type of the microcatheter. Lvis Evo have a kind of a flow diverter light, and maybe is Silk Vista Baby's strong flow diverter is not the ideal one. So why to use Lvis Evo if you have the capability to use the Silk Vista Baby?
I mean, the amount of wires is very different. The same difference is between Lvis and Fred. Maybe your question is why not to use systematically Silk Vista Baby instead of an Lvis Evo. I fear that flow diverters are more thrombogenic. We've had with flow diverters several issues with delayed thrombosis after 1, 2, 5, 8, 10, 12 years that we don't have with regular stents. So in regular stents, including the Lvis Evo or the Baby Leo, we stop at 1 year antiplatelets and we don't have occlusions. With flow diverters, we keep on antiplatelets because of those delayed occlusions that have occurred.
Rene, one question. Regarding restenosis, hyperplasia, I heard in one of your talks about this topic, about that you find more hyperplasia with Lvis Evo compared with other braided stents. Is it still in the long-term follow-up, or at some point it starts to disappear like in my experience it can happen with Baby Leo?
So it happens both with Baby Leo and with Evo, slightly more with Evo, but just slightly more. There's one interesting thing that I did not mention. The arteries that you bridge with the Evo, you have a tendency to have some endothelialization, just like with a flow diverter. A flow diverter makes it even more, a braided stent makes it less. I would say the Evo is something in between the Baby Leo and between a flow diverter. So that's an argument not to use a flow diverter, because when you bridge an artery, you see quite often some endothelialization and some progressive shrinkage of the artery which is being bridged. Why not to use a Silk Vista Baby in any distal bifurcation aneurysm? Because of the rate of occlusion of the artery which is bridged. I asked Isil, Sachi, and Saru are promoting flow diverters in bifurcation aneurysms. The rate of occlusion, which is silent, but still rate of occlusion of the side branch is something between 30 to 40%. This is the reason for me not to use these devices in those indications.
And one last question regarding sizing. I know that with Baby we undersize a little bit to let a stent open. What about Evo?
So in fact, if you consider a 2 millimeter Evo, it's just like a 2.5 Baby Leo. No, sorry, it's the contrary. There is no extra reserve with the Evo. So a 2 millimeter will not go up. contrary to the baby Leo.
One question, Rene. You just said that with flow diverters and bifurcation aneurysms, the rate of occlusion is around 30% of the side branch. But you also said it's silent. So
it's silent.
A lot of collaterals developed, so there's no harm to the patient and the aneurysms are cured.
It's true, but is the goal of our treatment to induce an occlusion of an artery? I mean, flow diverters have been developed for giant aneurysms so that we don't do apparent artery occlusion. So the flow diverters are being used in order to save the artery and not to produce an arterial occlusion. And when we place them in bifurcation, we know that very often we produce arterial occlusion. It's a kind of paradox.
Okay. Any more questions for Rene? Yeah.
You still have one more.
Hi. Sorry. So just one question. You know, with the baby Leos, we're used to pushing it a little bit. But when I do that with the EVOs, it crumples.
Yes, and I don't think it's an advantage because retreatment becomes a real pain. It's not because you compress the stent that it does not recur. We had some super tight compression stents with recurrences, and then you cannot enter. The only catheter that entered was a marathon. And the marathon is so soft that as soon as you push a coil to the marathon, it jumps out. So it makes retreatment much more difficult. Another one who stated this is Giovanni Slack, who makes Y stenting with Lvis EVOs, and he takes special care not to push too much, because if he pushes too much, it's so compressed that he cannot cross.
Okay, thank you. We move on with the next presentation. Professor Senta Frol will be presenting to us initiation of oral anticoagulation in patients with ischemic stroke. Please.
Thank you very much. So I will have a different kind of presentation, maybe very typical for a neurologist. So yeah, different than you are used to have the congresses regarding the interventional neuroradiology. We know that atrial fibrillation is associated with a very high risk of hospitalization, all the cerebrovascular and cardiovascular conditions, and also premature death. Approximately 37.5 million people have atrial fibrillation, and more than 50% of those are aged more than 70 years. The incidence and the prevalence of AF are expected to increase due to the population growth, aging, and then we also have much better prevention regarding primary and also secondary stroke prevention. So what is the biggest problem with atrial fibrillation? So the cardioembolic strokes, which are actually much wider. The patients are more severely disabled compared if the patient does not have atrial fibrillation. So it's important that we choose the most appropriate anticoagulant therapy according to the guidelines for prevention of stroke in patients with AF. We always have to put the patient on anticoagulant therapy. So antiaggregation therapy is a placebo, so anticoagulant therapy is the choice. We have warfarin, which is a vitamin K antagonist, and then we have the non-vitamin K oral anticoagulants, the NOACs or the DOACs, as you can read in the literature. So warfarin is actually a very old drug. It has a very narrow therapeutic window with a very long half-life and lots of interactions with food and other medications. And the NOACs are definitely regarding half-life and regarding the interactions much more safe. So we have thrombin inhibitors, dabigatran, and then we have factor Xa inhibitors. such as rivaroxaban, apixaban, and edoxaban. The NeuroAddicts are prescribed once daily or twice daily regarding to the type of the NeuroAddicts. We always have the standard dose and the lower dose for each of the NeuroAddicts. For apixaban, patients do need to have 2 clear indications that we can prescribe the reduced dose. Maybe just to mention that only dabigatran in a reduced dose was proved to be safe and effective in the randomized clinical trials. We don't have the data from the randomized clinical trials regarding the lower doses of rivaroxaban, apixaban, and edoxaban, but we are using it especially in patients who are older, who have like mild kidney dysfunction. The randomized controlled trials and all the meta-analyses have clearly shown that the NeuroAddicts are much more safe and much more effective regarding to warfarin. It is, I think, the most important thing that is to prevent a recurrent stroke when we are putting a patient on oral anticoagulation. And of course, the most devastating condition are the intracranial bleedings, which are absolutely less severe in patients who suffer them on the DOACs. Dabigatran in a standard dose was actually the only dose that was significantly more effective compared to warfarin in secondary stroke prevention. And all the guidelines recommend use of DOACs in secondary stroke prevention. The ERA guidelines say that all the NOACs or DOACs are comparable, but my thought is that in the era of antidotes, it is not completely correct. Data from the real world from the everyday clinical practice also shows that the lower doses are also effective, especially in the elderly patient. When we are prescribing anticoagulation in a stroke patient, we always have to balance between the hemorrhagic transformation when putting a patient on oral anticoagulation. And of course, there are very clear benefits because we are preventing a recurrent stroke. We have 2 scores. The one is the Chatzwas score and then the Hasbled score. But for the patients with stroke, they immediately get 2 points. So it is clearly indicated to prescribe anticoagulation in those patients. Adherence is very important. In primary stroke prevention, we know that it is very low. We've done a very huge analysis also at our department regarding the adherence in secondary stroke prevention, which was quite impressive. Up to 85% of patients have good adherence, which is, I think, very, very important. There are still some clear indications when we have to initiate warfarin. In a patient with a severe kidney or liver dysfunction, still the patients with the artificial heart valves, the studies did not show that the DOACs are more effective compared to warfarin patients with artificial heart valves. Then we have the patients with antiphospholipid syndrome and the patients with cerebral venous thrombosis. But for the last indication, the guidelines are going to change. We are also using the DOACs in everyday clinical practice. So the story regarding warfarin in cerebral venous thrombosis is changing. Regarding the kidney dysfunction, we always have to be aware when it is below 30. So dabigatran should not be prescribed in those patients. We have much more space for the apixaban and the rivaroxaban. Regarding the liver dysfunction, it depends on the liver damage. As I've already explained, the patients with antiphospholipid syndrome, so these are in the majority the younger patients, we are still using warfarin. As I have already explained, the incidences of recurrent stroke on DOACs or NOACs are very low, approximately 1% yearly, and the hemorrhagic strokes are even rarer, up to 0.1%. When we are dealing with a patient with an acute stroke, there are, I can say, like very clear dates when it is safe to initiate oral anticoagulation, because we know that the cardioembolic strokes are much more likely those patients will suffer intracranial bleedings, which are actually a devastating condition when we have a patient on warfarin. But regarding the DOACs, the situation changed in the last years due to the reversal agents. It all started with the dinner rule. It is 1, 3, 6, 12 days. These are actually the days when it is safe that we put a patient with acute stroke on oral anticoagulation. So if we have a patient with a TIA, we can put the patient the next day on oral anticoagulation. If we have a patient with a mild stroke, we have to wait 3 days. And if we have a patient with a severe or moderate stroke, we have to wait 6 or 12 days. And it is always important to do a control CT scan to exclude hemorrhagic transformation. So the dinner rule is also incorporated in the ERA practical guidelines, which are actually the same. So the dates 1, 3, 6, and 12. But before we put the patient on oral anticoagulation, it is mandatory that those patients are prescribed aspirin, and then we discontinue with the aspirin and put them on the oral anticoagulation. There are many studies running and also ended up regarding if it is better to put the patient earlier or is it better to wait. Up to now, we know that it is much better to put the patient earlier on oral anticoagulation. So in case of an acute ischemic stroke or intracranial bleedings on oral anticoagulation, we have reversal agents which are specific. We have idarucizumab and andexanet alpha. For warfarin, we are using vitamin K, which is a non-specific reversal agent, and PCC. So for dabigatran, idarucizumab is indicated, and for factor 10A inhibitors and andexanet alpha, maybe just to mention that it is not indicated for patients on edoxaban yet. So what is idarucizumab? It is a humanized antibody which is very specific to dabigatran with a very high affinity. What it is important that in the reverse AD study there were no anticoagulant or procoagulant activity, and it is very easy to use idarucizumab. It is as a bolus of 5 gram IV. So the efficacy and safety was proved in the reverse AD study. What is very important was the mortality rate, which was very low. It was up to 16%, which is, I think, a very low mortality rate if we are dealing with the patients with intracranial bleedings. So it was proved to be safe and effective in different kinds of intracranial bleedings. Andexanet alpha is a bit different antidote. It is a recombinant modified factor 10A. But the problem with the andexanet alpha is a procoagulant effect, so with the thrombotic events. In the Annexa 4 study and the sub-analysis, it was found that approximately 10% of patients suffered a thrombotic event within 1 month. And also the application is different. So we first give the bolus and then the 2-hour infusion. We have 2 doses of andexanet alpha, the higher and the lower dose. The dose depends on the type of oral anticoagulation and the last intake of the drug. So the efficacy of andexanet alpha was proved in the Annexa 4 study, but as I said, the problem are the thrombotic events. So therefore, we cannot use andexanet alpha in the cases of an acute ischemic stroke, but it is indicated in patients who suffer intracranial bleedings. The mortality rate in the Annexa 4 study was also very low. It was up to 15%, which was comparable to the safety studies of idarosizumab. What do the ERA practical guidelines on management of acute stroke say? If we have a patient on dabigatran and it suffers an acute ischemic stroke, we can thrombolize the patient after giving the patient the idarosizumab. We are using the idarosizumab every day in clinical practice, and there are very clear data that it is very safe and it is also very effective. If we have a patient on factor 10A inhibitors, we cannot give the patient the antidote and then thrombolize the patient. We've done quite a lot of research and also analysis regarding use of idarosizumab before IVT. Already in year 2021, we've done one study together with the colleagues from Greece. We actually put all the data from the literature together, and it was really a nice systematic review, and we found out that the rates of hemorrhagic transformation in those patients were very low, and also the mortality rate. So all those findings were consistent with previously published studies in non-anticoagulated patients. Above that, we proposed the standard operating procedures together with the German neurologists, and we've published it this year. So it's actually a very simple algorithm. If we have a patient on dabigatran and it suffers an acute ischemic stroke, and if we know that the last dabigatran intake was less than 48 hours, or if we have the abnormal laboratory exams or impaired renal function, and if we are uncertain about the last dabigatran intake, so we shall treat the patient with idarosizumab and then with IVT. The ESO guidelines regarding the intracranial bleedings on DOACs are also very clear. So for the dabigatran, we shall use idarosizumab for factor 10A inhibitors, andexanet alpha, and for the warfarin, vitamin K, and PCC. Regarding the mortality rate from the real-life evidence, we've also did this analysis in a systematic review. So the results were quite comparable to the reverse AD study. So the mortality rate was up to 10%, which is, I think, a very important message that we got from this systematic analysis. And this is exactly the right side of the algorithm. So if we have the patient on dabigatran, we shall treat the patient with idarosizumab. Regarding the andexanet alpha, I was actually the first author regarding the use of it in the cases of intracranial bleedings, again with the German neurologists. So the problem with the andexanet alpha is actually the price, which is much higher compared to idarosizumab, and then the thrombotic events. So there are still not, let's say, what it is better to treat the patient with the PCC or with the andexanet alpha, but I think that the guidelines will be very clear that we shall treat those patients with andexanet alpha, but there is a problem with the patients who need neurosurgery. There is no data regarding the use of andexanet alpha prior to neurosurgery, which I think it is very important because it was clearly shown that minimally invasive neurosurgery treatment is much more effective for patients with intracranial bleedings. And this was our proposed standard operating procedure. So for the patients on factor 10A inhibitors, if they suffer an acute ischemic stroke, we shall not treat them with andexanet alpha. we can thrombolize those patients if we prove that there is no anticoagulant activity of factor Xa inhibitors, which have to be specific regarding anti-10A for apixaban, rivaroxaban, or edoxaban. But for the patients who suffer intracranial bleedings on factor Xa inhibitors, we shall treat those patients with andexanet alpha. The results regarding the edoxaban are still not published yet. The Annexa E study, which was the last study that was done regarding the andexanet alpha, there were less than 10% of patients on edoxaban, and the results were not significant. So the guidelines still don't recommend to use andexanet alpha in patients who are on edoxaban, but we need to treat those patients with the PCC. So thank you very much. Any questions?
Thank you, Senta. Any questions?
Very nice, comprehensive present thing. Practically, as you have made us aware, the 2.5 apixaban is of no use. That's the word.
2.5.
2.5 milligram.
Yeah, we are using this dose when you have two criteria fulfilled. So the patient should be old patient. So it is indicated if the patient is more than 80 years old, if the body mass index or the weight is below 60, or if there is the kidney dysfunction. So you need two criteria to put the patient on a lower dose of apixaban. Otherwise, you need to put the patient on a standard dose of 5 grams.
Does it give adequate protection? 2.5 milligram BD twice a day. Does it give adequate protection? What your study was showing that it is not good.
We know that for all the other NOACs, they are not like half of the doses that are, let's say, efficient. But it was like in the randomized control trial that they used this 2.5 and then the 5. But I don't think that it is very efficient, but for the elderly patients, yes. I like to put those elderly patients on apixaban in a lower dose. Because what I think is also very important, we know that in the elderly, we have the gastrointestinal bleedings, and the apixaban was definitely proven that there is a lower chance of gastrointestinal bleeding compared to dabigatran or rivaroxaban. So I must say that I put lots of patients who are above 80 years on apixaban, definitely.
Second question was about the use of dabigatran through a Ryle's tube.
I did not understand, sorry?
Giving a dabigatran in a patient who is not capable of orally accepting the drug, is there some efficacy of the drug goes down when we use a dabigatran with a Ryle's tube, the nasogastric tube?
Yeah. So the dabigatran should not be used in patients with the nasogastric tubes, yes. Because it is a different package, and we shall prescribe those patients the apixaban or rivaroxaban, yeah. But in the majority, again, from my clinical experience, I work at the department when we have like lots of elderly patients with cardioembolic strokes, and I'm leading that part of our department. And as I can say, the majority of those patients are put on apixaban. Yes.
And the last question was about the patients who had suffered stroke, and we see an ICAD, but intracranial atherosclerotic disease, yes, in the territory of the stroke, and the patient is simultaneously having an AF recording also. Mm-hmm. So do we need these patients to put on an antiplatelet, antiaggregant, and the NOAC also?
Yes. If you have a clear AF, you have to anticoagulate the patient. But if you are also putting the stent, so it's clear that you have to first put the patient on dual antiplatelet therapy and the lower dose of the DOAC. We are usually doing like this for 1 month. We are putting the patient on a lower DOAC dose, aspirin and clopidogrel. After 1 month, we stop with the clopidogrel and continue with aspirin and the DOAC. And after 6 months, we only put the patient on a standard dose of DOAC because it was also proved for the atherosclerosis.
Thank you.
Okay.
Okay, thank you. Any more questions? Okay, thank you, Senta. We're gonna have the lunch break now, 25 minutes, and we return at 1:45 for another live transmission. Thank you. In another lecture room, okay.
Regarding the intracranial bleeding, so I will come later back.
Okay, but you have lunch. So we come back in 25 minutes, please.
Им, по-моему, не слышно, да? Так, можно будет нас картинку на экран вывести, пусть она идет параллельно. Идет, да? Somebody in the room? Hello?
Hello, Minjil, it's Ahmed.
Ahmed, now is the time for lunch break, and we are starting the live case, but it's just the beginning, DSA, and I hope in 20-25 minutes we can start the main steps. And
Okay, this is what I told
intracranial-
everyone, that we come back in 25 minutes.
Yes.
Because everybody's hungry, so don't go so fast, Minjil, wait for us.
Okay.
Okay,
We
thank you.
just start, and who is not hungry may continue to watch. Okay. There is intracranial stenosis on the ICA and the patient after stroke. And also there is a vertebrobasilar stenosis.
Okay,
with
take your
aneurysm on
time.
the
Take
left
your
side.
time doing the angiograms. Don't treat until we come back. Okay.
Okay.
Thank
Okay.
you, Minjil. Bye.
Окей. Звук можно выключить пока. Явно передний центр на жопу. Ну, хорошо. Передний? Передний. Это наша все. А, вот так. Все. Давай, он тут. Медленно. Слушай, сколько человек? А, пока продолжай. Ага. Назад. Звук идет? А, окей. Hello, dear colleagues. It's very interesting situation. Вперед. Окей, назад. Стоп, послай. Референс. Маска свисла. И референс свисла. Oldu mu? Так, сүренің дауысын сәл жай қоя сал, Замира. Сүренің дауысын сәл жай қоя сал. Сәл жай қоя сал, бірақ тұра берсін. Ага, все, давай. Ага, 14. Ага, назад. Ага, 14. 16 бересің. Он 18 бересің. Назад. Он 18. 20 бересің. Hello, can you hear me in the room? Кто-нибудь есть в комнате? Вы нас слышите? Казра показывай. Все, здорово. Все здорово. 20. А, все хорошо. Ага, 20.
Джилл.
Да-да.
Мы слышим, все хорошо видим, это Виталий. Мы все хорошо
Виталий,
видим.
рад слышать. Как прилетел?
Спасибо, все хорошо.
Там все на русском разговаривают или есть кто на английском?
Нет, иностранных коллег в зале еще пока нет, небольшое количество участников, но мы все смотрим, поэтому продолжай, нам всем интересно.
This is a case of intracranial stenosis, and patient had a stroke on the right hemisphere, right hemispheric stroke. And also patient has a right vertebral occlusion in V4 segment and nearly normal, looking normal left ICA territory and critical stenosis in left vertebral artery. And during the navigation of the microwire, which was Xeon blue, we had a wire extravasation. And now you can see the CC fistula. Yeah? But it's okay. It's possible scenario. Now I will place 3x9 stent in proximal cavernous, and then we can see what we can do in distal part. Maybe we will place Lvis Evo stent distally for the stenosis and for the assistance in cavernous sinus. Когда народ больше прибудет, я с самого начала все расскажу. Пока продолжаем.
Хорошо.
Yes, for more than 300 cases, this is CC fistula number 3. Yes, and it was another 2 vertebral artery extravasation, and in total, for 300 cases, nearly 5-6 scenarios like this. It's not possible to push the 3 millimeter stent distally. And my guiding is finished. It's a 90 centimeter max catheter from Boston Scientific, and it's a maximum. Okay, let's place stent here. Блин, медленно. Так, так, вот диаметрикс. Так, дальше. Altogether. Now we gave 6 atmosphere назад. And got 6 there. Now you can see the balloon. Назад. Okay. Oh. Alberto Gil. Rene, Alberto Maria. Alberto Maria. Назад, назад, назад. Стоп. Yes, and there is a problem with the pushability of the device, and yes, it's not going. Like, oh, alto version, 6 version. Stop. Назад. Коронаркада ешкім жоқ деді? Замира. Коронарная интервенцияда ешкім жоқ та? Еще раз, 6. Все назад. Ага. Фентанил істейсаңыздаршы. Хорошо. Значит, не чекай блоки есть. Yeah. Almost. Тоже был, по-моему. Yeah, was. Kick. Hello, colleagues. I hope you enjoyed the lunch.
Ланч пока продолжается, поэтому пока
Окей.
иностранных коллег здесь
Хорошо.
нет.
It's good, huh? It means you have a good discussions.
So if you want, we can discuss with you.
Yes, we can discuss. No
Yes.
problem.
What your opinion? Want to change the for distal access catheter in this case?
Distal access,
Yes,
yes,
right.
it's possible, but it will cut the length of drug-eluted balloon coronary, and usually distal access like Sophia Plus is 131, and you need to take out the Y connector with flashing system to place the stent in distal anatomy. Okay. It's also possible, Nazar. Also possible to use distal access. Then we asking the companies producing the devices to produce something special for neuro with lengths and etc. Okay. Now we took a Chikai Black with the narrow speed. Maybe at the end we will place a flow diverter stent in this segment. Maybe. Let's see. Okay, now we are in place. This is ICA, and it's quite strange. We did the angioplasty, and we could not navigate our narrow speed distally. Usually, it shouldn't be like this, but it's stucking somewhere. It's very strange. And I have no idea why it's not going distally. No idea. And our colleagues from interventional cardiology department also on weekend, and we have no access to the cardiology department. Usually Camus Balloon from Asahi or Tadzuna is doing all this job. Huh? София ма ана неде бір дистал аксес катетер жатқан, алып келіп бересіңші, Замира. Шкафтың ішінде. Okay. It's a good suggestion from Vitaly. Maybe we'll try to go with the distal access catheter. Okay, this is not working. Maybe distal access could be helpful. Maybe let's see. Lesions. Назад. Жоқ, София емес. Ана коробкалар бар ғой. Неге алып келген коробкалар бар. Шкафтың ішіне алып келші. Бер жағында шкафтың ішіне. Иә, қытайша жазылған коробкалар бар ғой. Ойлаймын. Ага, 8 бересің. Let's take to the count the real length of the neural speed, which is not 8, like on the box. Usually it's 15. We could not push. Okay. Let's take the neural speed out. And it's nearly kaput, huh? Okay. Take 1 second. No, out French.
Манжелки, ну, в принципе, больше, ну, собралось больше людей, поэтому можно, в принципе, как бы рассказать, наверное, всю предысторию.
Okay. Just a second. I will now change for the distal access catheter, and then I will explain what's happening. Okay? So, yes. Yes. Yes, this is a patient 78 years old with a history of stroke on the right hemisphere. And on CT angiography, we found, yes, the stroke was on the right hemisphere. Yes, it was a temporary temporary hemiparesis on the left side. It was right hemispheric stroke. And on CTA, there is a subocclusion of the right ICA, and which you can see also on angiography. Subocclusion of the right ICA. There is a tandem stenosis, paraclinoid and cavernous segment. And V4 segment on the right side is occluded. Yes, no lateral images, and critical stenosis on the left side, V4. And there is an aneurysm, dysplastic aneurysm in the basilar artery. And the strategy, left hemisphere is normal. Some irregularities, but it looks like normal. And then we went for the right side because it's a symptomatic part. And you see there is a subocclusion, and the plaque is not, it's ugly shaped plaque, ugly faced plaque, yes. And This is angiography, and then we took a neurospeed with the Xeon wire, and we tried to go with the Xeon, and at some point it was extravasation of the Xeon wire, and you see now the CC fistula. And patient under local anesthesia, we gave fentanyl and Acom. Then we went with the neurospeed, and we couldn't pass this segment with neurospeed. And after this, we took a 3-meter wire, we placed through the neurospeed from the cavernous segment, and took out the neurospeed, and we did several PTA with the 2x8 balloon we took from the coronary stent. Unfortunately, our cardiology department today is on weekend. There is nobody in the cardiology. And we did several PTA, CC fistula still in place. And now we are trying to advance the neurospeed balloon, which is not pushable, which is not pushable in that segment. Maybe I will change the 3 millimeter neurospeed for 1.5 or 2 millimeter neurospeed. 2 millimeter neurospeed, хорошо. And also we took a distal access catheter because pushing the device from the 8 French MAC catheter from Boston is not possible. And it's all the time protruding to the ECA territory. Now it's a Xeon wire from Asahi. It's a coronary one. And as you can see, there is a place, stent in place in this segment. And it's very interesting. I cannot push the balloon. It's a maximum. Yes, it's something strange. Huh? Usually it should be not like this. And now I will try to give nominal pressure. We will try. Oh, okay. Now it's went. There is a coronary stent already placed. Okay, thank you, Vitaly, for the suggestions about distal access. Yes. Usually we do not use it, but in this case it's okay. Thank you.
Not at all.
Да, Виталий. Yes, Виталий.
Говорю, не за что. Всегда рад помочь.
Okay, thank you. Назад. Alt. Медленно. Егер напряжение сесем, тоқтайал. Все, стоп. Назад. Yes, we gave 4 atmosphere in distal part. We don't need the second CC fistula distally. Yes. Now the territory is better. And we advanced the distal access catheter distally to the fistula point. And I will try to place my balloon a little bit distally. Okay. And after that, we have 2 scenarios. Максимум. Еще раз. Медленно. Yes, and all the time I need to control my assistant because during this movement, the balloon may move from the place, yes? Okay. Cancel. And as you noticed, in Kazakhstan, we have a lot of complex, I want to say complex stenosis because it's a extracranial, intercranial. In Europe, usually you don't see so much intracranial stenosis. In Russia, I think the situation the same. And in our country, we have a lot of patients with such kind of stenosis. One more time, we will give 6 atmospheres. And our insurance system said there is some stop, назад. Okay, there is some points in the insurance system, and nowadays we are trying to correct the situation. Okay. We have dilemma. Should we stop with this stenosis on this point or еще раз, 6? Or we need to do something with this CC fistula, we can do it later. Nice. Okay, a couple of weeks ago, we had the same kind of CC fistula in Almaty, and at that time we placed FD with the liquid embolic injection. But in this situation, distally, the artery is not so healthy looking. Huh? That's why there is dilemma issues. 6.
Do you hear me?
Yes.
Okay. I think you can leave the fistula there without putting a covered stent, because the option to occlude the fistula can be that. And sometimes they disappear, at least in my experience.
Guillermo, Pero, yeah?
Yeah, I'm here.
Yes, nice to hear you.
Thank you.
Yes. Thank you. Thank you, Guillermo. Guillermo, yes, we are taking your time. Okay, I want to ask the technical support. If it's possible to place us on the different screen and continue with presentation, and at some point of the operation we can interrupt and can explain what's happening, because we are taking your time now.
Can we go on with the presentation? What you said? To do both, to do presentation and
yes, we can stay with the stay with the video on the different screen. All wall of the conference hall is a screen. You can what you can see on the right and left and in front. It's a LED screen, all wall, and
Tariq
we can place our operation on one of the walls.
If Tariq
Okay,
is
thank
ready,
you.
we can start
Please
with his
continue.
presentation. Okay. Tariq will give us a presentation about flow diverters in bifurcation aneurysm. And the question is, why not for Tariq? Please.
Good afternoon, everyone. So, after Dr. Rene's talk, and we have got it's a sort of a debate, we have got Dr. Udai's talk following after that. It's a difficult job for me, and I will try to defend. Though personally, I would not like to defend, but I would try to defend my thing. So these are my disclosures. The most important disclosure, I don't personally believe in endoluminal flow diversion at bifurcation, but still, we'll go ahead. Because we do believe we can treat bifurcation by these means. There are multiple ways where the bifurcation can be dealt with, and these are the means. Having said that, there is a very nice paper, a meta-analysis of a bifurcation aneurysm, very recently published by a group from the US, JNIS publication, 19 studies. The conclusion is that the bifurcation flow diversion has a modest efficacy and relatively unfavorable safety profile. We, proceduralists, may consider reserving flow diverter as a treatment option if no other surgical or endovascular therapy is deemed feasible. With that, I go ahead. This is the first case where nothing was feasible. Mirror MCA bifurcation aneurysm. Do I have the pointer? Yep. So this aneurysm had got a sentinel bleed, multiple branches arising from that saccular thing, and we need to preserve that, and there is a bifurcation up ahead. And the bleed was localized. I don't have a CT for that, but the bleed was localized in this sylvian system, suggestive of this aneurysm has ruptured. We did a diversion because nothing else we could consider was possible here, because this fusiform sac was having so many of an artery arising from it. We did a flow diversion. That was the only plausible thing what came to our mind, and we did a diversion, and we tried to save the bifurcation up above. This is the immediate post-stasis. We tried to anchor this is a pipeline which has been deployed, pipeline shield, not a vantage, and the stasis have come, and subsequently, 6 months later, we got the cure with all those branches still flowing and patient clinically intact. Then we went on the other side, almost similar, but I think much worse than that, multiple branches arising from that, and was having an Acom aneurysm also. We treated both in the same sitting. Again, same methodology. The Acom was done with a stent-assisted coil. A Lvis-assisted coil was done. And this is a follow-up after a year of the first and 6 months of the second treatment, a magnificent result, where we don't see the aneurysm. We see all the branches which are there. So from there, we move on to a question. The question is, when we talk about FD at the bifurcation, we talk about a subset of an aneurysm where we see the chances of coming back again and again. There are two things, inadequate occlusion and the jail branch conundrum. We are going to jail branches, and what the implications are going to happen on those branches, the ischemic or the inadequate occlusion. If those branches persist, by our understanding of a flow diversion concept, the aneurysm may not go. If it is going, we may have an ischemic complication. So if we go back to that paper, that said 22% complication rate. The aneurysm occlusion was 68%. They have given a criteria, either the aneurysm is seen or not seen. The papers, sorry, lost my screen. Yeah. These 19 of the papers, they were either on a RNR or most of them were on OKM scale. So we moved first to an occlusion, try to address the occlusion thing. It's hanged. So the traditional occlusion scales are an RNR or OKM scales, what we are aware about, but is the natural history of on a RNR scale is same for a coiled aneurysm or a diverted aneurysm? Can we go and say, okay, we need an RNR is or OKM is sufficient enough to look for an aneurysmal occlusion? From there, we move on to a newer classification. Again, probably we may need another classification. This is the classification by Dr. Sikhaje, where they try to identify, characterize an occlusion rate of a endoluminal flow diversion. And I would say the class 5 or class 4 of these branches, they deal more justifiably with a branch flow diversion phenomena happening. So what is a bifurcation aneurysm? A big PCOM arising from an IC? Do we consider it as a bifurcation, or it has to be in equal branches? Again, there's a controversy on that. When we consider an aneurysm to be a bifurcation? These are the two cases where we got the PCOM is flowing, the aneurysm is gone. That means with the jailed branch, if it is flowing, we can still have an aneurysmal occlusion. This is again the case taken from the MCA aneurysm, the healings there. So we move on to try to find answer. This is a ruptured distal AC aneurysm, one of our 2-year follow-up case. This young lady, fusiform distal AC aneurysm. We deployed a device. We probably missed, so we deployed an overlapping pipeline device here. This was the 2 devices which was deployed. This is an angiogram post deployment. We could achieve some stasis. This was an IA vasocity which was done. And follow-up angiogram 6 months. We see still a part of the aneurysm. So the question is, have we treated, have we achieved the treatment, or still it will be labeled as an inadequate occlusion? I believe we have achieved the treatment in this with a sac there, still there. From there, this is the angiogram of that aneurysm. Almost a year follow-up. Another case, an MCA, bifurcation aneurysm, where both the branches are incorporated. The entire bifurcation is, this patient was simultaneously having an Acom aneurysm. So we stent coiled the Acom and we deployed the FD in one of the branches. The flow diversion was done. This was the angiogram. The run. We have achieved a stasis there. See the stasis. But all this patient has been done 5 years back. We still have a follow-up. This aneurysm is still seen. The patient is stable, but the stasis has marginally, or I would say has remained the same or has increased the thing, but the aneurysm is not gone. So do we see it as an inadequate treatment, or do we see we have achieved some treatment on that? A case, another, an MCA aneurysm, a ruptured Acom, we coiled the Acom, this was an MCA with a small branch arising from it, we diverted it. This was the angiogram. This was the angiogram, the patient was discharged well, and the patient had an occlusion of this FD, came with an acute stroke, landed up in ER after getting discharged. The M1 occlusion, we took the clot out, sucked the clot out with an aspiration catheter. This was the post-recanalization what we achieved, and the aneurysm is not seen at this juncture. The patient was changed from he was an ecosprin clopidogrel changed to a ticagrelor, and this is a 1-year follow-up after that. And this is a 6-month follow-up, and this is a 1-year follow-up. We again have seen the aneurysm coming back. There's a stasis there, but the aneurysm is coming. Now have we achieved the treatment or not? The question comes. Move to another M1 aneurysm, pre-bifurcation, involving the MCA bifurcation. A young guy ruptured aneurysm just at the pre-bifurcation. This was the hypothesis what we were talking about, deploying a device, a fusiform aneurysm. The device was deployed, a pipeline, this was a FRED device, the first generation FRED, which was device. That was a 5-year back case. We coiled the aneurysm. We got this result. This is a IF-CT angiogram, which was done, which showed a good apposition. And the follow-up, this was the CT. The follow-up control angiogram after 6 months. We see a recurrence. So we changed the antiplatelet regime at that time. The aneurysm was growing, and subsequently called the patient 6 months after that. This was an IF-CT. This is a control angiogram after a year. We see an occlusion of that device, clinically silent, asymptomatic. The MR was negative, no ischemic event on that. We got a complete occlusion, but we got a collateral flow which was sustaining the parenchyma, the leptomeningeal collateral flow which was there from the posterior circulation, both the anterior and the posterior circulation, which was contributing to this left MCA flow. So the part 1, are these aneurysms are treated or untreated? Because if we say 60%, we get a occlusion rate of a 60%, we say on a scale which we evaluate a coiled aneurysm. Can we evaluate a coiled aneurysm and a flow diverted aneurysm on the same scale? Now coming to the another thing, it's the jail branch conundrum. Is the artery can get an occlusion, that's 17% of the literature what it says, can get a narrowing, 23% is what the meta-analysis says. The ischemia complication ranges from 10 to 20%, which out of them, the symptomatic are 8 to 15%, and the fixed deficit are in 4 to 9% of the cases. A case, an MC aneurysm, ruptured in the sylvian, we got a sylvian bleed, a focal bleed there. Again, issue of a controversy whether to treat these bleps or not. We took it as a ruptured location because this was in very close proximity to the sylvian bleed where it was there. We deployed a device. The measurement was coming something 2.23, 2.4. So we exactly sized the device as what we were used to do it with an IC aneurysm. The device was deployed 2.2510 across the aneurysm, and this has an IF-CT. And next day, we see a branch occlusion with a symptomatic infarct in the superior division. From there, we had almost a similar case there. This time it was same, but only strategy what we changed, we oversized the device without any manipulation of the device. It was just an unsheathing maneuver which we employed in deploying this device. This device was deployed and oversized. The patient developed symptoms in the post-op period, was having recurrent aphasia, which was managed with a GP2B3 inhibitor on a continuous infusion, and then she recovered. We have got a 2-year follow-up of this patient, the healed aneurysm. She was having 2 more aneurysms which were treated. Another case, a ruptured MCA with an hematoma with a this is a fusiform aneurysm there with a pseudo sac there. So since the hematoma was big, we could not put the patient on an anti-aggregant. We coiled the ruptured part, and then subsequently the patient was put on a flow diverter. Now this time the device which was put was 3.25 into 20. It was highly oversized without much of maneuvering, and this is the end result. Both the branches preserved, the aneurysm gone, and we got a complete cure. This is 8-month follow-up angiogram which we got. A DACA aneurysm, recurrent DACA, the plan was, we coiled it first, and then this aneurysm grew, and then you can see there is a de novo formation of another aneurysm which was not there before. So we thought probably we changed our strategy from doing a stent-assisted coiling toward putting a flow diverter. This is a 1-year follow-up of that aneurysm. The branch vessels patent and both this sac gone there. A posterior circulation PCA bifurcation aneurysm, tandem aneurysms there. This was it took us long to navigate the fusiform part, and from the first aneurysm to the second part which was there, we deployed a long device, and this is a follow-up there. So do we get answers all the time? This is an Acom with a visual symptom and compression there, large Acom, no A1 on the other side. This was the only A1 on the left side. The right A1 was completely hypoplastic. We deployed a device, we deployed a coil. Final angiogram, we thought probably we have done enough. We should not put more of the coils. Follow-up, growing aneurysm there. The aneurysm, the coils were displaced, the aneurysm sac was growing. We balloon plastied the stent, the flow diverter. We put another device there, overlapping device, and again, the follow-up, still growing. So there are, I would not say there are places where putting using a endoluminal is not the panacea for the cases where we got stuck. But my submission is we cannot look away from the option of flow diversion for bifurcation aneurysms. We cannot apply occlusion criteria which are applicable for a coiled aneurysm therapy to the endoluminal therapy. And probably we can strategize and our strategy regarding how to balance between an ischemic complication happening on an occlusion of the device which is there. Thank you. Thank you.
Okay, thank you, Tariq. Do you have any questions in the audience? Okay.
Hi, Tariq, excellent lecture. Do you think that aneurysm, which have been treated with flow diverter for bifurcation, who had remodeling and also has some vessel remodeling, still has post of rupture of aneurysm?
You want to say when we say an angiographic occlusion, we can still expect a rupture? Do you want to say that?
Yeah, do you think that if the aneurysm is remodeled after the flow diverter and also the vessel also reconstruction, do you still have theoretically post?
In fact, we have got 2 such cases where we have got a completely healed aneurysm angiographically and we had a subarachnoid after that. You do have.
Thank you.
Tariq, hemorrhages from the covered aneurysm?
We did in one of our case, we did a thing. Probably our hypothesis was probably it is because of vasa vasorum proliferation which has caused a rupture on that.
So the aneurysm was growing.
The MR was showing that the sac was growing.
In the MR,
the sac didn't show a resolution in the MR.
Okay. We did a couple of cases, but one well done, of aneurysm that was completely healed, angiographically healed, but growing for vasa vasorum. And we did the gamma knife in this case, and in this case it worked. But if the aneurysm is growing not for vasa vasorum, but because of there is still flow inside the aneurysm, it will never heal with the gamma knife. Gamma knife can be effective in aneurysm growing for vasa vasorum proliferation. Vladimir?
Tariq, thanks. It was nice to see all those cases, beautiful. But the fact, just a comment about these two cases that you were treating with the FD, and it was bifurcation aneurysm, and that they were rupturing after. Those probably were the cases with large or giant aneurysms with a lot of clot?
Yeah, they were partially thrombosed aneurysms.
So they will continue growing also maybe because the healing or the thrombosing of the aneurysm sac was not completed.
Yeah.
No? Could be so. In some case, these aneurysms are acting just like the tumors and starting their own life based on, like Guglielmo was saying, vasa vasorum. So those aneurysms are really particular, and maybe the treatment should be more aggressive. So FDs plus coiling, but well-packed coiling to get the thrombosis of the sac, maybe.
Or probably maybe something like we may have an endothelial growth factor which is there, which is probably, we may have some anti-VGF activity. We can try that thing also on these aneurysms.
Could be. Thanks.
So it's a great argument. Thank you. Thank you for your presentation. Udai, please, can you do your presentation? Udai comes from India, and I love his presentations.
I hope you guys have my presentation because I don't have a computer here. Great. So the original idea of doing this was different, and I did not know whether, like Tariq didn't know, whether we are supposed to debate and argue and fight about it. What Tariq did was that we don't have to argue and fight about it because he actually proved my point. Here, we are not talking about all those aneurysms which are giant, partially thrombosed, or difficult aneurysms, branches coming out of them. The idea is about a classical bifurcation aneurysm, a saccular aneurysm, which incorporates both or three branches. Would you put an FD in one of those and get away? So since none of your cases actually was like that, so the point is already proven that you use a lot of FDs in many aneurysms, none of which was a classical saccular sub-centimeter MCA bifurcation aneurysm. So given that there's not going to be any debate, I will try and show you why we don't use it at all. Our idea is to secure the aneurysm, aneurysms which look like this, and obviously protect the branches. So simple. It's been always the case for the last 30 years. And for the last 30 years, we have had many things that we use. Right now, I'm not going to show you any cases in any other circulation. All of them will be MCA bifurcation or at the most M1 with a branch coming out.
And we have so many things that we have been using over the last 2 or 3 decades, and all of them are more or less working well. Quickly show you a few cases. When it's a balloon, as we had discussion in the morning, try and keep it simple. So even though the anatomy to the angiogram looks tough and difficult, but maybe you can do many of these cases with just one balloon and need not be the difficult artery. If the balloon is a hypercompliant balloon and you inflate it to include the origin of the other branch, the more important branch, then you will get a good result most of the times. So a couple of cases like that, single balloon, hypercompliant, not going into the difficult anatomy, and still getting a good result. Now here, we were not at all sure that how can we protect this with just ruptured aneurysms, with a balloon inflation, hypercompliant balloon, with a small little subcortical branch which always gives a very large infarction, a very debilitating infarction if you occlude it. And so we said that we will give it a try with a hypercompliant balloon and coils, with a little overinflation of the balloon, and at the end, we could achieve this result. Again, we were not sure whether this will be durable, but the MR showed that at least the artery is not going and the aneurysm is not filling. The angiography is actually looking much better than the MR. The artery is not at all damaged by the coils, which are very, very close to its origin. And this you can manage most of the times with a single balloon. Now here on this DSA, we don't know what the anatomy is. So obviously you have to do the 3D and see that it's easy to enter. The easy branch is always the inferior one, but the superior artery is the one that we should not lose. And again, we were able to manage this one balloon, hypercompliant. And as long as you can see it well, that the balloon is inflating into the origin of the other artery, you will be able to do it with one balloon only. Sometimes it's imperative that you use 2 balloons, and some of the cases like that, from 1 balloon to 2 balloons, and you can still get a very good result without the temptation of using a flow diverter, which many of the youngsters today are doing. You see anatomy like this, they just deploy into the easier artery, the temporal artery, a flow diverter, and more often than not, then they have the limitations that Tariq has already spoken about. Another case with 2 balloons, when it is imperative that you need to protect both of those. You may go with those 3 catheters in the same long sheath or an 8 French guiding. We sometimes still prefer to go with 2 guiding catheters, one with 2 and the second one with single. So balloon is great, especially in ruptured aneurysms, time tested. Of course, it will save your patient in case there is a rupture. And you will be able to do most of these with 1, if not with 2 balloons. Stents come into the picture with aneurysms like these. And Tariq, you did not show a single aneurysm which look like this, where you know that we have seen many patients and cases, at least in our country, where the temptation is to go just the easier artery and deploy a flow diverter and see what happens. And you can tell the patient that the patient is treated. Is he cured? May not be the case. And so here we did it with a stent, again a single stent in the artery, which matters, not the temporal division, the superior division, and it still will give you good results. There's a little bit of spasm in the superior division, but full patency at the end. Like the balloon, single balloon, sometimes we use 2 stents, Y stents very often. Our go-to Y stent option is neuroform. Always go into the artery which is seemingly difficult to go through first, and then the easier second artery can be cannulated through the first stent, and the results are always durable and long. Now from so-called easy looking aneurysms, we are going to a little bit difficult ones where the base is wider than the sac, than the dome, where again 2 stents is imperative, from 1 stent to 2, from both the divisions, again very easy to do, so-called, with 2 neuroforms and coils. Everything can be done just with a 1 microcatheter, which is what we prefer to do, rather than taking 2 microcatheters in simultaneous. Now this, I sent this picture to Cheki because there are many people here who believe in braided stents and why braided stents. It is not necessarily difficult to do, but you have to be ready to do an angioplasty for the second one, because the first one doesn't allow the second braided stent to open fully. So as long as you have the second braided stent, it's very easy to go into that stent, because now that's the preferred option to do an angioplasty, and you will get a good durable result because there is healing at the level of the neck. Then we come to the newer option, the exciting option. Anything which looks a little bit of complex, how am I going to protect both? As our comment in the morning, if you can do it with a single device, why not? And this is the one. It looks complex, especially for the superior division, and you can still do it as long as you have good anatomy. You can still do it with a single intrasaccular device, a couple of cases with the web, and that will be followed by, this is a follow-up, complete healing of the aneurysm, and full patency of all the 3 or 4 branches which are coming from the MCA. Another web, same 2, 3, 4 branches coming, difficult anatomy. Which one are you going to really protect? With what? With 1 or 2 balloons or stent? Try using an intrasaccular device when the anatomy is more complex. And as long as you get a good placement of the intrasaccular device, the follow-up is always, by that I mean more than 80% to 90% good. We have used all sorts of intrasaccular devices, and most of them, as long as you put them very carefully, they will give you good, safe results in the end. So this was another one, again, fully incorporated branches, the superior as well as the inferior division, where the contour sat very nicely at the neck and gave us a good result. It should be, this is my point, that if it is intrasaccular, it should be simpler. You cannot make it more complicated. Otherwise, why use an intrasaccular device, especially for the sub-centimeter sized bifurcation aneurysms? And I'm with you when I'm going to show you a few cases of FD, where we thought that it is not possible to do it with a regular one. Something similar that you showed, where in your case there was the aneurysm which was not healed, but in this case we were luckier. A branch coming right out of the aneurysm, and you can see that it's a very important branch with motor strip branches. But there was no other way of treating this, and we just put a flow diverter at the base. The branch goes, the aneurysm goes, but if it doesn't go in the 24 to 72 hours, then there is absolutely no clinical consequence to the patient, because now it is filling in a retrograde fashion right up to the level of the aneurysm. And if at all you have to use a flow diverter in the bifurcation, this should be the strategy, that the branch should go. If the branch doesn't go, the aneurysm doesn't go, but it should go not acutely. When we have a case like this, it is not easy to just put one flow diverter and some coils. So we prefer to have a deconstructive strategy, where out of the 2 branches, a large aneurysm, we have to see that which one of the 2 can be actually sacrificed and then make it into a side wall aneurysm, and then have a good complete occlusion. So we did that with a balloon test occlusion into the temporal one, and the superior one was a very complex, of course, the most important branch of the MCA. So we inflated the balloon into the temporal division. This is the balloon inflation, and took shoots from the vertebral to show that it is well supported by the PCA. And once that happens, this is the balloon inflation in the ICA, and now the balloon inflation, the PCA. It is again well supported by the PCA to the temporal division of the ICA, of the MCA, and then we occluded it. By design, by choice, Once you occlude this artery, it becomes like a large, complex, but sidewall aneurysm. It's completely a different and milder animal as compared to what it was before. And once you do this, you will have a good, stable, long-term result. 1 or 2 small coils there, just not doing anything to the sac of the aneurysm, but the flow diverter eventually will do the job because the temporal artery is taken care of by the PCA, and this is the 2 years follow-up angio with complete healing of the aneurysm, total cure, not just treated but cured aneurysm, and because it's a little bit of more complex strategy that we have to follow. Now you showed some papers, meta-analysis. These are also recently published literature in 2023 and 24. This one is by the Turkish group, and the next one I'm going to show is by the German group. What I want to show is exactly the same. Occlusion rates of 60 to 70% max, branch occlusion rates of 20 to 30%, and clinical sequel to nearly 20%. So which is absolutely not worth it. So if you can do something else with all the techniques that we have been using, then probably these aneurysms are better served with those. I have borrowed one case from them because obviously we have not put inside the MCA bifurcation. So this is the subarachnoid hemorrhage. And this is our case. It is not an MCA bifurcation, but there was no way of treating this. Patient has bled. There's a dissecting aneurysm on the P1, P2, where the PCOM joins exactly at the level of the aneurysm. So occluding it is not an option. Putting a flow diverter in the contralateral artery is not an option because the PCOM will continue to feed the artery. So we were forced here to put a flow diverter on the right side. Everyone happy that, wow, it's looking healed. Everyone is so kicked about it that, wow, we finally treated the aneurysm. But not at all, because patient had superior cerebral artery occlusion. This happened over the next 24 hours. And the angiogram showed absolute occlusion of the PCA because of the flow diverter. And if this can happen in this circulation, obviously it will happen in the anterior circulation. So we don't use in the regular saccular MCA bifurcation aneurysms, we do not use a flow diverter. Patient recovered as far as the hemiparesis is concerned, but obviously there is a field defect which has happened because of the PCA infarction, which we gave him. Control angiogram shows full patency of the artery, but the damage was done in the first 24 to 72 hours. This is a borrowed case from the Turkish group. Complex aneurysm, single flow diverter, everything is looking good. The flow diverter deployed, all arteries filling. Aneurysm will occlude eventually. It did, along with the 2 important branches. And this patient in their series had a bad complication of MCA infarct, which is the reason that we don't want to use this strategy. So what is working for us? And it has been working for a long time. Why change it? Just because there is a new strategy. It's so-called easier because to go into the branch, it's easier and deploy a flow diverter. But with questionable occlusion rates, which are less than 80%, 60, 70% occlusion rates, 20, 30% branch occlusion rates with clinical sequel, I think it's a no-brainer that we continue to treat the saccular MC aneurysms the way that we have been and reserve the flow diverter only for the most complex ones, along with the strategy which is specifically devised. Thank you, Tariq.
Thank you, Udai. Great presentation. Congratulations. Are there any questions? Tariq.
Yeah, of course.
So it would be, again, difficult to state my point. But my conjunction is that when we are saying it's not the treatment, it's not the treatment at the moment, but still, when we are saying about the bifurcation aneurysms, we are seeing failures, whether in terms of the endosaccular device or a balloon-assisted coiling. The recurrences are happening. The most stable results come with a stent-assisted coil, probably, but it carries the risk involved in the with the procedure and again the thromboembolic complications happening with that. So when we are talking, we are not yet at the moment, probably we are just at we can look forward towards this modality where probably over a period of time we may think, okay, let's think this as also a possibility rather than just keeping it aside. So that was my submission on that.
Yeah, sure. And the flow diverters also, it's not just one type. There are various flow diverters with various wire coverage of the flow diverters. So maybe it was like 94, 96, 72, and now they are lighter flow diverters, so to speak. Maybe they will help over here. I'm not saying that you should at any point of time just give up on any treatment strategy. At the moment, as you rightly said, at the moment probably is not the time. Even though it is the easier option, we shouldn't take it.
Thank you.
Thank you.
One consideration, sorry, I don't know, but I think that we always try to have 100% of perfect cure of the aneurysm, and we do not accept that there is a little bit of recolorization of the neck of the aneurysm that in terms of risk of hemorrhage is nothing probably. So frequently we push to use flow diverters, intrasaccular devices, everything more than simple coiling or balloon-assisted coiling or stent-assisted coiling, because we do not accept that there is a little bit of recanalization of the aneurysm, of the neck of the aneurysm, that means almost nothing in terms of risk of hemorrhage. So I usually, in this period of my life, I usually trying to consider how is the risk of hemorrhage, if there is a risk, if there is a small recanalization of the neck in this aneurysm. And my answer is almost always very low. So the risk of hemorrhage is very low if there is a lot Raymond Roy grade 1 or even grade 2 recanalization. We never consider it. We want always the aneurysm disappearing completely. I don't know if you agree with my consideration.
On the similar lines, there was a very recent paper that was addressing target aneurysm recurrence, which talked about a target aneurysm recurrence rather than an angiographic cure. You say if you have follow-up and you have a hemorrhage of that patient, or you lost a patient which has been recently coiled to any of the cause, you take it as probably the aneurysm which has recurred was asymptomatic, rather than going into the angiographic anatomy. Oh, we have got this neck, we have got that dog ear, which is there thing. So that was a more practical approach to that aneurysm recurrence, probably.
Thank you.
No, I agree. Last point. Pero, you rightly said that why do we treat aneurysms? It's the basic of the basic. We treat aneurysms because they should not bleed.
Yes.
So you're right that a small little recurrence at the neck, which is a central recurrence or recanalization, is not going to bleed, and we should not chase it. But we should follow the aneurysms up, and if at all it changes in morphology, then we should be able to treat. The point which I'm making here, maybe not for this audience, but definitely for our geography, is that when we treat the aneurysms, many operators and the young ones do not follow it up as our generation has done. And so that's my point. We should not go for broke or absolute perfection, but at the same time, we should not say that, okay, you're treated and now you can go home and for life you're okay. Yeah. Follow-up is important.
Yeah, follow-up is very important. We have to do that with every kind of device. And flow diverters have a lot of thromboembolic complications, late thromboembolic complications. So I think keeping the treatment simple and going on with coils, it's a good option.
Yes. So the bottom line, I think all of us will agree that for an aneurysm which is a bifurcation aneurysm, saccular aneurysm, sub-centimeter aneurysm, still the time has not come that we just go into the easier branch and just put a flow diverter and finish with it. Maybe not so far.
It's much easier.
Yeah.
It's much easier.
Okay, thank you.
Thank you, everybody. Now I'm calling Vlado, who will talk about kissing flow diverters. Thank you.
Good afternoon. So I brought these cases just to share with you because I thought that maybe kissing stent technique with flow diverters was the only option of the treatment. So I brought this series of 10 elective patients that were treated with kissing small, low-profile flow diverter Silvista baby. And I'm speaking about the Acom complex aneurysms, and 10 elective patients which were treated in 6 cases by the parallel deployment of the stents. In 4 patients, I had to deploy the second stent as a bailout situation while the aneurysm continued growing in a previous treatment. So in an Acom complex, we have the problem that the aneurysm is involving both A1, A2 angles. These patients were prepared and with a double anticoagulation, and I was using ticlopidine just because of no resistance of this drug. And I maintained this double anticoagulation for 3 months. Then stop, and aspirin was in therapy till 6 or 12 months, and then I stopped the aspirin. I had one patient which was with a third branch of pericallosal artery that was originating from the sac that I hold still on the aspirin, but the other ones are without the aspirin. So the follow-up was done, and as a result of the 8 aneurysms that were treated by this technique were completely excluded on a 6-month follow-up. What's happening with the other 2 aneurysms that I didn't arrive till the 6 months follow-up. So to show that the aneurysm is completely occluded, and on the angiography that the kisses are, the stents are kissing as the shrinkage of the sac. So, as the shrinkage of the sac is happening, the stents are getting closer to each other, and we have this effect. The patients were independent MRI score was 0-1, and they were completely doing well, except one patient that had a minor left hand deficit. But it's going well. While it's going well, what's happening with the problems? During 2 procedures, I had to inject ReaPro bolus, and I'll show you immediately what's happening. This is the Silvista deployed through A2, A1 angle, and as you notice, just 10 minutes after the deployment, I have the clot inside the stent. I injected just the bolus, and this is how the stents were deployed. So I was not pushing, or while I'm deploying DFT stents, I'm trying to deploy it just respecting the struts of the flow diverter, so not pushing it, not deploying it like the older and other stents. So the ReaPro bolus was injected, and this is how it looks like at the end of the procedure. So the problem was completely solved. So this is the control DSA on a 6 months, and as you see, there is no aneurysm anymore, and the reconstruction of the A1, A2 angle is complete. And this is how it was during the treatment. So the stents are getting closer, they're kissing. And I have started with this treatment, and it was like 24 millimeter aneurysm, and it was like in 2019, dissecting aneurysm. And I started with the harder part, but catheterizing the harder part on the right side, but at the end it was very easy. In these aneurysms, very often is very difficult to get out of the aneurysm sac. And here, for the first time, it was the first treatment, I had to loop the sac. This is how it's been done, and the stents are deployed at the end. So let's take a look at the result. This is 12-month result with the complete exclusion of the sac. You have on the left side the aneurysm and complete reconstruction. And the fact what is happening with the stent, the stents are getting closer as the aneurysm is shrinking. One more case, also this one was involving both A2, A1 angles. So again, I need to loop the sac to get out of the aneurysm. And I've noticed, of course, getting the smaller microcat, it is easier looping, or let's say, at least the risk of the rupture looks like smaller. So in all these 10 patients, I had in 7 patients, I had necessity to loop the sac. So these are the stents how were deployed at the end of the procedure. And this is the follow-up on a 6 month. So I am just...
CC fistula now on the right side, but so the next time.
The best is to wait.
Yes, yes.
It's not to do it.
Okay, we have audio of Minjilki.
Can we have the...
hello.
Yes.
Vlado,
Yeah,
sorry,
please.
sorry for
You're
interrupting.
welcome, my friend.
Yes, this case was the toughest one, and the patient is awake. How's Galapa? How is it? Oh. A little bit headache. Yes. We left for the, we went for the vertebral artery stenosis. You can see the stenosis. And the same story, when I'm trying to push my balloon and the coronary stent, it doesn't go distally. I think it's a calcified stenosis. Maybe, yes, sometimes it might happen. And there is also aneurysm dysplastic on the basilar proximal. And we did the PTA and we placed in proximal part coronary stent. And this is after stent placement. And we couldn't advance our balloon and stent distally this point. And that's why we placed stent in this point. And then we tried to go distally. It was not possible. After taking the guide, it looked like thrombus in the proximal part of the stent. And then we repositioned our distal access catheter. We did the aspiration. And this is after aspiration. Yes, everything is in place. And now we decided to stop at this point because not all the devices is available on the shelf, and we will do second session in Almaty. In Almaty, we have all devices for stenosis. This is complex case, very complex case, and that's why we will stop at this point. CC fistula is there, but the IC is patent. There is a stent at the fistula point, and I hope, and Rene is agreed, we need to wait and it will be occluded. We will take this patient after 1 month for the second session. Now my colleague will do control CT. I think control CT will be okay. Patient is talking with us, and see you in next 1 hour. Please continue, and don't forget to go to the coffee at 4 p.m. Okay. Let's take next question.
Thanks. So if you agree, I'll continue with the talk. So what's interesting about this, you can see the images. So the aneurysm, both stents are deployed, but as you notice, there is a accessory callosal marginal artery that maintains patent, and it stays patent, no aspirin anymore. So what happened, what need to happen was happening in the first days or 6 months, but after this one, patient continued to be followed and doing MRI, and I don't have new spots in diffusion to show the ischemics of lesions. So these are how the stents are looking when they were deployed, and these are the stents and the follow-up.
The other problem were like the patients that were treated years ago just by the coiling and the growing of the aneurysm like this. It was treated, again, she has a complex anatomy, and she was treated by the deploying ipsilaterally one Silkvista baby and contralaterally. As you notice, this angle on the right side is pretty difficult to navigate and would be also difficult to deploy the stent after. So I had to loop the sac. I passed under the coils, trying not to get involved with the coils, and straightened the microcatheter and deployed 2.5 by 20 Silkvista baby. So this is the control after the stent deployment and subtracted the imaging. So this is final control. As you noticed, stents from the Boyd side immediately are working, and the aneurysm is just less opacified from ipsilaterally. Recent case, so we're speaking all the time about good stuff, and now it should be good to complicate them a little bit. So this is the case where I was wondering how to treat ipsilateral or go with a kissing stent technique. So I navigate this side, and I wanted to deploy just one flow diverter from this side. I deployed it, but I messed up this part. As you notice, the stent is deployed on a vessel wall, but there is a gap. There is a gap. This gap will cost me a little bit of my patient and nurse. So why? This is the situation. Could you play this video, please? Just by clicking on it. Regia? Is it possible to play this video? Just click on it. No, it's not going. Okay, no problem. No problem. The fact is, like, while I was pulling out the pusher of this stent, the stent was adapting on the curves of the aneurysm, and it retracted, so it came down. That was a problem, or at least I was wondering what to do in this case, because I had a very short landing distally. It was like less than 4 millimeters, and I thought maybe could make a problem. So I went on the other side from the contralateral anterior cerebral artery. I deployed the coils, and I deployed one more flow diverter. So the flow diverter was deployed here as a baylite situation. Why? To get progressive thrombosis, and I was thinking that would be better for stabilizing the stent from the other side, not to get protruded into the sac. I went to control the aneurysm on the other side, but immediately I saw this reaction distal of the flow diverter. So flow diverter was, in this case, making a stenosis of the A2 segment. So what to do here? Doing nothing. Because in these situations we are speaking and saying, okay, better is enemy of good. Do the angioplasty. How to do angioplasty? We have stent that is protruding into the sac. Should we do the balloon or renavigate it with the 017 and try with Comaneci? Extend with a stent. Again, which stent? Deploy the Atlas just to get it on the vessel wall, or deploy one more flow diverter, because there is a very, very short landing zone of the previous one, and the diversion of the flow in the sac distally could be compromised. So these were my doubts. Yeah, Udai Limaie, please.
Is there someone with an answer?
Yes, okay. Please. Okay.
Personally, I would put an Atlas because it's low profile, it's 17 microcatheter, it's very good radial force. I think Comaneci, I will not use it because I will be afraid of not able to resheath the Comaneci to close it back. Yeah. Balloon can work also.
Just a couple of weeks back, I posted the same case, but that happened with the Silk Vista on the IC aneurysm.
Yes.
And again, that braid was collapsing. It was fish mouthing. Probably, what I believe that braid was collapsing because it was trying to adjust to the artery which was distal to it, and because of it was a blister aneurysm, ruptured blister, which I was doing, and was trying to push the stent, form the stent too much inside it. So probably that was the. So in the meanwhile, I was thinking about these options only, and the Atlas was the first option. What I thought, the flow diverter started retracting so much back again, and the aneurysm started filling. So the option left with me was only to put another vista inside it.
Yeah. These were my doubts, and because of, I'll show you this, because of this landing part that was very short of 4 millimeters, and for me was not enough, this image. I thought maybe the other flow diverter into this one and extended distally would be. So I took this decision. You know the situation, you're alone in the Angio, so you have to do something. I decided to go with the Silk Vista Baby, navigate it, and extend it distally. And this is how it looked like at the end of the procedure. This is the Angio. These are the stents at the end. And let's see, I just wanted to make the Angio before coming here to have the follow-up of this case. And I've done it. And it's going pretty good. The aneurysm is almost completely excluded. But look at this. Tariq, what do you say, my friend? Huh? Look at this. The stents are pretty different. Why are they different? They are extended in a part of the aneurysm neck, proximally, distally. They are like stenos. They are a little bit less wide and different respect how I left them on both sides. Patient is completely asymptomatic. This is how the stents were at the treatment, and this is on 3 months. Why? Why this happened? This could be the attempt of DFTs how to act on the wide neck. So the migration of the changing, modification of the profile of the DFT, which is happening during the healing of the aneurysm. I saw this phenomenon on the ICA, never seen distally. Why? Maybe because I was not doing the control on 3 months. I was doing all the 6 or 12 months, so I didn't see it something like this. This is the one more case, and complicated one. This was a kidney transplantation candidate, and this is the aneurysm of 12 millimeters. So he had option or surgery or endovascular, and patient opted for endovascular. These are how the stents looked like at the end of the procedure. So the profile of the stent is, I would say, perfect. During the night, he has an epileptic crisis. And my colleagues are saying that he had a subarachnoid hemorrhage, but it is not a subarachnoid hemorrhage. But during the night and the following day, they're treating him for the subarachnoid hemorrhage. The patient has a very bad clearance of the creatinine, and they take off ticlopidine, and they continue just with the aspirin. And this is what is happening. The patient develops the ischemia, frontabasal ischemia. But all this period, he was just initial crisis, he was confused, and he had a problem, left hand weakness. Yes, please, please.
This was contrast.
Yes, this was contrast.
This was contrast, and we had several cases, and we publish it. It's you have toxicity with contrast on the cortex because of the blood-brain barriers are not working, and after 3-4 days, patient is hemiplegic completely. So you are worried. You do CT, you do MRI, you do everything, and after 3-4 days, they recuperate completely. And it was actually toxicity with contrast. We had several cases like this. So you have to, when you do the scan, there is a special energy acquisition in the CT, so you can make the difference between blood and
the
contrast. So this will eliminate the blood. So this is a mistake to arrest the double antiaggregants.
I do agree completely with you. I had also few cases during the last year of toxicity of contrast, and Vlado Kalaušek also had, and we were discussing about this, but also heavy situation with the hemiplegia.
I know, we had total hemiplegia, and you are worried, the family is worried, you don't know what to tell them, but you do CT MRI and you do not have any necrosis. I had one last week, and actually I think it's because of we use now large guiding catheters. Yes. We are highly located. We do a lot of runs, highly located. So if you do it with a syringe, what I advise is to lower the pressure of the injection, because usually they put it at 450 or 500 PSE. So I don't do it more than 300. And when I do manual run also, I do not force like a bear. This is...
That is a good trick.
Then I think, I don't know. And maybe also it's depending on the type of contrast, because we didn't have this before using the triaxial system.
So something changed in the last period, and we more frequently hear about this situation. Guglielmo, please.
Nadir, during the MRI, do you see any restricted diffusion for this contrast toxicity? Oh, okay. No restricted diffusion, like okay.
It's not a stroke. It's not stroke.
No.
But you see all the circumvallations of the cortex, hyper intense, and first time we didn't understand what's happening, and then when the patient recuperated, then we had several cases, and then we understood. You put corticoids and hydration.
Hydration, yeah.
And you have to wait and say to the relatives, it's not a problem.
The problem is, like, we are without our department. So my colleague who is doing the night and the next day, he doesn't know these things. So he's asking advice for somebody else. Then I arrive in the afternoon when already anti-aggregation therapy is took off. So these are the problems. Gestire the treatment of these patients after the procedure is very delicate, and it has to be followed up precisely. I had this situation, and on this case, I show you what's happening further. So I took him to Angio. They didn't want to do the Angio because he had high creatinine. It was almost 7. And I insisted to do the Angio because with that kind of ischemia, I don't know what to wait. And this is occlusion of the A1 segment on the right. But good compensation. Compensation is coming collateral. Compensation is arriving from MCA ipsilaterally. This is contralateral. And you see that from the neck of the aneurysm, distally, the circulation is patent. And now is again, what to do now? So now he's back in a double anti-aggregation, but he is with ischemia. Proximal part of the stent is occluded. Patient is completely aware of everything, communicating, moving. He has just a small weakness of the left hand. Yes, please.
What I use in this case, I don't put again ticagrelor, because ticagrelor, the half-life is long. To stop it, if you have bleeding, it will take a long time.
Yeah, problem.
So what I use in this case is cangrelor.
Cangrelor, yes. It's easy switch on, switch off.
Switch off, switch on, and if ever you have a hemorrhagic transformation, you stop it right away.
Yeah. We're doing that for acute treatment.
Yes, but this is
this
acute.
one could be, yes.
But this you can consider it acute. You have a stroke.
he had the stroke, and this is the therapy from his last days. So single anti-aggregation was in the first days, then he back in the double anti-aggregation and arrived to do this angio with this therapy. And considering that he is in a double anti-aggregation with that ischemia, occlusion of proximal stent, what to do?
He can bleed here.
Yes, he can bleed.
I would stop the ticagrelor and shift to cangrelor.
With the idea to recanalize the proximal part of the stent or no?
On the right side, you mean?
Yes, on the right side.
You take risks of damaging the stent. How are you going to recanalize it? With a stent reaver?
Yes, the idea was I recanalize it, passed through, brought 017, and then I brought the tiger. But the tiger was not opening because the clot inside of the stent was already organized. So it's not like the clot of the stroke that we are treating, that it is acutely few hours. This one is for few days. In this case, I was evaluating risk and benefit, and I stopped. I couldn't open it, so it means inside the clot is stiff, so I cannot open it. So no stent will open it. I take it off. This is the angio at the end of the procedure. What could go worse? Patient is waking up still with just a little bit of weakness on the left hand. Could something go worse?
Hemorrhage. Bleeding.
Yeah. No. Patient is going well. He is moved in the other hospital. Rehabilitation, nephrology, and they again took off the second anti-aggregate because in a story he has the description of the subarachnoid hemorrhage. So he is for 1 month just on aspirin, on clopidogrel. These are the images from the other hospital. So he's starting ischemia on the homolateral, so on the left side. And let's take a look at the angio. He's doing angio control in the other hospital, so they send me the images. We see the complete compensation of MSA. Ipsilateral, the stent is patent, and this is the stent that had 1 month just clopidogrel. The aneurysm is getting smaller. There is some flow, and there is no compensation from the posterior circulation. So just the MCA. The stents, I had also this one on 3 months. The stents are changing morphology that I told you before. Patient is asymptomatic, and hopefully he will remain like this. So the reconstruction of A1, A2 angle in Acom complex aneurysm and kissing stent technique can be successfully achieved with very effective occlusion of the sac. Low profile flow diverter, like in this case, could be very successful. We need more understanding of acting on DFT FDs, especially in a distal circulation. So how they are making, moving, changing, what's happening. And thank you.
Thank you, Vlado. Any questions?
Please.
You too? Oh, okay.
Thank you, Vlado. No doubt this is an effective treatment. All aneurysms are occluded. I was thinking doing a bilateral approach, dual stent retrievers, it's quite a huge exposure. Worst case scenario is bilaterally occluded stents with, in most cases, would be fatal. Is there something against doing this as a stage procedure?
It can be considered as a stage procedure, and there are centers that are doing one side FD, waiting for a while, and then do the second stage FD. But I told you that at the beginning I was using, or I'm using aspirin and ticlopidine, that there is no shown resistance on ticlopidine. So this is the way why I've been doing these treatments in one session.
I agree. Other comments? Okay.
Hi, nice presentation.
Thank
So, do you use SVB for all your cases?
Do I use S?
Did you use Silk Vista Baby for all your cases?
Yes, I used it for these.
For these 7 cases?
Why? Because I needed to, in the 7 cases, I needed to loop the sac. So I think that the looping the sac with those 17 or all 21 are 2 different things. First thing. The second thing, I had, we're speaking about the personal experience. I had a personal experience good with Silk Vista Baby in distal impericallosal arteries. So passing this part and treating the angle of A1, A2 was not a problem. So for me, it became the first choice stent flow diverter in this situation.
So do you think that, we all have this problem with these newer DFT?
You had or you didn't?
We do.
Yes.
We all do.
We all
So I think because they're softer, the material deforms easily, and over time you've also shown the morphology change. So my question is, you remember in the first generation silk, we used to put a Leo and then deploy the silk?
Yes.
So do you think that putting, to change the angle, put an atlas or something and then put in, because that will also go through a 17 catheter, put in an atlas and then do the SVB, it will reduce the problems?
Could be, but also it is changing also the acting of FD. So if we consider that way, Silk Vista Baby plus Atlas means Fred, no? Conceptually. And we are using flow diverter just to get its own mesh like it should be. So yes, it can be. We have done the treatments like that in a basilar artery, putting the stent which will give the construction for FD inside. Could be the solution, but I don't know how will act DFT inside of the Atlas. Why? Because speaking with the engineers, DFT stents are acting differently with the percentage of the drawn field tubes. So because of the platinum inside. So that is what is giving to this stent the stiffness. It's not the stiffness, the wish to open. So different percentage of the materials will give him the different possibility to open more or less. This stent, when you use it, you see that it is very elastic, soft, it's opening all the time, but it continues to open. In some point, as we saw that they are getting back, in some point he will start to change and will get back in its own form. How, why, I still don't know, but I think that something's happening after the thrombosis of the aneurysm sac, and the forces are changing. I think that is just made of, that is a problem, so-called problem of DFTs, because after a while they're getting back in the pre-shape. But it is a long process.
So I didn't understand. You suggested to put an Atlas and then a Silk Vista Baby inside.
A long Leo or an Evo, and then put in...
But there are two problems with the Atlas and one with the Evo. One with the Atlas is that you do not control very well the struts, so you don't know where they are if they are in the vessel, so you have to pass again inside and you don't know what happens. And the other thing is that the flow diverter works very well when the struts are well opposed to the vessel wall. If you put another stent, the struts will never oppose very well, so it's against both the Evo and the Atlas. Sorry, excuse me, Orlando.
Excellent presentation. I think that we learned a lot from those cases. Thank you for showing to us. A comment, when we're doing any flow diverted distal to the A1, A2, when we're in A1, we use Brilinta, ticagrelor, and we're very obsessive and compulsive with the P2Y12. We're always wants to make sure that the patient is responding, because the fact that you're giving ticlopidine or prasugrel, even Brilinta, you don't know if the patient is responding. So the smaller the vessel, the higher the incidence of thrombosis. So we're very obsessive, and we do this case in 2 different sessions. Put the first one, control of the blood pressure, send the patient to ICU, send the patient home, and bring the patient back for the second. But I think that you have a great result with the other cases. Congratulations, and thank you to show those cases to us.
Thank you for this observation. And with prasugrel, yes, Brilinta, you have the other situation of time of onset and offset of the drug. So they have to be very precise with taking the drugs. If they forget, then it's disaster. And the other, just to subline, as you mentioned, the pressure is very important. So while I'm deploying these stents distally, I insist with the anesthesiologist to have the pressure more there 110, 120. Low pressure will start depositing the platelets inside the stent, and after a while I will have a clot. So that is so thank you for subline the pressure. Pressure is very important in the cases like this. Thanks.
Okay. Thank you, Vado. Great presentation and great discussion.
Thanks.
Now, I please Nader to come to do his presentation on Pegasus stents.
Good afternoon. I don't think my presentation will be as much as interesting as yours, Vlad. I try to make it quick so you can have your coffee break. So these are my disclosure. So I'm going to talk to you today about a stent. It's a Pegasus stent, which is a stent that we use in ischemic stroke, mainly, but I'll show you other indications for it also. So what do we know about ICAD? 6 to 24% of patients treated with mechanical thrombectomy, they have reocclusion within the 24 hours, which is a big number. An important factor associated with reocclusion is the presence of intracranial atherosclerosis. So 8 to 10% of ischemic strokes in the US and 30 to 50% in Asia are caused by intracranial atherosclerotic disease. So we need an alternative for endovascular techniques. Patients with ICAD-related LVO respond poorly to mechanical thrombectomy and have higher rates of endovascular therapy failure or reocclusion. This could be related to longer procedural time, concealed stenosis, or plaque disruption inducing in situ thrombosis due to multiple passes of the stent retriever. Although stenting is primarily used as a secondary treatment in elective cases of ICAD, its role as a bailout therapy in acute stroke recanalization remains debated because of the use of double antiaggregants. Emerging evidence indicates potential benefits for rescue or bailout stenting in selected acute cases. The Pegasus HPC is a novel laser-cut self-expandable stent with anti-thrombogenic polymer coating, potential reducing the risk of local thrombotic complication. So this is the stent, as I said, self-expanding open cell stent. He has the indication for the treatment of aneurysm in combination with coil, vascular dissection, and intracranial atherosclerotic vascular stenosis. It's the only stent actually with open cell that has the IFU for these indications. The available with proprietary anti-thrombogenic coating technology, the sizes goes from 2.5 to 4.5, and it goes in a 17 ID microcatheter as well as in the double lumen balloons. These are the ranges of the sizes of the stent. It is not very well radio opaque. You have only at the two extremities the radio opaque how say it, spots, but in the middle you cannot see very well the stent. It's not radio opaque. The HPC effect, you know that the glycocalyx, it's a natural lining of the endothelium that indicates an intact inner vessel wall. If this is disrupted, then you have the receptors of the platelets, they detect the damage and start the thrombogenic clotting effect. So the HPC coating, it mimics glycocalyx, so the platelets do not recognize the surface as a foreign body and they do not coagulate. The radial force of the stent is almost the same as the Atlas, but it is much less than the wingspan, but it is comparable to Atlas. So this study, the coating study, it's the objective, it's the first multi-center RCT trial to assess safety and efficacy of the P64, which is a flow diverter. So the P64 HPC, it's a coated flow diverter that you can use with a single antiplatelet therapy, and they compare it to the bare P64, which is used as a flow diversion with a dual antiplatelet therapy. The study design was this prospective international multicentric dual-arm randomized controlled trial on 170 patients, 85 in each arm. The primary endpoint of the study is the number of diffusion-weighted images assessed within 48 hours of the index procedure visualized via MRI. So till now, the safety analysis of 140 patients confirmed the safety profile of the study, but the study is still going on till they reach 170 patients. Another study was a retrospective single-center series documenting initial experience with the stent system for the treatment of intracranial arterial stenosis in emergency and elective settings. The inclusion criteria are classic. The patient was chosen on the condition potential leading to a luminal stenosis, either atherosclerotic dissection or due to a thrombus after unsuccessful thrombectomy. In any location, the patient undergoing any initial treatment or retreatment of the index lesion, patient with or without acute demarcated ischemic infarction on pre-interventional imaging. Balloon angioplasty was used pre, post, and per intervention. All types of balloon were allowed to be used, all types of access material, and any type of antiplatelets. The only exclusion criteria was related to hemorrhage. So any acute hemorrhage is excluded, or stenosis next to an aneurysm or a vasospasm after subarachnoid hemorrhage. This is the study overview. So the interventions were 43 overall, 37 were done in emergency and 6 elective. The majority was done in the anterior circulation, especially the ICA or the MCA. Some was done in the vertebral or basilar artery. The results, which is interesting, the percentage of stenosis pre-treatment went from 88 to 35% of stenosis, which means that improvement of 53% of stenosis. But is this enough to have a good outcome? We will see. So revascularization achieved success rates of 100% with improvement of stenosis of 50 or more. Subsequent occlusion after initial treatment was observed in 3 cases. The majority of intervention consisted of futile thrombectomy with a minority comprising elective intervention for symptomatic stenosis. This is a summary of the complications that happened intra-procedural and post-procedural. I will explain it to you better. 42 stenosis done over 2.5 years, 86% done in acute ischemic stroke treatment. In elective cases, no intraprocedural hemorrhagic complication directed to the stent. Complication occurred only in 3 post-procedural stent-related hemorrhage, stroke, or dissection. In emergency cases, we have more complication. 7 patients had intra-procedural major complication as emboli, stent thrombosis, or dissection, and 3 post-procedural, 1 hemorrhagic and 2 ischemic. Of the 37 emergency patients, 25% died, not because of the stent, but because of sepsis, hemorrhagic abdominal hemorrhage, hemorrhagic shock, cardiogenic shock, and basilar thrombosis. The outcome, 53% reduction of stenosis on follow-up at 30 days, 62.5 of stents were patent on follow-up. The MRS score improved slightly from pre-interventional to post-interventional, slightly better in emergency patients. In elective patients, the mean MRS score showed no change, so we did not have any change of the MRS score when it was high. So improvement in the MRS in 19 patients with a good clinical outcome, it means MRS 0 to 2, achieved in 20% of cases, including 7 emergency interventions. So patients with pre-stroke MRS score ranging from 0 to 2 had 50% improvement of the MRS. Technical note, thrombectomy before stent implantation was carried out in 86% of cases. Balloon angioplasty was performed in 95 with a neurospeed balloon most frequently. For stent deployment, neurospeed balloon catheter was employed in half of the patient, and the others were SL10. Pre-dilatation alone was done in 58% of the cases, pre- and post-dilatation in 30% of the cases. Post-dilatation alone was performed in 2 cases only. The antiplatelets therapy, it's a classic antiplatelets therapy for elective cases. You load the patient before with aspirin and clopidogrel after a multiplate test. During the procedure, you give aspirin injection and heparin. And after the procedure, you continue with aspirin and clopidogrel if the patient has no resistance to clopidogrel. In emergency cases, this is what is interesting. All patients had aspirin IV, but some had only aspirin IV with no other antiplatelets. Some had heparin, some had tirofiban, or both. But a lot of patients, they did only aspirin and did not have any thromboembolic effect. So if we see the Sampris study done on the wingspan, we see that the wingspan, it was a relatively large catheter that we use. It was a 27-inch catheter compared now to a 17. So this makes a difference in the outcome of the patient, as using a 17 microcatheter is minimal invasive. So this contributed a lot for the success of the use of the Pegasus compared to the wingspan. As you can see in Sampris, the incidence of stroke or death in the stenting arm plus the best medical treatment was 14.7% versus best medical treatment group 5.8%. That's why when we had an ICAD in elective, we thought that medical treatment alone is much better than having medical and mechanical treatment. This is one case I want to show, 76 years old, that came with aphasia and hyposthenia and dysarthria. This is a case that was done by Gianluigi Guarnieri from Napoli. You can see there is a basilar artery occlusion. After mechanical thrombectomy, you can see that in the mid-basilar segment, you have a severe stenosis. This patient, if you leave it like this, he will, for sure, he will re-occlude. So this patient had only aspirin injection. And after deployment of the Pegasus, you can see here on the right side, the Pegasus is deployed, but it is not very radio-opaque, so you cannot see it. Still, the Pegasus did not open completely the stenosis, so they did a dilatation with the balloon, pita balloon, and here you can see it. And the final result is a very good, very nice result. So this patient needed really to have this stent treatment, otherwise he would have occluded again. And it was used only with aspirin injection, no double antiaggregant, which is a very good benefit in case of acute cases. So bailout stenting using the coated Pegasus stent system in field thrombectomy causes is a valuable treatment option, as well as for elective patients. This study from this center showed that it is viable, safe, and it can be used in emergency cases, but it's not enough. We need an RCT trial to evaluate the additional benefit of this HPC coating. Thank you.
Thank you, Nader. Is there any comments, please? May I have a comment?
Sure.
The last study you shown, they had at one month 38% of occlusion of the artery.
Yeah. Yes, I think so. Yeah.
It's a little bit high. My personal point of view is that in ICAD we should use coronary balloon mounted stents. I don't know what the...
But this 86% of the cases were acute.
Yeah. But
So
now how many cases do we treat in elective cases? Most of the treatments we do...
I agree with you. But with the coronary stenting, you have to use double antiaggregants. You cannot use only one.
Yeah, but you have a stent that works.
Yes. But you do not have the IFU to use it in the brain.
Yes, it's another problem.
This is another problem. In some countries like US or, I don't know, some Middle Eastern countries where they're very strict, if you have any problems and you don't have the IFU to use it, you are condemned.
I know. In Italy, if you use it in an emergency setting, like an acute case, it's okay. You don't need any particular permission.
I agree, but on the medical legal point, if you have an alternative that has the IFU for use in the brain and you use a coronary, I don't know if you are completely protected.
Yeah, but we are risking to go back to the 20 years ago with the samples that didn't work. So if we have a stent that closes in 1 month in 30% and 40% of cases, it's not so good. But I know it's very easy to put a Pegasus, an Atlas. It's not against, but it's my opinion regarding the way we have to follow, and the companies we have to follow.
Actually, till now I used only the Atlas. Pegasus I didn't use much. I used the Atlas and I used the coronary till now.
Okay, you use coronary.
So, but the idea of having a stent coated is interesting. Just to use only one antiaggregant in case of acute stroke, it can be interesting.
Yeah, I agree. I perfectly agree with that. But the stents, the problem with these stents is they are very, very soft. They do not have any.
Yes, you need always a dilatation with balloon pre or post or inter-operative.
But what he was showing was an acute case with a single antiplatelet. That's what is the occlusion. And you're trying to compare with a double antiplatelet within a planned case. They are two different subset of patients.
I say that we need something that works.
Yeah, and the second thing, why you like coronary? What the anatomy works, the morphology look good, the picture look good after putting a coronary. That what's appeal you?
We do not have so many 1 month occlusions. we have to use Cangrelor and aspirin that are, Cangrelor is off-label, okay, coronary stents are off-label, okay, but at the end, the patient, in my opinion, has a better result and a better treatment. It's my opinion, it's my personal opinion. I'm sorry, there are no studies. Unfortunately, no company of doing coronary balloon stents wants to start a study, a trial doing that, because the coronary stent costs 300 euros, $300. And
sorry, why you said Cangrelor is off-label?
Because there are no studies.
No. We published Cangrelor in use of acute stent. We had a series published.
Yes. How many patients? Is it a phase 2 study?
No.
We published it even.
But it's not. I mean, it's not a device that you use and you keep in the. I mean, it's a drug like the aspirin. Aspirin also can be off-label.
There are no on-label antiplatelets. Cangrelor, in my opinion, is the best. We use it. We had more than 200 cases used when you use it Cangrelor, and we are very happy to use it.
Yeah.
Every antiplatelet in acute stenting, intracranial acute stenting is off-label. There, not tirofiban, no antiplatelet. So the fact that there is
if you go on this principle, you will use nothing.
I say we don't know. We have to forget this problem. It's not a problem, in my opinion, the fact that it's off-label, because there is not an on-label drug. So it's okay. We use that off-label and we use whatever we think it's bad. It's better.
Hi. Nothing. Thank you. Very informative talk. And in India we see a lot of acute strokes who come out of intracranial stenosis with an underlying ICAD. And the common locations are the V4 segment or the mid-basilar like you showed, or the petrocavernous junction or the cavernous supraclavicular junction. So these are the commonest things we see. Now, somewhere during the years of practice, most of us do an angioplasty, see if it's holding, and come back on day 2 and then put in the stent.
Yes.
That's a kind of practice that we all kind of go to. But there are cases where the angioplasty doesn't hold and we know it's going to reocclude, which is why a device like this on a single antiplatelet is going to be a game changer, number one. Number two, we've been using Credo or Atlas on the straight segments coronary stents after loading. But the rider is when we have big MCAs, etc., and our patients are on dual antiplatelets, then doing the decompression sometimes becomes an issue. So that's one point, that doing the angioplasty and leaving it at that and seeing if it's holding and coming back on day 2 is some media we've been following. The second thing is that Credo and Atlas have been working for us in the self-expandables, and but having this HPC will be really good. We don't have IV aspirin with us.
Well, I used always Atlas, and well, the radial force of this one is comparable to Atlas, but the advantage is it has the HPC. So, and it has the IFU to use it with a single antiplatelet. So, why not?
Absolutely.
Compared to the Atlas? This is first thing. But I agree with you. In acute case, what I do first is try to dilate with a balloon. And now what I have intentions to do is to dilate with a drug-eluted balloon. So maybe this can be also an advantage plus that we. So if you dilate with a balloon as a first stage in acute phase and you see that it works, I agree with you. Don't put stent, you put it later. But sometimes it doesn't work, and sometimes you can see that there is always
reocclusion.
This is first, and second, sometimes you have dissection also that aggravate the occlusion. In this case, you don't have any other choice than to put a stent.
And any of your, how many patients on IV aspirin in your series?
This is not my series.
Okay, in your literature. Was it 30% who occluded on single antiplatelet? of the Pegasus? 38%? No, I don't.
It was 62 patent, 62% patent at 1 month. Can you please put the presentation?
Yeah, 62 were patent.
So
62% were patent. So it means almost 30% were.
Almost 40%. 1 on 2.
Yes.
1 on.
But still, look, you have a pre-stroke MRI score. That patient that comes with an MRI score that is not very high, 0 to 2, you have 50% improvement clinical, which is good.
Yeah, probably the 50% with the patent artery.
Absolutely.
We should do an analysis.
It cannot be with a closed artery. It's logic.
Yeah, okay. I'm sorry for this long discussion.
No, it's an open discussion. But you, in your center, I know that you use this stent a lot, and your colleague is doing a series on it.
Yeah, what I'm saying, what I want to say is that it's easy for companies to propose a product that they have to enlarge the indication. So it's done for aneurysm, the Pegasus and the Atlas, and they say, okay, you can use it in stroke. But they are not proposing a stent done for intracranial stenosis to be used in acute setting or in elective cases. We have not still a stent done for that.
This is yet?
This is done for the aneurysm and they enlarge
it's done for intracranial stenosis also. It has the FIU for both.
They started it for...
the Atlas,
and they enlarged it. And they enlarged
the coronary is done for the cardiac, it's not done for the brain.
Yeah.
But you use it.
Yeah,
Atlas was done for the aneurysm, but you do it also for stenosis, so you use it.
Okay, but we have to, we need something better. Okay, in my opinion, I don't know. I don't know if you agree with me. We need something better.
We always need something better. Everyone needs something better. When you have a Fiat, you want a Ferrari. You always need something better.
Okay, let's try with the McLaren. Thank you. I think there is a coffee break now. Thank you.
So, Guillermo, what specific stent do you use for intracranial?
No? Hello, hello. I hope you can hear me. Who is in the room?
Italians are in the room.
Italian, okay. Vlado.
Yes, yeah.
Okay.
People are getting from.
Just a second. Hello, dear colleagues, once again. This is the Radio Presidential Center. Okay. This is a patient already treated on the hemangioblastoma, and it was a first session decompressive craniectomy on the posterior fossa with the biopsy. And at the time of open surgery, it was a bleeding. And it was a hypervascular tumor, and my colleagues decided to send this patient to the neurosurgical center, or another experienced colleague, but we discussed this patient, and it's possible to do embolization, and we took him for the first session. We placed coil in distal pica and the proximal. We trapped the sonic in between, and we injected squid 12. And now this is another side, and I want to show you the squid cast, and the part of tumor penetrated. You couldn't see. It's very tiny vessels, and at the control angio at the time of surgery, embolization, the right side was avascular, and the remnant part is circulating from the left side. And also on the left side, now we are directly went for the left vertebral artery without checking the right side, but you can see there is no supply from the right side. And also there is a aneurysm on the pica on one of the branches, and there is also intratumoral part of the pica. There is also aneurysm. And this is the images, and you can see on the pica, not at the branch coming distally, but there is some branch going to the tumor, and there is aneurysm inside the tumor. Yes, it's very interesting. And then we took headway duo. We placed headway duo distally. Ana kisilerdi shaqib keladi solingizlar, kelaversin. And with headway duo, we did the angiography. This part is fully for tumor, but there is one branch going distally. And then we went to that branch, and we did the angiography with sonic, and less tumor. Mostly it's a cerebellum. And if there is small branch going to the tumor, my colleague can resect it with no problem. And we placed the microplex coil 1.5 by 4. We nicely tucked it in the branch. And it was not detached. And then we lift small part in the proximal branch, just before the bifurcation. And sonic is located before this branch, not inside the branch. We don't need to go to the branch. Maybe we need. We will see in a couple of minutes. But this strategy is a little bit different than AVM embolization. Now, we check the proximal part of the artery, and you see there is an aneurysm. An aneurysmal part is going to the cerebellum. And we checked more proximal. Yes, this branch is fully going to the cerebellum and for the tumor. And now we are ready to detach the second coil in proximal part. At this point, we place the second coil. As this is the second coil and angiography. Now we can detach the, okay, this is sonic in between two coils. And distally you can see there is no flow. And flow will come through the collateral system. The guiding is below, and I especially left it below. I don't want to create the vasospasm, but maybe we need to pull it up. A second. Okay. Let's look for this. This is with coil. Okay, let's detach the coil and then we can place. Okay, the coil is in place. Now we can touch this coil. Okay. Kızılcan. Ha, bataryası oturağında. Новый имбересанс şu. Замер. Кастрат. Бас şu. Кастрат. Спирали клей. Okay, it's not detaching. Let's take another one. Dexamethasone, наркоз поглубже, стивернозер. It's a new one? Okay, fine. A second. It's not touching. Еще есть. I think the coil is damaged. Right? Okay. Okay, it's moved. Cheers. Тартасыш. Екі де алты спираль бере салшы, тағы да біреу. Тройка шприц. Шприц. Екі де алты. Спираль екі де алты. Берем. Правильно. Правильно. Alberto, yes. The gown is on the table. Yes. Yes, we already placed one coil and now we are placing the second one. Yes, distal coil is working. Distal territory is not more filling. Yes, не стыдно. Не стыдно. Могу. Мынау таза емес қой, алдындағы спираль анаған салған жоқсың. Бере салшы. Бір жарымда 4 бере салшы. Бір жарымда 4. Замира бір жарымда 4. Қысымы ғой да, не істеген? Еш нәрсе емес. Тұрай. Таймер болса қыласын. We need a couple of minutes for the thrombus formation. Absolutely. Yes, yes, this one. Always occluded distal and proximal. We are cooking. It's Spanish way of cooking for the obtura. Yes, okay. Slow cooking. Yes, and you can see the distal cooking. Yes, the distal part is no more filling. Oh, we can wait. And also we have a way for the obtura leaking, it's aneurysm. Yes.
So what we wish here is obtura not only to fill in the malformation, but also to diffuse within the veins. And we will get it.
Ah, okay.
And in fact, most of hemangioblastoma is small arteries, but most of them are veins.
Yeah. Yeah.
Arterial veins.
Okay, we are ready to inject. Just a second. There is a blue syringe, is a demiso, dimethyl sulfoxide, and it's a 1 cc like in other liquid injection. I'm injecting half. It's a dead space, and then Alberto is giving me. This is a medallion with. It's a beef medallion. We have a timer. Now it's a 3 minutes from the beginning of the. Yes, and this is Canon. You should count the imaging. It will be different than on Philips and Siemens. Okay. As Alberto discussed me the way of using the obtura, it's a tac way. Spanish way, eh? And also the Maimon is taught us to use it in this way. Yes, and visibility on this machine is
The maximum so they will reduce the lights in the room.
Süt düşürse hazır. Okay. And I think we need to do under graphy. It's a point of aneurysm, and we still have a room. Now it's start to go. Yes. Then we can wait a little bit. Yes. It's not machine for the liquid embolics. Yes. Maybe for the actor. I need to wait. It's a different philosophy. It's refluxing. It's refluxing and it's also going. Yes. Okay, let's wait.
Michel, just to ask you, different philosophies, so what does it
No,
mean?
no need. It's not going proximal. Yes. Yes, yes. There is a comment from Nader.
Yeah, it's Vlad. Michel, so it's different philosophy, so what does it mean? Can you explain just what are you doing?
The machine is working in different philosophy. It's a Japanese philosophy. Yes.
Before we get subtracted fluoroscopy.
Yes. You need the time to see the roadmap. Yes.
So here we can see a lot of perforators also filling.
It's coming from the
Or
V4
proximal
proximal, yes. And it's very important to know about this because you may also reach this region. That's why last time we decided to use a squid 12 because the visibility is.
Mendel, we have a question here.
Yes.
Can you explain us the strategy you are wanted to treat this hemangioblastoma?
Yes, Nader. Now it's Nader. Yes. Nader, my colleagues, neurosurgeons, in August 24, took this patient for the surgery. They did a good decompression and they started to take the tumor and it was bleeding. And they stopped the surgery and decided to send this patient to another center for more experienced colleague. Then I said, okay, it's a hypervascular hemangioblastoma and usually no problem. Let's do embolization and then
what is your strategy of embolization?
The strategy of embolization, I did a distal occlusion to prevent the cerebellum from the infarction. And there is already collaterals from the superior cerebellar artery. And I blocked proximal to prevent the road leaking proximally. Yes, yes.
If you are more comfortable with the run, we keep the run.
Oh, no, yes. Now we can see better. Yes, the goal is not to penetrate the hemangioblastoma fully, but if we will occlude both arteries, and then it's okay. At this point, we need to stop. It's a cerebellum. Yeah. And after occluding these both segments, and now there is no tumor from the right side, feeding with the pica, and we will do the same from the left side. And next week, my colleagues will go and will take out this hemangioblastoma.
And what about cerebellar infarction?
Yes, Nader.
What about cerebellar infarction?
Last time it was not infarction, and I hope this time will be the same.
going to go inside the tumor. It don't do it now, but it will do. What's has to go here?
There is proximal.
Okay, you can listen up. You have a steam catheter?
Yes.
Minjel,
Continue.
is there a difference in the outcome with embolization with onyx or obtura in these lesions if you compare with particle embolization? Because I remember a long time there was this article from Lariboisière where they treated 3 cerebellar hemangiomas with particles and the 3 didn't make it. The 3 ruptured and died post-operatively. And I don't know what are the results with onyx. Is it safer than the embospheres embolization or what? What do you think about this?
Yes, particles, you already saw the collaterals coming from the V4 segment and its transmedullary branches. And there is a quite risky, I don't see it, yes. Yes, it's reflection, yes. We have a glue, we can place glue.
Yes.
At the moment it's now.
No,
Okay.
yes.
Кара пакетте клейвер ашпересонс, липиадол и NBCA пакетик.
So to answer to Ahmed, I had one of the complications of the street bleeding. It was not 3 out of 3, it was 3 out of 15 or 20, but still microparticles and specifically embospheres, they go to the vein and they produce a venous occlusion.
So the cause of bleeding would be the occlusion of the vein during embolization. That's what you're saying.
Yes, it's a diffusion of the microparticles within the whole hemangioblastoma, but the shunts are quite large. So at some point, some particles go inside the veins and somehow we produce a hyperpressure on these transmedullary arteries.
Thank you, Rene.
And once it's occluded with liquid embolic, any liquid embolic, whether NBCA or NIX, and probably obtura, this risk is not there anymore. The only thing we don't want it to leave it like this. We would prefer the embolic agent to go within the shunts and to start to occlude the vein. Yes.
Yes, these small feeders also could be resected. I hope so. Okay. It's already there, yes. It's here. It's already in place.
It's ready for
Ашперес, біреуін ашасыз, бір пакетик. Yeah. We already used, and you need to take one squid бір наборын ашып бересіз. Okay. Let's continue. And I'm so sorry, but we interrupted the presentations and I hope we can join you in 40 minutes.
Maybe wait for this thing to be injected because if
It's okay.
backwards, we won't be able to take any further MCA.
Okay.
Or if you had just a few drops, then you don't have the legs anymore.
Yes. And Alberto, look for this. Alberto.
Yes.
Is it up to?
Did it end up?
Contrast.
No,
it's a tube from the
tube.
machine.
Okay. Ah, okay. That's not good. Okay.
Because
Let's-
otherwise
Yes, you see how the roadmap is coming. It's coming in 15 seconds. Глюкоза берешь 5%?
washing with glucose.
No, washing with
The good thing is the microcaster cannot occlude
Yes.
with.
With Aptura, it's possible to wait up to 5-10 minutes. We waited yesterday and the day before, and everything was okay. Yes, with the old machine, I think Aptura is not so funny, yeah? Yes, and the guiding catheter is located in subclavian. I don't want to move it before the NBCA, and after we can see. Yes. We need additional 10 minutes, and then we can continue with presentations. Yes. Yes, everything is okay.
It's a flow coming from the other side. You can't see.
Yes.
There's no flood. No, there are two catheters in the verse, that's all. Otherwise, we would have seen it here. You see the flow comes backwards, it's because of spasm. There's no flood there, it's fine.
But Rene, then glue will be till the third marker is okay?
Should much more.
Okay. Good. Now I'm taking the glucose. Some sugar. And if you notice, Aptura is on the table, and I'm not rushing. Not rushing, yes. No rush, and it's possible to inject this. And glue? Alberto? Glue is coming? Oh, I need one more. Yes. Okay. And the glue injection I will also do under graphy. Yes, for the tantalum-based liquid embolic, it's okay. And this is headway duo.
Okay. Take stronger.
Just a second.
No.
Oh, it's coming. I have not more space, and there is another comment from Alberto. The NBCA can mix with the Aptura. Aptura is not at this point, okay. But you need to keep in mind about this. Yes, now it's coming. Okay, we have time.
Michel, just to precise, this was a drop of glue or?
Yes.
It was half of the drop of the glue. And because of the Canon, we are doing this under. Now it's penetrating, yes. And we need to keep in mind the tumor has a collaterals.
Very good. Go. Now we're entering a vein. And we continue because we should be able to get all the vein. I think we can do it through. Now we see very well. It's more amount.
Down there.
Yeah, it's okay. It's a cerebellum. Oh.
Yeah.
Okay.
Small vessels are not necessary.
Okay. Yes, it's very slowly. It's a Spanish way, yeah? Tat, tat, tat. And I'm asking to see the part with the transmedullary. Okay, this may connect, yes.
Okay, that's the most important phase now. This will help a lot. Okay.
Okay.
Great. Yes.
It's okay. Continue.
So
Continue. Don't stop. Continue. Yes, in the vein. Do this vein. Get it on.
Okay.
Did you finish? No, not yet. I said you can even increase speed once it's getting inside.
I need to be careful with
looking,
transmedullary, yes. This is great.
It's perfect. Increase speed. These are the veins coming now.
That's right.
Try to do it in fluoroscopy because it's not bad
Okay.
now.
Okay. It's a good reason to buy new Angio suite. I'm looking for the lateral. AP is not much informative.
That's why I mean still low pressure, but continues. Yeah, it's good. Continue. It's exactly there. It's the vein around. Continue to get the vein. As soon as you're finished, I've got the other one ready here.
Oh, just a second. This is the vein, yes?
Yeah, it's a vein. It's perfect. It's a vein.
Okay.
It's a vein. Perfect. Could not be better. And now this should cut off all the perforators from the basilar.
Yes.
Yes, it's cutting now naturally. I think the most important here is trapping of the pipeline.
Yes.
Otherwise, we feel in the pipeline here. At some point, the door opens.
And I want to say thank you to Chiki. Chiki brought this NBC and Histocril. Thank you, Chiki. There's something is going.
It's okay. It's good. This is what was coming. Look at the run from the basilar. This is where the veins coming from the perforators from the basilar. No, we will not see it. Oh, there's just one microcatheter. We'll see better. Yes, let's make a run from the guiding. Now we will have flow because there's just one microcatheter left.
Maybe I need to take this out. Of time.
Okay, nice work here. Fabian here. Question for Alberto. Alberto, what is the concentration of DMSO in obtura? How many percent DMSO do you have?
Concentration of the DMSO, Alberto.
What do you think of
the concentration of, there are mainly two types of different concentration. One is obtura 20, which is like squid 18 or onyx. And the other is obtura 15, which is the one we are using now, which is like squid 12. So the less viscous, the more you need something to do a good plug. So I think this was a very important point in this case, to show that sometimes coils are not enough, and it was necessary to do some proximal.
Oh, the drainage now is getting out to a spinal vein. Would be nice to avoid this. Look here. Continue. It's a spinal vein somewhere. This here. See, it's getting down. The spinal vein.
But it's okay.
We should be able to get that little rest here before the injection.
Okay.
So question again. So which obtura are you using now?
Obtura concentration is 15.
15. Okay.
1,
thank
5.
This is 15, which will be like a squid 12, but we can talk about this afterwards, because now we are concentrated on the possible reflux into the small branches from the vascular.
I think Alberto has a presentation tomorrow, yeah? On obtura.
Today.
Today, okay. During the gala dinner, Alberto will do presentation on obtura. And also I have a presentation in parallel room in neurosurgery. Okay. In 30 minutes, we will be there. I hope so. On the roadmap is nothing visible. Now it's a Chapot's way of injection, force injection. It's like intra. But it's already trapped and should be no problem. And yes, at this point we can also stop. Yes.
Very good. It would be nice to make an overview of the posterior fossa to make sure that the distal pica territory is refilled by the left SCA, which is very.
Monjil, do you think that at the end there was extravasation into the tumor?
It might be.
Like a like a extravasation from the, because the way that is not like an artery or something like that, similar to the case with the meningioma yesterday or not?
Okay, let's see. Yes, the territory is already filled by collaterals. And if Alberto agreed with me, we can stop at this point, yes. Just one push and then we can stop, yes.
Getting another vein there. Laterally, we see we're getting another vein, which is good.
Yes, it's a half cc in.
No, this above here on A is too large. This is extra.
Okay. Okay. Yes, at this point we can stop, and the patient already operated and decompressed on the posterior fossa. It's the first point, and the second point, you can see the VP shunt. Yes, and our procedure is maximum secured by neurosurgical team.
Regarding your question, Orlando, I think that it was extravasation. Next injection, 100% of the time it will go to the extravasation point. So since I see that we diffused it again, I'm not sure that it was extravascular. Normally, when you have a burst of the tumor capillar or nidus, normally the liquid embolic, doesn't matter what type of liquid embolic, it only go to the extravasation point. So I'm not sure, but I think that it was not a real extravascular injection.
It's relaxation and tension. It's also inside the Datura Demeso, and we are working nearly 25 minutes, and it should detach. I will fix the sonic at this point. Now let's wait a little bit. How many cases you already done, Rene? With Aptura, how many cases? Okay. Okay.
Take it out, take it out.
And I hope we have a one-time permission now in Kazakhstan. Then we can use it. Okay. It's a hijama, yes, endovascular. Okay, let's do zoom.
can focus on the radiopacity of the previous injection in the right side, which is more dark, versus the left side, which is less dark. This is also an advantage of the liquid embolic, that it allows to see overimposed or structures. This is also good.
The remaining spreading downwards to the spine plane.
Yes.
It's okay, it's going to be afraid of having DNA. Probably because of it from the beginning, let's see. If it's making it down.
Yes, and it's going also to the right side. Yes. Okay. I will do one more, and then we can finish the case. Okay.
Are you doing
Any
Diagnostic?
questions?
Diagnostic?
Yes, now we are doing CT. Cut it. Oh, let's wait for the. They call it city. It's not Dyna, it's not Expert, it's a city. Thank you. Okay, let's wait for the. How many syringes we did? Three? Three syringes, yes. Okay. We can go to the control room now. It will be. Okay. Okay. Сейчас это закончим и, может быть, завершить. Мой телефон. Нет. Все, спасибо.
Maybe for this machine, it's better to just speak.
Yes. Or better to change the tube. Okay, what's your answer? Вот шприц. It's a cannon. This voice. It's a signal that operation is finished. It's all the time 20 seconds. Okay. Мы можем сюда камеру навести? Да. Угу. Пока принесите, но на данные не наводите. Угу. Окей. Сейчас у нас... Сейчас пока на монитор не наводите. О, Каза, бір секунд. Just a second. Just a second. This is the cast. Yes, and no artifacts, if you noticed. Just a second. Можно будет здесь свет выключить. Yes, this is a brain. This is cerebellum. And this is artifacts, I think. display as sagittal. Nader, Guillermo, Vlado. I think there is no blood, and this cerebellum is intact, and it's a sign that everything is okay. Like this, yes. Yes. And on Monday or tomorrow we will do MR, and I will show you in NeuroAddicts. But this part is okay, and some artifact from coil, and I think we can finish on this level. See you, I hope to join you in 20 minutes in the conference room. See you. Sure.
So, should we continue with the session? Yeah. Okay, we have Guglielmo, Pero, Niguarda Hospital, so we'll see what he's gonna tell us about the dural AV fistula.
Thank you, May
So
I have our... Okay, great, thank you. Thank you for the invitation. Thank you for all the friends who are here. And when Mujil asked me to speak about dural fistulas, I said, okay, it's a beautiful argument, but what about dural fistula? I didn't know what about that. So I decided to speak about protection of the sinus or veins, and about the and about the dangerous situation when we embolize dural fistulas. I know I cannot say nothing new to you, but I'm trying to do that. So why protection of sinus or veins during embolization of dural fistulas? Because in type 1 and type 2 dural fistulas, we have the dural sinus involved, and frequently we have to maintain its patency. And sometimes, even if it's if it can be occluded, it's better. It may be better to keep it open. So the old guys here remember how it was difficult to embolize a dural fistula, type 1 or type 2 dural fistula, before having a Copernic RC balloon, and we had to inject particles, coils, glue, and the results were always frustrating. And what can we do now? It's a typical type 1 dural type 2 dural fistula, okay, and with a balloon there, a microcatheter in the occipital artery, and it's an injection of fill, and it goes very well, and at the end there is no more fistula, and it's a straightforward treatment. It's okay. And even the cerebral venous drainage changes immediately, and the dural sinus now are orthodromic. So, and once we finish, now we always do acquisition like VasoCT or DynaCT to understand where is the embolic agent and where is the sinus, and we can see that the wall of the sinus is as a layer of our embolic agent, and so I think it's fantastic. And before injecting, it's always better to try to understand which are the different part of the different feeders, and where they go, and where is the fistulas. We can combine both the feeders, and having other computers and not the standard computer we have, we can combine even more than 2 feeders using a 3D slicer. That is a free tool for Windows and Mac. but there are even some collateral points. So dural sinus are not uniform tubes. They are irregular. There are segmentations. Sometimes they are double. And sometimes there are even cortical veins, normal cortical veins draining in the pathological sinus. So we have to keep it open. So VASO-CT and DynaCT help us in understanding this anatomy much more in these situations. And this is another case. And here we can think that there is a pouch here, a venous pouch here, that is separate from the sinus, and it seems so even in this projection, and even injecting from the MMA. So DynaCT, this is a VASO-CT, sorry, it's a Philips machine, confirmed that the fistula seems to be here. So we put a balloon, and inflating the balloon and injecting, we see that we still see the fistula, so probably the balloon is not in the proper position. What we did was to place another balloon here, a smaller one, going in the different segments of the sinus, doing some trials, and it's open, and move the balloon, and it's open. And finally, in this position, we injected, and the fistula is closed. So we understood that in such a situation, we can inject our liquid embolic with no problem. And we go on. And sorry. Oh. Okay. Sorry. There is the cast here. Here is the cast, and the fistula is closed. So this is another patient. It's a patient, an elderly patient who had venous sinus thrombosis some years ago. And this is the venous thrombosis. Here the sinus is occluded, and even the straight sinus is occluded. And this patient came 2 years later with this fistula here, and with reflux in the sinuses, and it's not an easy situation, not good, with this venous drainage of the cerebellum. Okay, and here we can see that the torcular here is very big, is very large. So we have different solutions. We can put more than one balloon, 2 balloons, or we can do, here we tried before inflating the balloon going to the superior longitudinal sinus, but the fistula was still open, and then we went on the other side and pushed the balloon, trying to fold it in the torcular, and doing that, the fistula was occluded, so we injected our it is always fill, and we occluded completely the fistula, and it was almost easily. It is the posterior meningeal artery from the vertebral artery, and immediately we have a good results. We restore improving of the venous drainage of the brain. This is another patient, more interesting. He came in our hospital after several treatments for these fistulas here. And when he came in our hospital, he had a fistula in the torcular, not so big, but draining in the venous sinuses, in the cerebral veins. So the anatomy was not so clear. At the end, I understood that the fistula was in the lower part of the torcular here, probably. It's what I understood, and I placed a microcatheter in the vein going there, in the part of the sinus going there, so passing from the torcular going down in this vein that arrives between the torcular and the straight sinus. but injecting from here, and then I put a balloon. This is a global injection. I put a balloon in the straight sinus to avoid reflux of the liquid embolic in the straight sinus. But when I injected that, I understood that there was a drainage from the balloon, from the microcatheter here, so there was another passage, so I had to put another balloon, so 2 small balloons, not Copernic, but 2 small remodeling balloons, and we injected, and then this is the occlusion of the fistula, so it's good, and I was very happy. The fistula was occluded. But 1 year later, when he came back to took the control, he had again the fistula here, a small fistula in the same place, worse because it was draining. It was now a type 3 fistula draining directly in the cerebellar veins. And what we saw now, it was that all the sinus were occluded. He had an occlusion of almost all the dural sinuses. So I had to decide between treating just the fistula or treating the sinuses. And what I did was treating the sinuses. I opened them, and I didn't touch the fistula. So this is the results, and this is 3 months later. The sinuses are open, and the fistula is completely gone. So treating the sinus was the solution to treat even the fistula. And I was really happy. But Copernic RC is not always and everywhere available. So sometimes we have to do something different, and we are not happy. And this is a patient, an elderly patient who arrived in our hospital because of a seizure, and it was during the COVID period, so there was a shortage of the Copernic balloon, and this was the fistula, very big with drainage in the cerebral veins, and it was the cause of the seizure. So what we did was placing the microcatheter. Even the microcatheterization was not so easy because the MMA was occluded on the right side, so we had to pass from the other side and from the posterior, from the occipital artery. And we used a PTA balloon. It is a never cross balloon, and you understand how it is stiff, and it's not the same as a Copernic balloon, as a remodeling balloon. And this is the injection of our liquid embolic. It's still filled. And at the end, there is still fistula. It is a patient, very elderly, so we wanted to solve our problem of the seizure. And we said, okay, that's okay. It's some months later, a control, so we don't see anymore the big veins in the big cerebral veins. So we reached to transform the fistula from a type 2 in a type 1. Okay, but remember, PTA balloons for sinus protection during the treatment are stiff and difficult to navigate, are very difficult to navigate, are frequently very short, do not cover all the sinus, are not compliant, so they are well opposed to all the parts of the sinus. They are like a cylinder, not like something like open at the diameter of every part of the sinus. And if we want, we cannot use another microcatheter in the same guiding catheter because even the shaft is larger. So always prefer a Copernic RC. Dangerous situations, okay. This is a big fistula we treated recently, and the venous drainage of the brain was completely very short, very slow, and at the end we obtained this result, putting some coils, the balloon in the sinus, and some feel here. okay, and the fistula was occluded, and we were very happy, but a couple of minutes after the wake up of the patient, he was comatose, mydriatic, and he had this big hemorrhage immediately, and she died. Sorry. Another possible problem comes from, this is an type 1 fistula, okay, not so interesting. But when we do the internal carotid artery, we see that there are some feeders coming from the MCA, and it can be the source of two problems mainly. One is the reflux of our liquid embolic in the cortical arteries, causing an ischemia, and the other problem can be even an hemorrhage to the occlusion of the vein and not of these feeders. And what we did before, it's a case who did Amadeo Cervo, who's a colleague of me, who did him. And what he did was catheterizing all the feeders going from the MCA and putting some glue there. And this is the first injection of glue there. And this is the second feeder, and injected even that. And at the end, the procedure went very good, and the patient was very good. So this is a stupid thing I did, but it was many years ago. This is obviously a fistula with feeders from MMA, from the occipital artery, and even from the ascending pharyngeal artery. And we occluded the sinus, we put some onyx, okay, and we were very happy, but there was still the part of the pharyngeal artery. And this is the stupid things, because injecting the ascending pharyngeal artery is very dangerous always. We can cause cranial nerves palsy, but I'll show you something different. And please see here, and this is the injection, and you see this spot of onyx here. What is it? Yeah, bravo. And it's in the carotid. We were very lucky, so the onyx stayed there. Didn't embolize in the MCA or in the cerebral arteries, but it's something stupid to do, so I suggest you to do not embolize the ascending pharyngeal artery, or at least this branch of the ascending pharyngeal artery. Okay, concluding, compliant balloons are very useful to treat type 1 and type 2 dural fistulas. PTA balloon cannot do the same job, so try to avoid it and try to have the right balloons. Some cases require combinations of more than one balloon, and Vaso-CT and Dyna-CT are great to understand the anatomy of the fistula. And what we do always is to do an acquisition of the cast at the end of the procedure to understand better what happened and if we reach the result. And this is a case we did recently, and this is a fistula, a very small fistula in the vein of Galen. With in red you see the posterior circulation injection, and in blue here it's the carotid injection. And here in blue you can see the cast of the liquid embolic. It was here, even in this case it was a fill. These are calcifications and not fill in the veins, in the cerebral veins, fortunately. Okay, and so be aware, in my opinion, of high flow, long-lasting fistulas, because when we occlude them, there is a risk of impairment of the auto-regulation of the brain arteries and the risk of hemorrhage, like in the case we saw, I showed before. And pile feeders are another point to take care and to avoid embolization of the fistula. We keeping open the pile feeders. We recently had in another hospital another case of hemorrhage, of a big hemorrhage some days later, the embolization because of the rupture of the feeders. I have some open questions, and one is the need for recanalization of the occluded sinus without venous stagnation. So if there is a fistula and there is an occluded sinus or a very stenotic sinus, would you open it? Would you do an angioplasty to recanalize well the sinus? Do you think it's useful? And another problem can be stenting during the treatment of the fistula. Is it okay, or you prefer to do it in a second session? Thank you.
Very nice. I treated a patient of type 1 fistula, quite important, and I could not, because it was extended all over the lateral sinus, and I had a very big vein of Labbé going in the middle of this fistula, but he was very annoyed of the tinnitus, and I put a wall stent. I stented the whole sinus, and it was cured. So
just with the wall stent.
Just the wall stent. I didn't inject anything.
Like the case I show you.
Tinnitus and fistula, almost all the fistula, he kept one small axis coming from the ascending pharyngeal, I think, but it was not symptomatic.
Okay. Because even Cognard did some cases like that.
Yes.
So probably we can do something different, mostly in difficult cases.
Yes, the symptoms, they went immediately.
And the fistula, you controlled it, you found it?
At the control, I found it was almost all gone. And there was some little fistula, but not symptomatic, so it's type 1. I didn't touch it anymore.
You showed a case that a superior sagittal sinus fistula and the patient bled and died. So my question for you and for all the audience is those cases with a type 3, with a lot of venous reflux, with the veins that they are arterialized, basically.
It was a type 2B.
2B.
Sorry.
Okay, but my question is, those cases that there is a lot of venous reflux, dilatation, tortuosity, that those veins are used to have a high blood pressure. We fix the fistula, and then we see a stagnation of those veins after the treatment because it's draining the normal brain. So the question is, should we heparinize the patient for 24 hours to prevent those veins get spontaneously thrombosed? Because I have a case that the patient bled, and I'm assuming that was like a subacute thrombosis after treating the fistula. So for nowadays, it's empirically, there is not any study demonstrating what is the best. But it's common sense to keep the patient heparinized, those cases with cortical venous drainage, to prevent subacute thrombosis of the normal vein. What do you guys think? This is an open question.
Fabian?
Okay, so we always keep the patient on heparin for at least 2 days after the procedure, and especially if there is stagnation, there is no doubt about it that we continue the anticoagulation for some time. And secondly, I have a single case of putting a stent across, opening an occluded sinus. The fistula did not go in that case. The fistula continued, but this was across the transverse sigmoid, so we could open that. It reduced the vein of Labbé reflux. I didn't have to put a second balloon into the Labbé then. I could take put a Kopernik RC across that, now that it was open inside the stent, and then go ahead with the fistula embolization. So that was point 2. But I had a question to you regarding the philosophy of your use of Kopernik RC. I noticed that you were overinflating your balloon to occlude the fistula completely before doing your injection.
Because you can what can I answer this question before and after saying something to Orlando and to you regarding the patient who bled? I think she was already paralyzed, but what we thought between us colleagues there and who were involved was in this kind of patient could be better to reduce progressively the fistula, so doing the treatment in 2 or 3 steps to allow the brain to a situation that is more similar to normal, and then occlude completely the fistula. So keeping a good access, but occluding other arteries, just the arteries going there, to reduce the flow, to avoid this sudden modification of brain circulation. Do you think is it another strategy that can we use it?
Guillermo, thinking like that way, yes, of course, it can be useful. But when would you apply this way of acting? Is it just the superior sagittal sinus when you have the both side feeders that are bringing the high flow, or so is it the type 1 fistula?
It's just a question, a matter of the amount of flow of the fistula. Yes, no one knows when to start to do this strategy. So sometimes it's unuseful. It will be unuseful, and the patient has a second treatment and could be closed in just one. But just the amount of the fistula, it was so large fistula, it was crazy fistula. So this is, sorry.
And the idea could be.
You know, dural fistulas in general is a venous problem. It's a, there is a shunt that is change of the hemodynamic changes. The change of the flow is the tinnitus. But in reality, progressive neurological deficit, venous hypertension, everything is the vein. Yeah. So it's at least, I think that we need to take care of the veins after the embolization. It's a good idea maybe to do partially and bring the patient back. But sometimes the insurance is not allowing us to do that. But I think it's very important to keep the patient hyperonized to prevent the subacute thrombosis. Yeah. Thing is, we need to take this into account that sometimes we forget. We're happy, you show beautiful cases, the patient, they did okay, but at the end there is stasis of the vein that is expected because you change the flow. So I think the most important problem is the thrombosis of the veins afterwards. Yeah. Is my opinion. I don't have scientific evidence of that.
Thank you. Please, Fabian.
Yes, I will just say I agree completely. Usually for dural fistulas, when you close the shunt, you have slow flow, but the flow is continuous. In the instance when you have superior sagittal sinus fistulas with maybe occlusion of both transverse sinuses, you start with opening the sinus and you can see not slow flow, the flow is completely reversed, and sometimes it's no flow over the whole convexity. And in them cases, I do recommend and I give them 2 weeks of low molecular heparinization. Yeah.
Thanks. Regarding the question about the overinflating of the balloon, in fistulas of the sinus, what we want to occlude, what we want to preserve the sinus, and we want to occlude almost all the arterial feeders. So if we do not overinflate, if the sinus is not well opposed to all the wall of the if the balloon is not well opposed to all the wall of the sinus, we will have a layer of liquid embolic, of onyx or whatever in the sinus, and we risk to get the veins, the access to from the brain veins, so it can be dangerous. So we always inflate very well the balloon. It's our opinion.
No, you misunderstood. Actually, maybe I didn't explain this. My question was that you wait for the fistula to be absent on angiography and then you inject your EVO, right?
Yeah, it's better. I think it's better if we see, like in the one on the first cases I show you, if you see a passage of contrast, it means that you are not occluding protecting well all the veins that you can protect.
But I do it a little differently. I see the pathology, like Orlando said, is on the vein, right? It's a venous problem. The shunts are on the venous wall.
Yeah.
Now, when you overinflate the balloon, in my opinion, may be wrong, that we are actually plastering the shunts, right? We will get arterial occlusion. We may not get the pathology, the foot of the fistula, which is why I start by embolizing it with a balloon which is like just opposed to the wall, and then I overinflate it once a penetration occurs, especially like in that case you showed where there's a separate pouch along the venous wall, so that to get access, and you put a second balloon into that too.
Yes, but when we inject liquid embolic, even if the balloon is overinflated, at the end we will always have a layer. So when you inject, the balloon is has not enough force to avoid that the liquid embolic goes in the sinus. So there is always a minimum layer.
Yes, but this also allows a little bit of the forward flow because the fistula is still there initially.
Yes, sometimes what happens is that we start injecting and at one moment it doesn't go well, and so we inject without inflating the balloon. We see that the liquid embolic is going on in the right place. Once it reaches the right place, we inject again. We inflate again the balloon. So, thank you.
Any other question? Thank you, Guglielmo. Thank you. So, to stay in the team, we are speaking about the vascular tinnitus, and Orlando Diaz will explain us about all what we have to know about it. Please.
So, thank you again. I'm happy to be here with you guys. We're going to be talking about vascular tinnitus. If you see our field, interventional neuroradiology or endovascular surgery, is growing. Now, after the stroke, endovascular mechanical thrombectomy basically increased the number of patients that we're doing. After mechanical thrombectomy, we have also middle meningeal artery embolization for subdural hematomas. And now with vascular tinnitus, this is growing and growing, especially in US and Canada. So tinnitus is becoming like a separate section of the ENT together with neurosurgery. So there are tumors involving with that, ENT problems, stenosis, dural fistula. So I think that after mechanical thrombectomy, endovascular treatment of subdural hematoma with middle meningeal artery embolization, tinnitus, this is growing. Also the spinal CSF fistulas. So there is new procedures that we're doing that we need to try to understand to provide the best treatment. So there is an abnormal perception of a rhythmic sound, but not all the tinnitus are the same. And this is, believe it or not, there is a lot of people, especially in the US, having tinnitus, all type of tinnitus. Not all of them are vascular tinnitus. But this is terrible. having this. The patient sometimes say, I cannot live with the tinnitus, and sometimes they want to commit suicide. They have insomnia, anxiety, depression, poor concentration. This is a terrible symptoms. And eventually, a patient with a dual fistula causing tinnitus can have a venous infarct, or the patient can have blindness for benign intracranial hypertension. So sometimes tinnitus, we say it is a tinnitus, but we need to investigate more because they can be related to other type of symptoms. So the first question, so what do you think is, where is the abnormality, and what do you think it is? It's an open question, okay? A microphone, please.
No, I was suspecting there was something with the left carotid artery, but...
What?
Left carotid, no?
No, it's on the right.
No.
The lesion is on the right. Microphone.
The right 7th, 8th nerve complex in the internal auditory canal.
Yes, so what do you think it is? Or what is the differential diagnosis?
It looks like a schwannoma.
Schwannoma, yes. Anything else? Anybody? Yes. Yeah, there is a light.
Maybe some petrosepics, inflammatory changes.
No, the lesion is in the internal auditory canal. So it's, let me see, let me show you.
Inflammatory, like MS.
So, yeah, the lesion is here. So a normal enhancement here. Look at the left, look at the right. So what is the difference?
On T2, it is iso to hypointense, and on T1, it is enhancing very brightly. So,
so let me tell you that this is enhancing. Yes, it's enhancing. Hypointense, I don't have the T1 without control, but this is enhancement, and it's intracanalicular lesion. Okay, so question 2. So what is the abnormality here? And that patient has tinnitus, by the way, the first one. So what is the abnormality here? Anybody?
Aberrant ICA.
Yes, a patient with tinnitus. So look at all this. So there is arterial cause of tinnitus, but also we have venous. So there is a venous etiology, arterial etiology. Most of them are not vascular. I don't going to tell you that all the tinnitus are vascular, but some of them are vascular, and we need to find venous etiology and arterial etiology. And this is all types, we need to find dissection, aneurysms, aberrant internal carotid, dual fistulas. So this is arterial causes. And let me show you, this is a 66-year-old patient with tinnitus, of course, vertigo, and the clue was deafness on the right side. And it's the first case that I showed to you. And this is the angiogram. Again, the MRI, I'm sorry. This is the lesion. And this is the angiogram. So you can see there is a distal ICA aneurysm. This is the three-dimensional images and the dual volume that you can see where the lesion is. So clearly it's an aneurysm. Most likely maybe it's a dissecting aneurysm. And the patient presented with deafness and tinnitus. And the MRI showed this intracanalicular lesion that the differential diagnosis, as you mentioned, was schwannoma, hemangioma, but also from now on we need to consider an ICA aneurysm. That is a possibility. So this is the aneurysm here. There is narrowing of the artery in that area. This is the angiogram after the embolization. Use the headway duo. Of course, I was planning to sacrifice the ICA, but I was lucky that I closed this, partially treat the aneurysm. I have to use a balloon into the vascular to redirect the microcatheter, and this is after the embolization with the post-treatment. So this is post-calling and follow-up. The ICA open. This is the coils inside of the internal auditory canal. And this is 1 year follow-up. So it's persistent occlusion. So the other one you can see here, pulsative tinnitus and tumors, of course. This is a lesion is involving the external auditory canal, is in the mastoid. That is a good transmission of the pulsatility. When we do the injection, we can see the hypervascularity on that area, and was a tympanicum paraganglioma that was resected. So we can see aneurysm. We have seen vascular tumors. This is doing the embolization, and then surgical resection. Again, symptoms. It's an aberrant internal carotid. This patient with an Acom aneurysm. On the left, the internal carotid was okay. On the right, the patient have aberrant internal carotid. She consulted with Tinnitus. The MRI and MRA show the aneurysm and also the aberrant internal carotid that you can see clearly. The clue in the MRI is to see the direction of the petrous bone. Sometimes the petrous canal is hypoplastic on the side. So this is, you can compare the normal with the aberrant internal carotid. And why there is a tinnitus? Because the internal carotid is projecting inside of the middle ear. So all this variation, sometimes they can be confused with a glomus tympanicum. And when I was doing my training at Mass General in Boston, this was biopsy, thinking that was a glomus tympanicum. So, and this is, you have all this type of variation. The inferior tympanic artery, this is the way that is, this is the origin and embryology of that. So we have another patient here, 71, with TIAs, dizziness, generalized weakness, and left-sided tinnitus. And this patient cannot live with that, and this is a diffuse FMD. So normally we don't do any treatment for that unless the patient is presenting with ischemic or dissection, etc. But in this particular case, we decided, very unusual, to reconstruct the whole artery and the tinnitus disappear. And this patient, unusual case with fibromuscular dysplasia. So another case, you can read everything. There was a retroorbital headaches, etc. And we can, this is the CT and MRI showed an abnormal vascular lesion. Over there is round with edema. That way we can see this patient also presented with tinnitus. There is an abnormal blood vessels in the posterior circulation. And this is the angiogram that we see that there was a venous aneurysm in this dural fistula associated, and meningohypophyseal trunk supplying also. Guillermo, when we have this fistula that you showed, sometimes I used to have a balloon into the cavernous internal carotid because we can reflux, especially if we inject some of the neuromeningeal trunk. So we need to protect, even if we don't see this type of meningohypophyseal, by anatomy, they can be open during the embolization. So this is the angiogram here in this patient, and with a venous outflow. And in this case was you can compare 2016 with 2021. The patient, the venous aneurysm was growing. This is the injection into the external carotid, and we decided to, as Guillermo showed, that sometimes we understand the fistula after the treatment. We use a balloon, hyperglide balloon into the cavernous internal carotid, but as we were planning to do an onyx embolization using the middle meningeal artery and the two branches of the middle meningeal artery, occluding the internal carotid at the same time to prevent. This is inflation of one of the sector balloon, inflation of the second one, and then simultaneous injection, inflating just the balloon into the cavernous internal carotid to prevent reflux. And we can see the injection and into the simultaneous injection from the two sector mini. I learned that it's very easy to occlude the lumen of the sector mini, so we use we don't have squeeze 12, that is ideally, but we need to use 18 and basically close the fistula in one attempt. This is the post-embolization, and we can see the embolization material in the foot of the vein. So this is the case that that I showed this morning, that was also in using the transmastoid foramen, but it's not worth it to show. So this is Archigel. So far the Archigel approach, we can see aneurysms, fistulas, tumor, etc. But also venous etiology is one of the causes. And it's very important, the clinical examination. So basically compress the jugular vein to see if this is getting worse or it's getting less conspicuous. So it's contralateral jugular vein, and do the different maneuvers. Also, sometimes we need to do a balloon test occlusion of the veins, especially the posterior hypoglossal vein. So we can see here stenosis of the transverse sinus that is associated with tinnitus, and sometimes is associated with benign intracranial hypertension. Stenting is one of the things that we can do that. So we measure the pressure, and now we can use 6 to 8 in the gradient, and it could be also an external compression, internal compression. This is not the reason of this talk, and we need to measure the pressure of that. So idiopathic intracranial hypertension is the patient is related sometimes to overweight, multiple medication, as you can see here, and is also a common venous cause of venous tinnitus. So the first line of treatment for this is the idiopathic intracranial hypertension is losing weight. Acetazolamide is the second one, but sometimes is not accepted, is not tolerated by the patient. And there is a study that is the Nordic study, and where this was study acetazolamide versus low sodium weight, and the trial found basically controlling the visual loss, papilledema, and CSF pressure. So, and this is after losing weight. This is what is medical treatment is recommended, and you can see the side effect of acetazolamide, the DAMOS. You know, the patient can have fatigue, nausea, vomiting. Sometimes it's not easy for them, and they stop taking the medication. So what to do with those patients? Sometimes they can do CSF diversion, bariatric surgery, or venous stenting. So this is what we're concerned about, is the complication rate in general is 6.6%. And you know, you can have this type of complication, and they can come back. So this is a patient with 27 years old, anemia, tinnitus, not projective bruit. And when we have that, we can see stenosis of the right transverse sinus, as you can see here. And DynaCT, we sometimes it's an external compression, sometimes it's arachnoid granulations. Like in this case, very easy to go there, and we can easily stent it. We don't have any FDA-approved specific venous stenting, but there is a lot of one coming soon in the US. So we put the stent here, and we understand better. Normally, we don't have to do post-stenting angioplasty. The easy procedure, the tinnitus disappear, and the benign intracranial pressure also decrease. So another, this patient with bilateral stenosis, again, we can see here, normally I try to do one procedure and bring the patient back in case that I have a complication in one. In this case, we did the 2-1 for insurance. So we put a precise on the right and precise on the left, a little bit one, and this is the right, and then basically is reconstructing the sinuses. Also, we can see sigmoid sinus diverticulum or sigmoid plate dehiscence, and they can have pulsatile tinnitus. And sometimes we can go and try the diverticulum. This is a patient 61, hearing loss. when we do the angiogram, we can see that diverticulum, the tinnitus was on that side. So we can do the stenting and treat this like an aneurysm. So normally I put a couple of coils there, and then after that, stenting, and immediately the symptoms of this caused by the diverticulum disappear. Another patient, 45, pulsatile tinnitus. We see this, the angiogram. There is another diverticulum here. And we can see the erosion of the bone, so the chronic mass effect. And the 3D, just for documentation, it's like a white neck aneurysm. Again, we go with this one. We can gel the microcatheter, put the stent, and coil the diverticulum. So we need to look for. If we don't look for, we cannot find this type of lesion. Also, it's interesting. Sometimes the responsible of the venous diverticulum is emissary veins. And emissary veins abnormalities, specifically the posterior condyle vein or transmastoid vein that I showed you this morning, is responsible. This patient have pulsatile tinnitus, and it's persistent, high pitch. So when we do the angiogram, we can see this prominent posterior condyle vein, which if you analyze the angiogram, this is very frequent. See this. It's unilateral in the site of the tinnitus, and I don't see any other cause. And when I compress this area, the tinnitus disappears. So what we did is with the patient awake, we went to the jugular vein, put a balloon into the posterior condyle vein. Remember the anterior condyle confluence, the hypoglossal canal is very interesting anatomy that we need to understand. So the patient awake, we put a balloon in the posterior condyle vein and start talking to the patient. The room has to be quiet. And according to that, we decide that the tinnitus disappear. It's a test occlusion, angiographic test occlusion, but the patient is awake. It's not only angiographic. So after knowing that the tinnitus disappear, we can go specifically and do the balloon-assisted technique, protect the sinus with a balloon and close the posterior condyle vein, and this could be, in this patient, the symptoms release. So we are very obsessive and compulsive. Not all the posterior condyle veins prominence is causing tinnitus. If you analyze, most of the time, it's not. This particular case was asymmetric, and the test occlusion showed disappearing of the tinnitus, so that's the reason we do. But it's not that we need to close all the posterior condyle veins in all the patients with the tinnitus. So also the jugular vein, we can have high riding jugular vein, jugular bulb that are sometimes now we're doing stenting, jugular dehiscence, diverticulum, etc. And this is another case with gadolinium is a chronic venous sinus thrombosis on the left, but when we do we can see also the stylus process compressing the jugular vein. So those findings we don't used to look for before, but now with a patient with tinnitus, we need to understand, and the jugular vein is compressed. That is called the eagle syndrome. So sometimes it's compressing the internal carotid, sometimes it's compressing the jugular, and in certain positions the patient is having symptoms. Sometimes it's responsible for dissection too. So pulsatile tinnitus is definitely terrible. This is not just the patient has tinnitus, and sometimes the type 1 dural fistula just with tinnitus, sometimes we treat it because they are symptomatic. There is a lot of causes. And eventually, difficult entities like an aneurysm of the internal anterior, the ICA, dural fistula can be potentially risks. So what I think is we need to analyze this algorithm. So this patient's vascular causes. So is risk of a stroke or no risk of a stroke? A stroke risk, we have dural embolization, wrist stenosis, dissection, fibromuscular dysplasia, the no stroke risk, intracranial benign hypertension or not. So if there is not, and the patient can be the tinnitus is debilitating or not debilitating. If the patient said, I can live with that, there is nothing that I can have a stroke, that I can have increased intracranial hypertension, maybe we don't do anything. We follow those patients. If there is debilitating, the patient wants to be treated, it's terrible, so we can do any endovascular treatment. So if the patient have benign intracranial hypertension, medical treatment, losing weight is the way to go. There are other treatment, etc., that we can provide or consider stenting. The other thing that after I went to Alice in last year, Rene showed 5 cases of dural fistula after stenting of the benign intracranial hypertension. And when I went back to Houston, I think that I had the first case, and last week I had the second one. This is, so this is a patient with stenosis. This is the second case that I saw, stenosis on the right. I put a stent, it's perfect. The patient has tinnitus. There was not benign intracranial hypertension. The patient went home, the tinnitus disappeared. 3 months faster, the patient I have pulsatile tinnitus again, and this is what happened. So the patient developed a dural fistula. Rene, remember that you presented 5 cases? So after that, I have seen. So immediately I went back to Houston. I did a follow-up of the first case and was a dural fistula after stenting, and this was the second case. So honestly, I don't know what is the reason of that, but this is, let me go back again. So this is stenosis there. There was a gradient. Patient did great. The patient was very happy. And, this is because we sent it for publication before Rene had the opportunity to do it. And this is the dural fistula that I treated with a balloon protecting the sinus. So this is, to me, is a mystery why those patients develop fistula. I personally have had 2 cases after stenting of the sinuses. For tinnitus, the patient come back with tinnitus, and they develop a type 1 fistula. So this is an open question for you guys. If you have this type of complication, I would like to ask Rene, what is your opinion, why those patients develop the fistula? Any questions for me?
No, I fear I don't have the answer. Venous hyperpressure, but how do we create a hyperpressure or some venous obstacle? Must be around it, but I don't know precisely.
In both cases, I used a wall stent, and coincidentally was a 10 millimeter wall stent. Maybe I didn't have any smaller. So I agree with you. Maybe using a bigger stent of the sinus with a chronic pressure there is irritating inflammation, creating the fistula. So for now on, I'm very careful to measure the sinus and not to use a bigger size stent, but I don't know the answer. But maybe it's that.
Yeah, maybe it is. I mean, the stents are circular, right? The sinus is not circular. So there will be pockets where thrombosis is formed. There's an inflammation, and the arteries of the meningeal layer grow into this thrombosis, and at some point, breakthrough. Just an idea.
Yes.
You showed the case with the diverticulum and the transverse sinus. I had a couple of cases like this where I placed a wall stent with coiling, and the tinnitus, of course, disappeared. But there are 2 cases I know of that treated by colleagues of mine, and it was a diverticulum, and they placed the stent without coils, and the tinnitus also disappeared.
The tinnitus went also?
Yes, I did 2 cases.
So maybe we don't need stent for that.
No, we didn't. Maybe we don't need coils.
Maybe we don't need coils for that.
Maybe we don't need coils. Maybe.
Yes.
Yeah.
It's a possibility. I always put a coil.
I put coils, but I've been shown a couple of cases without coils, and the tinnitus also disappeared. So maybe.
Maybe, yes. Thank you very much.
Thank you, Orlando. Very nice presentation. Thank you.
Thanks. It's clear now? Alberto should say something, huh? Please. We've been waiting for this moment.
First of all, thank you very much for the invitation for Angio. It's nice to be here again and to share my experience with a new liquid embolic agent, which I think is going to help us a lot, especially in ABM's treatment. But also, I think that it could help in other entities. In our experience, we started this project to improve the quality of visualization in high-grade ABMs, because after several sessions, sorry, I think I disconnected this. I connected this. No, I don't have this one.
You don't have?
Okay. It doesn't work. One second. At the beginning, we started with this project because of when we injected a lot of onyx or squid in high-grade ABMs. We had a lot of problems to understand the anatomy in the remnants of the ABM, and this was so painful because we had several patients, young patients, that we did several treatments, and we couldn't finish the ABM. And some of the times, neurosurgeons could take the ABMs out when they were cortical ABMs or in a good location, but in other occasions, because of the remaining was the deep part of the ABM, the patient was sent to radiosurgery, and I think that the results of radiosurgery in previously embolized ABMs are not the best. So that was one of the main reasons, but the more we use this liquid embolic agent, the more we are convinced that it's going to replace the other one, because it's not only the loss of radiopacity, but also the diffusion. I'm going to focus on the advantage of the loss of radiopacity, but also the diffusion is, I think that improves diffusion related with tantalum-based agents because of two reasons. First reason is that there is no tantalum. The radiopack agent is iodine, so there is no tantalum, which means that there is no precipitation of tantalum neither inside the catheter or during injection in the nidus. So there is the rate of extravasation is very, very low. And this is one of the things why diffusion is good. And the other reason why the diffusion is better, in our experience, is that the way that the liquid embolic precipitate in the arteries and the veins is different, and it allows an internal channel that it allows to diffuse better. So Minjil asked me to talk about how to change my approach to ABMs, but it really didn't change anything, but I think it's going to change the results. I'm sure about this. Since 10, 12 years ago, we completely changed the strategy for ABMs treatment. Now we do it in a way that is similar like neurosurgeons do the ABMs. We go from the periphery to the center due to the fact that the vein is located in the center, and we go first for the direct shunts, which are normally usually located in the center of the ABM. We can have a venous occlusion before occluding all the nidus, and this can lead to a bleeding. I think that all of us know that this catastrophic bleeding in the first learning curve of Onyx were mainly related with this. We try to stage patients with ABMs more than 3 centimeters, and we try to leave the larger shunts and the main outflow vein for the last session. And this is another important advance, that if we have a good vein, which is not always the case, but when we have a good artery and a good vein for the last session, we prefer to go transvenous or a combination of transarterial and transvenous, because we have realized that the curation rate in the long-term follow-up is much higher with transvenous injection. Even if you cast the vein from the artery, we will not achieve more than 80% of occlusion, but through the venous approach, as a last session treatment, we can achieve 90-something% of occlusion. This is an example of how we proceed. This is an parietal AVM located, the epicenter is in the MCA, but there are indirect feeders from ACA and PCA as well. So in the past, we would have a start from the MCA and inject and try to get the other indirect feeders from the first injection in the main feeder, but we don't do this anymore. We start, in this case, the vascularization, the ACA, and then the PCA in the first session treatment. And in the second treatment, we focus on the MCA, but we don't go to the main feeder. We try to get first the indirect one, so we do the pressure cooker here, and we diffuse around the AVM, trying to avoid any drop of liquid embolic agent inside the main vein until the last session treatment. So this was before the last session. As you see, we transform a grade 3B AVM into a grade 1, and the last session treatment, we were obsessive at this time with indirect feeder, so we put a magic here in this indirect feeder before we went to we inject some glue, and this was the final result. And now you can treat this AVM very safely, even for the artery or from the vein. At this time, we didn't have experience with transvenous approach, so we took the vein from the artery, and it was very easy to complete occlude this AVM. This is after pressure cooker, and this was the final result. So in this case, everything was good, but sometimes you cannot go more from the artery. This is a right temporal AVM, and this is after 5 sessions. And the way to close this is, of course, from the vein. This was an easy venous approach, and we complete the last piece of the puzzle with the transvenous approach. But there are other cases that we cannot complete treatments, or we can achieve only subtotal treatments because we don't see. We don't see, and this is an example of a case, Rolandic AVM, that we could achieve this result, but we still have some chance. And in this case, we could go from this vein, we could do transvenous and inject a lot, but finally, there is a small remnant. You can see a draining vein here. Of course, this patient has less risk of bleeding. The patient doesn't have seizures anymore, but we have still to follow up him because we don't know what will happen with this remnant. This is another example, right massive temporal AVM. After this treatment, we cannot see, we cannot go on. I sent this patient to surgery because I don't understand the remnant. Even if I did 6D supraselective runs of everything, it was impossible for me to understand. I know that there is one vein, but I cannot see and I cannot treat it. And this was another recent patient that we sent also to surgery, that after many sessions, we had this. Even after a transvenous approach, we had this remnant and we couldn't control the anatomy. And if you cannot control the anatomy, you cannot do it because you can have a bleeding. So what is Obtura? Obtura is a new liquid embolic agent based on EVO dissolved in the MSO. The opacification, as I said before, is achieved by an iodinated compound. It is not needed to shake because you don't have tantalum. And the most important thing, but it's not the only one, is that loses radiopacity with time. We call this third generation liquid embolic agent because it lost radiopacity, but not only because of this, but also because the catheters won't get blocked, the risk of extravasation would be less, and the diffusion is better. These are the different types of viscosities. The most interesting are the medium, the 20, which is like squid 18 or onyx. The low is like squid 12, 15, and there is also a high one and a very low one, which I think will be useful. We don't have experience still with this 12, but I think it will be useful for tumors injection. This is one example of the first clinical trial, first in human trial that we did in Cuba, in La Habana, with Dr. Juan Carlos Gibre. And this is one frontal AVM. This is a pressure cooker. This is the injection of 4 cc's injection. And this is 1 month later. You see that the radiopacity has disappeared. And then this is the second injection. 1 month later, and this is after 5 sessions. You can see that there is not radiopacity there, and since there is not radiopacity, you can understand the remnant. And if you go back to the frontal AVM that I showed before, now we can see the remnant because we can understand the anatomy. And if you do supraselective injection, you will see that there is a draining vein. And of course, since you can see, you can treat and you can cure the patient. And this is the 6-month follow-up after treatment of this small remnant. This is another example of the same series. This is a big AVM fed by PCA and MCA. And after 5 sessions, you can see what we call the cemetery of the tip of detachable catheters. Or you can say that these are like the fish bone after you eat it. This is after 5 sessions, but not material that can hide the rest of the AVM. And you can see here, and once you see the remnant and you can control it, you can embolize and you can cure the patient. And this was the last control. Regarding radiopacity, is between onyx and fill, which means that this intermediate radiopacity, which is good enough to see, maybe not in an old machine like this afternoon case, which was not good, but in the modern machines, the capability of visualization is very good. And one of the advantages of this is that the artifacts and in the CT, Expert CT or Dyna CT are less. You can see this as after an injection, not as much artifacts. And this is the long-term follow-up of a cerebellar AVM 6 months later. You see that it has completely disappeared, and you can analyze what is going surrounding the AVM. These are the results of the trial, which was published in GNIS. And the most important thing is that we could achieve a 93% of occlusion rate in the 26 of the 28 patients that complete the cycle of embolization. And you have to realize that there was 91% of high-grade AVMs, and the mean size was 4 centimeters, which means that it was huge AVMs. So I think that this is important. The major complication is still 4.8%, 2 bleedings that were massive bleedings. 1 patient died. But I think that related with the literature, the results are good. And now we are ongoing a trial in Europe. We recruit 29 AVMs until the moment, and until now, the controls long-term at 6 months, 26 out of 26 patients that have been controlled are cured. And until now, we didn't have any bleeding complication, but now we have still another patients that we have to complete the cycle of embolization. This is an example of a Rolandic AVM. After 3 sessions, look at the anatomy. This is impressive. How can we understand if it was embolized with onyx? Impossible. But after 3 sessions with Obtura, you can see completely clearly the anatomy, the arteries, the vein, and since you can understand, you can treat. In this case, we treated from the vein, and we did a perfect cast because we could control everything, and this is the result. This is another case. This is a giant frontal internal AVM. After 5 sessions, this was previously embolized with a squid. These are remnants of previous squid in another center, but the obtura disappeared. And since it disappeared, now we can understand. And as you can see here, there are 2 veins. One is draining anteriorly, which is draining to the superior sagittal sinus. The other one is draining posteriorly, which is not connected with the sinus, which means that it cannot be navigated. And this is the supraselective injection with a balloon in the ACA, just to see the compartment of the ACA. And you can see that the compartment of the ACA is draining mainly posteriorly, which is good because we can inject very easily with a pressure cooker here. But there are some connections with the anterior vein. So this is the other compartment with the balloon inflated in the ACA to see the remnant related with this hypertrophic network of the MCA, which finally they are reconstructing the ACA, distal ACA, and this is the part of the nidus related with the posterior part of the AVM, which is draining mainly in the anterior vein, which is very easy to catheterize transvenous. So our strategy here was clear because we could understand the anatomy, and what we decided to do is to prepare an arterial pressure cooker and leave the catheters in the vein just in case that vein started to get contaminated with the material, which was what happened because finally they were connected. And since we have everything prepared, what we could do is achieve a complete occlusion. We finally injected from the vein and from the artery, and we finally occlude the AVM. We still have to control this patient at 6 months because it was in June, but this was the final result after embolization. And this is the last case. This is another giant temporoparietal AVM. You can see after 10 sessions, you can see that now the remnant of the AVM is very easy to understand and is not difficult to treat. There are high flow fistulas here, you can see there, but now we can understand these are all overlapping previous sessions, and this is a reconstruction of what we will be if it was onyx, and now we don't have this, and now we can understand. And since we can understand, we will treat this patient next month, and I think that the treatment is going to be very easy because now you see the remnant. There are direct shunts going to the same vein. This is hypertrophic vessels in the previous branch. This image here is related with these hypertrophic vessels in the lateral view, and the remnant of the AVM, which is located here, I think is going to be relatively easy to finish. And a couple of words about diffusion. This was one of our obsessions when we developed this liquid embolic agent, because Fiehler was first hyodenated liquid embolic agent, and the diffusion of Fiehler we didn't like. There was a lot of extravasation. It increased the size of the vessels. This was one of our obsessions, to at least keep the diffusion of onyx or squid with obtura. And finally, I think that the company IHT did a very nice work in this, very nice job, and they could finally achieve the result. These are a microtomography that they took from different liquid embolic. This is Fiehler. You can see that Fiehler expand the vessel because it precipitates in a very chaotic way, like plaster. This is onyx, squid 18, sorry, and this is the way that it precipitates from the center, from the periphery to the center in a lava way. But the problem is tantalum. Tantalum is a problem because, as I said, it can block the catheter, it can make extravasation. And this is the way that obtura precipitates, which means that there is an inner channel that we call the tunnel effect, and it, in our opinion, this is responsible of the better diffusion. And since there is a better diffusion, radiopacity is nice, we are using it in every case. And this is an example of how diffusion is good. This is a mesencephalic AVM, which is fed by SCA from both sides and a quadrigeminal artery. This is a supraselective simultaneous injection of both sides. And what can you see here? You cannot see much. Even if you are injecting supraselective, you can see the vein, the main vein of the AVM. Then this tortuous course, this is a congestive vein, and this is draining in the straight sinus, but you don't see even the nidus. This is injection from the vein. It took us a lot of time to get to the vein because of the loops. We have to put the balloon here to assist the catheterization, but finally we could achieve, you see, these are the arterial control, simultaneous arterial control before injection, to be sure that this is the area that we can feel, and this is the vein. We put some coils in the congestive vein and in the main vein to stop reflux, and this is the injection of obtura. You can see diffusion in these very, very tiny vessels. The problem of diffusion in these tiny vessels is that if tantalum precipitates in one of them, there can be an extravasation, and if there is an extravasation, every drop you inject will go there, and you will be limited your diffusion. So this is important to know. And look, finally we could do all the nidus of the AVM, and this was the final result. So my conclusion is that this is a new liquid embolic agent with excellent diffusion and innovative properties. The loss of radiopacity improves anatomical understanding, which is important in high-grade AVMs. And this allows to achieve a higher rates of complete obliteration, and I think and I believe that the complications related with bleeding will be less, and this would be also good. Of course, we need prospective studies and start to share our experience with other centers. Rene is starting recruitment of part of the European trial soon, and I would be so pleasant that he had the same experience in the next month. Thank you very much.
Thank you, Alberto. Is there any question?
Alberto, excellent presentation. I think that this is going to change the way that we treat AVMs and intratumoral hypervascular tumors. The question is, in all the cases that you have seen, and what is the risk of post-embolization rupture that I don't think is related to the obtura itself, but in general, the cases that you have seen done or the trial Claridad?
What is the cause of the post-embolization?
No, the rate, the percentage, how frequent there is a post-embolization bleeding of the AVM.
The post-embolization bleeding, it was double that the symptomatic. It was 9.6%. There were 4 bleedings in more than 120 injections, because we analyzed the rate of bleeding related with the number of injections. And it was like overall 9.6, but symptomatic 4.8. Half of them were symptomatic. The other were not symptomatic. The trial we did in Cuba has some limitations. One of them is that we didn't use biplane. There was not biplane. It was done in monoplane. And I think that now we have the icono as well. This is another advantage. And analyzing all these different compartments and venous segmentations will also lead to have less hemorrhagic complication. But I think that the rate of hemorrhagic complication is getting lower and lower. Not only related with obtura, of course, but with the strategy. There is a question.
Thank you for a wonderful presentation. I was wondering, does AVM's architecture, compactness influence on the outcome? And if you had any cases which were operated microsurgical after? Thank you.
Yes. Related with the compartments, this is our philosophy stone. We don't know. We don't know, but more and more we understand. And thanks to the supraselective injections, an AVM should be studied from proximal injection, 3D proximal, and then you have to go supraselective to all the feeders. And if you do a 3D injection of all these feeders, and you can start to understand the venous drainage. At the beginning, when the AVM is large, it's very difficult to understand the different primary veins or the venous segmentation. This is another advantage of loss of radiopacity, because you can understand the anatomy of the vein in the final sessions. But at the beginning, you have to have a lot of experience like Rene, but even us, many times we don't understand the veins from the beginning, which more and more we think that this is a very crucial point. And compartments, sometimes you see them very clearly, and sometimes this is important when you start doing venous approach. You start to learn a lot about compartments. And this is not rare that you navigate into the draining vein of an AVM, and sometimes the vein occluded transitorily because of a spasm, or you straighten the vein, and you see another vein draining the AVM that you didn't see at the beginning, and sometimes it happens, and you say, wow, there is a new vein that I didn't see, and then if you go back to the previous angiogram, you find it very tiny filling of this vein. So compartments is, I think this is a philosophical stone. This is very difficult to understand, but I think that more and more we understand, and the more we understand compartments, the more we have success, because the venous approach is not only more effective, but it's only is more safe, because you have less ischemia. This is also an advantage of the venous approach. When you inject from the vein, the likelihood to have arterial ischemia is lower. You can have, of course, but it's lower. And regarding your last question, I have some surgical. We have one case that the neurosurgeons took out after the patient bled. They did a craniotomy, and then when they replaced the cranioplasty, they took out the, and I think I have an image of the surgery after 3 months. Yes, I have it here. We presented this also in 3C, and I prepared, because there were neurosurgeons, and I have this image, which is interesting. This is a comparison about macroscopic piece of onyx. This was an AVM treated with onyx that was resected, and you can see that the AVM and the vessel are expanded, are like in tension under pressure. And this is the case that was operated with obtura 3 months later, and you can see that the AVM is some kind of relaxed. The reasons are not clear, of course. We have to study this more, but maybe this is related because of the fact that the radiopack agent diffuse and goes, but also maybe because of the tunnel effect, that the amount of liquid embolic is not the same. You don't need the same amount of liquid embolic to thrombose an artery with obtura than the one you need with onyx or squid, which this is another interesting point. This is not related with recurrence, because all the results we present are 6 months follow-up, and some of them at 1 year are stable.
Alberto,
yes, Udai.
Very, very impressive. But my question is, in behavior in your hands in the microcatheter, and as you're embolizing, is there any difference from, because we have had to learn how onyx behaves and then how squid behaves, and for a short time we had how fill behaves.
Yes.
And now, is it different or it's same?
Yes, this is, for me, this is one of the most important points. I mean, this is that the behavior is similar to onyx or squid, but you have to take into account several tricks. And if you don't take these tricks into account, you can start to say that this is not working, this reflux a lot, and I think that this should be so controlled. I always talk to Mario, which is here, which is the CEO of the IHT company, that we have to control the first experience in high volume centers with skill operators, and we have to go there with them to share the first injections, because there are things that change. First of all, you need more time for the reflux. If you don't use the pressure cooker, you can use the push and plug technique, but you need more time. You need more time for solidify the reflux and lead the liquid embolic agent to precipitate and to do the plug. But it does it. It works. Second, if you use the 1.2 microcatheters, if you use the Sonic 1.2 or the Apollo, you won't feel any different. But if you use the 1.2, at the beginning we started to feel like more resistance. And we started to say, hey, this is not working, what happened? Finally, we forget about it because we are down to it, and it works like the other one. But at the beginning, if you use the 1.2, you can feel more resistance in the syringe, which I don't understand. We talked with Mario a lot about this. I don't have an explanation. It's not that the catheter is blocked or this is a hyper viscosity agent, but this is something peculiar you have to take into account. But you have to go on injecting. And what else? The reflux in the vein, it should be done with more space between the coils and the glue, because sometimes when you inject the glue from the vein, when you're doing the retrograde pressure cooker, it can go beyond the obtura. But if you wait a little bit and take the second catheter a little bit more proximal, I think this problem won't happen. But these are small details that I think that at the beginning only experienced operator can handle. Okay. Minjil.
Why you are waiting for the comments? Let's go for the dinner.
Okay.
Okay. One more comment? Okay. Just before the comment, now it's 7. 2 questions. Okay. 60 cases. Okay.
Just to explain, Microangio Architectonics is not presenting because it's online, and Rahul is in the procedure now. So maybe Rene could present the cases, AVM that were planned for noon today.
Do you have the adapter?
this one, there was another one. So I'm going to show you 3 cases to try to convince you why the understanding of the AVM is the key of all what we do. And up to now, it's strongly related with one manufacturer. So today, I don't think that the other manufacturers are able to reproduce the same kind of imaging that we get. And without this imaging, it's extremely difficult. So we start with this patient here, which is, first of all, 6D. So what we call 6D is a fusion of 2 3Ds. So whenever you do a rotational angiogram, you create a volume. The volume you give a given color. So you can choose orange, white, or whatever, or translucid. Usually when you do another 3D, we replace the second one by the first one. In AVMs, we can intentionally make 2 3Ds of 2 different arteries, give a different color, and fuse. And this enables to understand a lot. This enables to understand what is inside. So let's look at this patient here. He's 25 years old. It's an AVM of the supplementary motor cortex. And it's still a human size. I mean, you can understand it more. That's why we're going to stick on it. So first of all, we see where is the location. Which territory is it? It's in the ACA territory, which means here you can know the direct feeders are from the ACA, the indirect feeders come from the MCA. You can embolize from here, you can also embolize from there. It's simple. We should all agree. If we look indeed from a microcatheter from the MCA, what do we see? It's terrible. We will not access. What is this artery here? Is it MCA or is it ACA? It's ACA. It's a distal ACA that is filled retrogradely. Question, how to get there? Either we take this way, super difficult, or we go through the AVM. Of course, we don't go through the AVM. We stay in the artery and we avoid the shunts. How to see it? Here, this is a 6D where, what is which color? Blue is the ACA, orange is the MCA. So this artery is this one here is blue, okay? So I follow this. It's a sagittal view. I follow this artery, I follow it, and this blue becomes orange. You see where the connection is. It's not always so easy. So you have 3 planes where you reconstruct. There's one where you can see it. The 2 others you don't. So this takes 15 minutes, 20 minutes. You scroll, but at some point you see it. And it's always there. Always. When you know where it is, you know which direction it is. You know which artery to access to. So again, this is the one we want to get to. Here's a microcatheter, and here, oh, it's super easy because it goes there. No, it's not easy. The magic is attracted by the shunts. It never goes here. But when you know where to go, when you give the direction to the wire, you can go there. And this is the reason why we fail to cure AVMs by the arteries, because we can treat the easy ones and we cannot treat the difficult ones. Here, we access the inaccessible. So first reason, and here's a 6D. Sometimes you don't see it, but sometimes it really helps. So that's the first part of the treatment. Now the AVM is reduced. 3 months later, you see there's much less coming from here. But it's still not finished. You have too many arteries. So let's look here at the 6Ds. Blue is MCA, orange is ACA. Here is coroview, here is axial. Now we go to sagittal. We said blue is MCA. Blue is MCA, orange is ACA. Look at the main vein. Look at the part coming here from the MCA, the one you cannot access. We follow this. We follow it. We follow, we follow, we follow. And what do we see? We see the vein here. The blue vein arriving in the main one. We all agree that this is the main vein of the AVM, that this is orange, supplied by the ACA, but this here is obviously blue, is obviously here draining the part which is not accessible by the arteries. So now, once we've seen this, we decide we must find a way to go to this vein. Where is this vein? Search for it. Take a microcatheter, go in each artery up to some point where we see this here. And this here is this. Of course, you look also on the AP, not only on the lateral, but at some point you can be sure. If you don't know, make another 3D, selective through the microcatheter. And then you will see that the vein that is appearing here is the same as this one. So you can confirm to be sure by 100%. Once you know it, then you must find a way to go to this one here. So this is tricky. You must find a way to go there, put one catheter, a second one, and then you plug the vein, a retrograde pressure cooker, you occlude it here, and you get all that bunch. This is where we are in place. This is a retrograde injection. Before, after. Before, after. This is a transvenous embolization of what? Of the blue part. The blue part is what is coming from the MCA. Before, you see a lot of anastomosis. After, nada. It's all gone. And you stop. You wait a few months, and now everything that remains comes from the ACA with 1, 2, 3 arteries. This one here goes through a lot of anastomosis. So you don't want to embolize here because we would kill all this brain. Much more ischemia by the arteries than by the vein. So we look at the vein here, this vein. And this vein is made out of this one and this one. So we can scroll. You see the one I just showed? This one here, this vein here, this primary vein arriving in the main one is this one here. And then you continue to follow. And then you arrive, you follow this one, this one, this one, and you arrive in this main one. So we're going to put a catheter in the one we just saw and in the main one. So now there is one microcatheter in this vein, one microcatheter in the other one, this here, one here, one there. The plug is being made here with a third catheter. We embolize the whole AVM transvenously. And he's cured. But the point here is to understand, and understanding is given by this vision of the AVM. Example number 2, 6 centimeter cerebellum AVM, growing venous aneurysm, some ataxia. You see this thing here, large lesion. So you go first transarterial, second transarterial, third, fourth, fifth, and this is now what is remaining. It's okay. Not too difficult. Where are the veins here? One is getting up there. This one is this one here. And then something is getting out through the superior petrosal sinus, probably here. Is there another vein? So maybe with obtura we see it better. Not maybe, we're sure. So I don't have the chance to use it up to now. But here we want to ask 6D, how are the veins? So this is a sagittal view. Here is a sigmoid, transverse sinus. This is a superior petrosal sinus. We follow the superior petrosal sinus, and indeed, we see a vein arriving here. This is our vein. But we continue, and we see a blue vein. Orange is the ECA. This is the drainage here of the meningeal compartment. But there's not only an orange vein, there's a blue vein. I mean, you see 2 veins in 2 different colors. It's obvious. It's impossible not to understand. And if you don't understand it on the sagittal, you can go on the coronal views. Here's the coronal view, the sigmoid. Here is the superior petrosal. And when you follow, you see that one is here and one is there. If we wouldn't have had this, we would have gone to the superior petrosal, we would have gone there, would have plugged, and maybe we would have occluded too distally the second vein. It's super important to see it. If we don't see it, we do a transvenous, it bleeds, and we say transvenous is dangerous, we should not do it. If we understand, we choose one vein. Here I choose the blue one, because the blue one was connected to the other deep one, which is difficult to navigate. So you see here, this connection? So I first went there, coiled this, went then down there. Let's see it. We're on the way. Okay, did I give the details? This is the drainage of the ECA. Oh no, sorry, I did not give the details, but here we occluded the blue vein. Now there's nothing which is left from the intracranial circulation, but we have what remains from the meningeal, which is going to be the last step, where we expect to have high chances to cure. Example number 3 in the last one, because the dinner is waiting. He bled once, he's 23-year-old, and again a large posterior fossa AVM with a large vein here. So interestingly, you see here, this is right vert, left vert. It seems to be more or less the same thing. This is the error we all did. If you look here at the colors, you see that the blue stuff and the orange stuff are completely different. These are just two compartments superimposing. This AVM is indeed very large, is not small. But we completely underestimate because we say, oh, it's the same level, it's the same thing. No. Now we realize how large it is because of both things. And then we do a first transarterial, and then we do a second transarterial, which reduces indeed a lot after both treatments here where we are. And then for the third treatment, we decide to take the vein to go to the AVM. And this is here the vein of drainage. So we should be able to go there and to plug here. But we look also to the ECA, and here we see another vein. And the vein that arrives here is there. And if you compare this to this, you realize that both veins join somewhere here. So if you go on by the vein, you must go far away here, plug there, and make sure that you don't occlude this, because this will require another access, which is what we did. So we went there, occluded that first part. Once this was done, the whole intracranial stuff was finished, but this was still present. So we had to take the other vein to finish the AVM and to get this guy cured. And I stop it here because otherwise it will last too long. But again, all this today is possible with Siemens Icono, and you need to have the ability for the machine to go exactly in the same position, which means that the whole mechanics must be super precise. And the mechanics of the other angio systems are 20 or 30 years old. So they did not put the whole intelligence in the system to be able to reposition at the same level, together with the ability to fuse. So there are different things, but when I see the fusion attempts on other systems, I'm a bit disappointed. You cannot really do it. So it's really important, and if you want to understand and to take vein by vein, this is to be done. Thank you.
Thank you, Rene.
And I'm not paid by Siemens, by the way, to say this.
Okay, thank you. Thank you all. And short information about this day. The all offline participants on the surgical forum in 6 rooms, 997, nearly 1,000 participants came today to this forum. And I just count on YouTube the show, the lookers for the YouTube channel, and it was more than 2,000 views of the channel. And altogether, it's more than 3,000 participants today, online and offline, in hybrid format. I hope everything's okay, and now we can go to the dinner and we can discuss 9D. Yes, there is a 9D. Okay, thank you. Let's go. The horse meat is now ready.